Good morning, everyone. Thank you for coming early. Welcome to our second day of the ESOT annual conference. I'm going to introduce our next speaker this morning. It's going to be Dr. Scott Nelson. He's an accomplished pediatric limb reconstruction surgeon who trained in Loma Linda University School of Medicine for his medical education and orthopedics residency. He then did a pediatric orthopedic fellowship at University of California, San Diego, and another fellowship at the International Center for Limb Lengthening in Baltimore with Drs. Herzenberg and Dr. Pelly. With inspiration from his grandfather, who served as a surgeon in Africa for many years, he also did significant portion of his career to humanitarian services. Since 2005, he spent 5 years in Dominican Republic with the Cure International Hospital, and also he did 6 years in Haiti, after Haiti was hit by the earthquake. He was internationally recognized with many awards, one of which was the American Academy of Orthopedic Surgeons Humanitarian Award of the Year was given to him in 2014. He's the founder and director of Limb Lengthening and Reconstruction Center at Loma Linda University. He moved back to California, Loma Linda University, currently working there after serving 6 years in Haiti. He has over 50 publications. He's given over 100 global lectures and also authored book chapters. It was great to see one of them in the limb recon part. Let me just tell you a story. We had a limb recon course just this week as a pre-AGM course, and one of the participants was someone asked, the participant asked a question, and the question was reflected back to the audience. So the participants were trying to answer. And one of them was talking about the rule of 57 and he was trying to say, you know, how much do we cut? How do we know how much to cut when you have this much, you know, a degree of angulation and so on? And he was talking about the rule of 57. And interestingly, he didn't know that the author of that paper was just sitting next to him. So it was very good to see that. I'm very happy to invite Dr. Scott Nelson to the podium to speak about ring fixation for deformity and trauma. Thank you.
Thank you, Teddy. Okay. Thank you, Teddy, for that nice introduction. It is a real privilege to be here with all of you at the Ethiopian Society of Orthopedics and Traumatology. I've been having a wonderful time in Addis Ababa working with the colleagues at CURE, working with Tim Nunn, and we had a very fulfilling and educational limb reconstruction conference for the last 3 days. And I myself always learn new things at these conferences as well. And so it's just such a privilege for me to be here with you. I'd like to thank Dr. Ephraim as well for this wonderful invitation. And I'm not sure how we start the presentation. Okay. Great. I was asked to talk a bit about ring fixation for deformity and trauma this morning, and this story does not really go back too many years in our history, but I find this story to be fascinating. Many of you have heard it before. Each time we see and hear new details of this story, I think it's an inspiration for all of us. And the story starts, of course, with Gavril Elizarov. The pointer is not working here. Okay, maybe it's working now. Elizarov was born to a poor Jewish family in Eastern Europe. He didn't even have the opportunity to go to school until he was 11 years old. And it was only 7 years after that that he started medical school. Shortly after that, Germany invaded Russia, and they were pushed off to a remote part of Kazakhstan, where resources, hunger, and fatigue were the norm. Lack of resources. He worked at a railway station at night unloading trains to earn enough money to stay in medical school and have a little bit of food to eat. He ended up graduating in 1944, and then he was posted as a family physician in Kurgan, Siberia, where he worked as an internist, OB, pediatrician, and general surgeon. Elizarov, I believe, had a natural gift for surgery. He had no formal orthopedic training, but he was faced with the challenge of treating many wartime orthopedic injuries. And focusing on the surgical aspects of his career, he accepted a position with the general surgery department in the city of Kurgan and pursued his treatment of these traumatic injuries. And these are three of the key elements that he brought into our profession that continue to be in use today. Elizarov, in searching for ways to treat these injuries, was developing a system to provide stable fixation. And he asked a local metal worker to fashion a device with rings and wires, thinking that small wires would be minimally invasive, minimal interruption of anatomy, but yet by tensioning them across a ring and providing that transosseous fixation, we could have the rigidity needed to treat orthopedic injuries ideally. He experimented on some broomsticks, and he actually ended up patenting his device in 1954. And his first patient was a worker from the same metal factory where his device was developed. The results were amazing, and he continued to treat many other patients during that time. But this was a very remote part of Russia. It was closed to the rest of the world, and it actually is probably a wonderful benefit for the early development of his techniques that it was close to the rest of the world, because all of us didn't jump in and start performing. Yeah. Oh, okay. Thank you. Start performing these procedures before he had been able to work out the pearls and pitfalls of these techniques. And so the treatment of the Elizarov treatment actually evolved significantly before the rest of the world found out about it. Elizarov promoted a low energy osteotomy. It's said that he spent 20 or 30 minutes doing just this part of the procedure. He used small osteotomes. He didn't use a drill or a saw. He did it through a small incision. And it's rumored that he believed in the necessity to maintain the cancellous bone in the metaphysis in order to promote this osteogenesis. But some others have said that basically he didn't necessarily believe that, but he did, we know, believe in the preservation of vascular supply and the periosteum surrounding these osteotomies, which has been shown to be an ongoing necessity to provide distraction osteogenesis reliably. And this can be done through a very small incision. We don't need to open, look at the periosteum, and disrupt nature. In the late 1950s, distraction osteogenesis was rediscovered by serendipity. Elizarov had a patient he was treating for a hypertrophic non-union, and he left for a short period of time and left the patient in the responsibility of the nurse at his hospital, who was supposed to be compressing the bolts of the fixator. And instead, there was some confusion and the fixator got distracted. Interestingly, Elizarov was not the first person to describe distraction osteogenesis. It was described in 1905 by Kotvila, and Elizarov rediscovered it at this time when he noticed that there was new bone formation in the gap where this hypertrophic non-union had been distracted. This would have maybe been easy to not realize. Maybe it would have been more the focus to scold the nurse and compress, and this whole discovery would have gone unnoticed. But Elizarov is the one that we attribute for the practical application of distraction osteogenesis and his tension stress theory, which has evolved and allowed us to do miraculous surgeries for the patients that we take care of. I want to pause for just a moment and remind us all of the meaning of the word serendipity. Serendipity is not just luck. This is different than luck. We could say that Elizarov was just lucky to have discovered distraction osteogenesis, but it's actually an ability to notice something that is, it's the ability to find something unexpectedly. But you have to have a ability, you have to put forth effort, and you have to be looking for something else. And I think for all of us, when we push ourselves to the limit, when we push ourselves to do our very best, when we have an inquisitive mind, when we ask questions, when we look for something, we might not always find what we're looking for, but serendipity will allow us to find something. The antibiotics were discovered in the same fashion when Alexander Fleming noticed that the penicillin cultures were producing something that has revolutionized medicine. Elizarov's work was largely discarded. It was largely unknown to the rest of the world. The surgeons in Moscow had jealousy. They sent one of their colleagues to the Elizarov Center to find out what was going on and ultimately discredit Elizarov for the miraculous and amazing claims that he had. There was a celebrity athlete who had gotten a gold medal in the Tokyo Olympics in 1964, and shortly thereafter suffered an open tibia fracture in a motorcycle accident. He underwent 20 different operations. He had a 3.5 centimeter bone deficit with shortening. And the surgeon, Brummel and his girlfriend were in visiting a doctor in Moscow to discuss the 21st operation and what they might do to heal this injury. And the doctor that had been out and observed Elizarov anonymously told the girlfriend of Brummel to go look up Elizarov and get treated in Kurgan. And they immediately called Elizarov. He assured them that he could fix this injury. Brummel went to Kurgan, and after one operation, his leg was lengthened, it was healed, and that same year he was able to begin training again as an Olympic athlete. And it was the media exposure of this event, the overwhelming odds against which Elizarov succeeded, and all of those previous failures that really captivated the attention of the general public and also the medical community in Russia. Elizarov continued his work, and he wasn't one to just experiment and trial and error. He did research. He researched with dogs, and he continued to develop many of the specific techniques as far as rate and rhythm, which we still use today. There was another event that brought his work to the rest of the world. It got it out of Russia. A man named Carlo Mauri from Italy was on a trip across the Atlantic in a papyrus boat. They were trying to replicate the immigration patterns of ancient people and understand how the Americas became populated. And they made a homemade papyrus boat. They left the shores of Morocco, and 57 days later arrived in Barbados. Incidentally, it was during this same journey that I was born in 1970. And Carlos Mauri was an Italian explorer that was on this journey along with a Russian physician. And Carlos had a tibia fracture non-union that from time to time gave him problems. It opened up, started draining, and this Russian physician oriented him to Elizarov and the work that he was doing in Russia. Carlo Mauri eventually ended up going to Russia, having an operation by Elizarov, which was successful. Here's a famous picture after being treated by Elizarov, enjoying a little break in the operating room after his operation. And Carlos Mauri went back to Italy and wrote an article in the newspaper about the treatment that he had gotten by Elizarov in Russia. And he called him the Michelangelo of orthopedics. The Italian surgeons became interested in this work. They went to Kurgan and they discovered what was going on. Subsequently, they invited Elizarov to come to Italy, and this was really the event that opened the floodgates of Elizarov's successes to the rest of the world. This is Dr. Stuart Green on the left and Dr. Dror Paley on the right, both of whom have been significant mentors to me, especially Dr. Paley, and they are responsible for bringing the Elizarov techniques to North America and largely for helping to promote and expand this knowledge to the rest of the orthopedic community around the world. Dr. Paley's amazing book of the principles of deformity correction is really an encyclopedia. Stuart Green is in Southern California and one of the early Elizarov adopters in North America, who is very well known as well. And the mentorship from these people has really opened up a whole new world of possibilities for treating patients with difficult problems. These are techniques and ideas that I never learned in my own residency training. It was in the 1990s that Dr. Charlie Taylor applied the concept of six-axis deformity correction and the projective geometry to the Elizarov fixation device. and developed the talar spatial frame with his brother that was a mathematician. The brother put together the computer program which was adapted to the 6 struts. And this is really like a second generation Elizarov that has expanded so much and made easier the application of the Elizarov principles for treating limb deformities that we have today. And it's based on the fact that we have an X, Y, and Z axis, and there's 3 translations and 3 rotations on each of these axes. And that loosely translates into why we have 6 struts on the talar spatial frame. This is a computer-assisted external fixator, and we can program in there a point where we have a hinge that we rotate around. We can provide lengthening, shortening, axial translation, rotation, and varus valgus correction by simply programming how that fixator is mounted onto the limb, where we want those deformity corrections to occur, and how quickly we want them to occur. I've had the opportunity to use this technology in a number of places in the world, and it's amazing that this is technology that can actually be easily used in fairly limited resource environments, places that have difficulty with supply chain. The devices in general are easily reusable, and they respect soft tissue. We don't need large incisions. We don't have large blood loss in these types of surgery, and by applying our training and our learning of these techniques, we can take them to places where people need them most and perform life-changing operations for patients that oftentimes have very little hope and very few options for finding the treatment that they need. I've been working for the last 6 or 7 years in a resource-limited environment in the city of Port-au-Prince, Haiti, where I've been running a hospital, and it's been a real privilege to take these techniques there, to train local doctors there, and multiply my efforts in treating these patients. And I think training and expanding this knowledge is one of the most satisfying things that we can do when we see our residents and students take these techniques and multiply our efforts. This is our hospital in Port-au-Prince, where we treat a number of traumatic injuries. This is an open distal tibia fracture here, obviously, at risk of amputation. Thinking that when you have an injury like this, we need to have a good plastic surgery service. At our hospital there, we don't have plastic surgery, and we really have to rely on orthopedic techniques to take care of this. But fortunately, what Elizarov brought to us has helped us as orthopedic surgeons to be able to take care of injuries like this. We debrided the devascularized bone. We applied a stable ringed external fixator, and did a proximal corticotomy bone transport after a latency phase of 0 to 10 days, which is standard for this, and distracting 1 millimeter per day, and then allowing the consolidation phase to take place. We lengthen approximately 8 centimeters, close down that gap, and here our patient is at the end of treatment without any need for plastic surgery, any need for fancy flaps, any need for vascularized fibula. I know there's some people in this room that have experience with vascularized fibula transfer. That's amazing, but this is low tech here, and even something that mediocre surgeons can be capable of doing. Distraction osteogenesis is an amazing phenomena, and it's known from Elizarov's work and been proven throughout the following decades that the appropriate rate of lengthening is around 1 millimeter per day. Sometimes we go a little bit slower than that in our tibial lengthenings, but this depends on several different zones. I'm not going to go into the details of the histology of this, but we have a small gap there in the middle called the fibrous inner zone, and that's known to need to be about 4 to 8 millimeters. And if you go too slow, you can have premature consolidation. Too fast, you can have a separation of this biologic process that can cause a non-union. And it's important for us to remember that the bone needs about 40% of its radio density to be visible on X-ray. And in other words, there's a lot of times that we're looking at an X-ray and we don't really see the mineralization of the bone, but it might just be 20 or 30% because we can't really see it until it gets to be about 40% mineralized. So in the first few weeks after starting a lengthening, we never see that new bone forming. I'm going to talk a little bit about a few of the details, some of the research that has been discovered since the time of Elizarov, oftentimes confirming the ideas that Elizarov taught us. And this was a study done back in the 1990s with metaphyseal and diaphyseal osteotomies in dogs. And they studied the effect of latency period. They studied the effect of location of osteotomy. And what was found is that the metaphyseal osteotomy is optimal. Bone formation seems to be a little bit better when we can cut the bone or do our corticotomy in the metaphysis. And the latency period may not be necessary. They had no non-unions in the 32 dogs that had a 0-day latency. And the premature consolidation was found only in some of the cases where there was a latency period, surprisingly. So we maybe do our latency period more out of a sense of tradition than actual need. And this is something that we should continue to ask ourselves whether or not that latency period is really necessary. My conclusions of this study, there's some other studies that show equivalent bone formation even in the diaphysis, but I think for sure we have to remember that the strength of a bone or any cylindrical structure varies by the fourth power of the radius. So you can see that in a metaphyseal bone where you may have a area that is 6 centimeters in diameter versus 4 centimeters in diameter, the bone is going to have 5 times the strength. And also it's easier to avoid thermal necrosis when you're cutting through metaphyseal bone than in the diaphysis. And so for those reasons, I think when possible, it's preferable to perform metaphyseal osteotomies. Elizarov promoted the rate and rhythm, and he actually said that more increments were preferable. That's been contested over the years. Some people, Elizarov said up to 60 a day would be ideal, but in practicality, it's difficult for patients to do more increments than about 4 times a day. And so that's become the standard over the past few decades. There was some studies done on motorized lengthenings with more incremental lengthenings per day. And this study in 2014, published by Herzenberg and colleagues, showed that using just an Elizarov fixator with motorized lengthening, that even 1,440 incremental lengthenings per day really made no difference. The 4 increments per day were equivalent. Now there's been some motorized struts. The auto strut from Synthes is able to be applied to the talar spatial frame, or the hexapod frame, I should call it. And they can do up to 20 increments per day. But again, the increased number of incremental lengthenings hasn't really been clearly shown to be beneficial. Although this does take out some of the patient responsibility for moving their fixators, but it's extremely expensive, and we don't even use it at our hospital because of the additional expense. There's been a number of enhancement strategies to try to accelerate the biologic process of distraction osteogenesis, and these include ultrasound, putting on electromagnetic fields, local injection of bone morphogenic protein, stem cells, mechanical stimulation of compressing and distracting fixators, and also giving supplementation. And none of these have clearly been shown to significantly decrease the external fixator index. Typically thinking about 1 millimeter of lengthening during the distraction phase per day, and then a consolidation phase that doubles the typical distraction phase, equals 1 month for every centimeter of lengthening that we get in bone. And there are some surgical techniques that I'm going to share with you that can significantly shorten the period of time that we need in the external fixator, but they don't necessarily accelerate biology. We know that the regenerate is optimized by minimizing shear, by maximizing bending and torsional stiffness, and allowing for compression and distraction strain. Not too much strain, not too little. And this is the principles, these are the principles that Elizarov originally taught us and have really been proven over the decades to be key for providing the ideal amount of regenerate, the optimal amount of regenerate. We do know that monolateral fixation can be used, and the principles of Elizarov still need to be respected as much as possible, but we can use half pins in certain anatomical areas like the femur and the humerus, and this has allowed us a much easier way to provide distraction osteogenesis in certain anatomic locations. The original Elizarov apparatus was designed to have 2 crossed wires with the bone in the middle of the ring. It's been shown subsequently that the bone doesn't necessarily need to be right in the middle of the ring, but having a significant angle between the crossed wires is important, but obviously that has to be done within the constraints of anatomy. These should be tensioned in a closed ring at 130 kilograms, and for the 1.8 millimeter wires. And this gives us the ideal amount of compression, distraction, strain while minimizing shear forces. And subsequent to this, it's been studied whether or not we can still provide the same type of stability using spatial frame or hexapod equipment, using half pins, adapting this for modified devices in different anatomical locations. And this particular study in 2005 compared the stability of the typical Elizarov block ring concept, which provided 2 rings on each segment with crossed wires on each of those 2 rings, and compared the relative stability of 1 single ring fixation with drop wires and or half pins. And it showed that the Elizarov block ring, double ring concept with 2 wires on each ring was still the most stable, but that there are some configurations that nearly approximated this. And it didn't say the size of their Chance pins that they used. Today we use 6 millimeter Chance pins when possible, and I think that we're coming very close, if not equivalent, to the Elizarov block ring stability when we use the constructs that we do now. Another study compared 5 different constructs, substituting Elizarov transosseous wires for 5 millimeter half pins in different configurations, and basically said that a 5 millimeter half pin is more or less equivalent to an Elizarov wire for as far as stability and shear forces go. But the Elizarov device does still have the most pure linear compression and distraction. When we go to using monolateral frames with Chance pins, when there's compression forces, there's a little bit of bending that occurs at the same time. If we can keep that bending under a certain amount, then we can still have success in distraction osteogenesis. We always need to respect the concepts of stable fixation when we're applying ring fixators or monolateral. Also focus on most of these same fixation concepts. That's having a good fracture reduction if there is a fracture, maximizing the pin separation, making one pin close to the fracture, one pin as far away from the fracture to give a good stable construct, using 6 millimeter half pins when possible. They should not exceed 1/3 the bone diameter. And even in smaller bone diameters, we have half pins that have a 6 millimeter shank with smaller threaded portion to accommodate for that, because again, the same concept, these pins in strength vary to the 4th power of the radius. So a 6 millimeter pin here has twice the strength of a 5 millimeter pin. 6 millimeter pin is 5 times stronger than a 4 millimeter pin. We can also increase the number of pins. We can provide multiplanar fixation, and having a robust fixation device, whether that's monolateral or a bar is also important. Other surgical techniques that can help to reduce the time in the fixator are lengthening and then nailing. That's applying a Lizaroff type fixator, especially applicable to the tibia with pin sites out of the way of a planned nail, lengthening and then placing the nail, which incites a regenerative process in the new bone formation there and allows us to remove the fixator as soon as we have the lengthening out to length. The lengthening over nail techniques, especially applicable for femur, prophylactic nailing after external fixation, and other plating strategies can also allow us to remove the fixators faster than we otherwise would be able to do. Hydroxyapatite coated pins have given us a major advantage in terms of pin loosening. There's been 4 well-performed studies that were examined in this meta-analysis in 2010 showing that the extraction torque was up to 195 times greater with HA-coated pins, and that universally there was decreased pin loosening when using HA-coated pins. They weren't really able to show a difference in demonstrating a decrease in pin tract infections or in outcomes. Perhaps some loose pins don't really cause a difference in clinical outcome, but definitely less pin tract loosening and hopefully less return trips to the operating room because of that. We treated a variety of issues with this type of fixation. Stiff club feet particularly are a difficult challenge for us in the older patients, and hopefully the Ponseti technique in the young children that is being practiced around the world will decrease our need for this. Oftentimes we do an acute correction of club foot and leave some residual deformity and correct that with remaining deformity with a hexapod external fixator. Or sometimes we treat club foot with no open surgery at all, doing just a stretching operation to completely stretch. There's some different configurations that we can use in these fixators. This girl didn't have any incisions, just purely hexapod external fixation, one foot, then the other foot, and here you see a 7-year follow-up. Managing soft tissue loss and traumatic injuries can be done with deformation, shortening, and then restoration of limb length. This is a patient that was injured in Haiti earthquake. This was the second Haiti earthquake that you might not have heard about. It was in 2021. We had a lot of patients coming to our hospital, open fractures, and we did some shortening, deformation, allowed the soft tissue to heal. He lived in a tent in front of our hospital for about 6 weeks, and then went back and straightened the bone, compressed the fracture site, and did a little bit of lengthening above with and avoided the need for a flap or any specialized plastic surgery operations. This is a patient that had suffered from a bone loss, and a monolateral external fixator was applied about 9 months before he came to me. He had spent all his resources on various operations and doctor's visits, and obviously didn't have a lot of hope that this was going to provide a functional limb. And we converted that to a hexapod external fixator. He had an ankle equinus contracture in addition to a bone deficit and need for lengthening. So this is a triple stack hexapod external fixator that allowed us to transport the bone, fix the equinus contracture, and provide consolidation at that non-union site. In order to minimize infections and pin tract problems, we always use a drill sleeve to protect soft tissue. We use sharp drill bits, prevent thermal necrosis. It's ideal to release your tourniquet during drilling, avoid skin tension around the pins, and the HA-coated pins have helped us with that. Post-operatively, we allow our patients to take showers. We don't do a lot of elaborate rituals for pin care. We just have them wash with soap and water and use some hydrogen peroxide if one pin needs a little extra help. Life doesn't have to stop when you have a fixator on your leg, and we even encourage them in places that is possible to go to the beach. Salt water is particularly therapeutic for these devices, and some of our patients that have the cleanest fixators are ones that go in water pools and the beach. And we encourage them, as Lizaroff did, to be active. This didn't happen the first day after surgery. Actually, this is if you know that your patient can can do this with a smile on his face, then it's probably almost time to take your external fixator off. This is a patient that came to us with a tibial plateau fracture that hadn't been properly treated about 8 months prior, and had varus and pain in the knee. We do a knee arthroscopy. We evaluate the affected plateau and the opposite side to see what the status of the good side of the knee is and what the status of the injured side. And he had a relatively pristine medial compartment. We did some open reduction, internal fixation of the intra-articular segment to try to bring it back together as good as possible, but obviously there was some unreconstructible damage to his lateral compartment. And so using the hexapod, we're able to fine-tune exactly where we want the mechanical axis and customize it for the patient based on the findings that we were able to detect arthroscopically inside the knee. And so in this case, we want a mechanical axis to go through the medial compartment, leaving him in just a little bit of varus. The osteotomy healed after the external fixator, and this is the type of result that we're able to provide for him. This is a patient that I've been treating recently in California. He said that he fell down. He's a gardener, and he fell down 6 months ago and is limping here with his knee. And we got this x-ray of him, and this is what we found. And I said, well, you just fell down. What happened? He said, well, I had an injury 6 years ago in El Salvador, and they did an operation on my knee. And then recently I fell down. It's a little bit difficult for me to continue my job as a gardener. And this here is a challenging situation that could be fraught with a lot of complications, but we decided to take a fairly simple approach and apply a hexapod external fixator without opening up anything, without having to look at neurovascular structures, and perform some distraction and translation. And this was the day before I left to come on this trip. We also set up an Alizarov hinge right at the hinge point of rotation of the knee. So once this gets completely reduced, we'll apply some Alizarov rods and start range of motion while holding the knee in a reduced position. This girl is from the Dominican Republic. This is Maria. She's a 16-year-old girl. Just wants to be able to go to school and function like the rest of her friends. And she has Blount's disease. And this is a case that's extremely difficult to apply ring fixation on because her tibia deformity is over 100 degrees of angulation. And so we've developed a technique for taking care of these severe Blount's cases by doing an acute correction with ring fixation. If you notice here, her femur is actually in valgus, which makes the tibial deformity even greater than what it appears to be when we see her trying to walk. And if we put a ring fixator aligned with the proximal tibia here, it's absolutely impossible. And so we plan this out ahead of time and basically make an osteotomy and implant the shaft of the tibia onto the lateral cortex of that proximal tibial fragment. And then she also needed a femoral osteotomy to correct rotation and some valgus deformity there. We did one side, and then a short period of time later, we corrected the other side. And she sent me this video after her treatment, and I think the color of her pants might indicate her satisfaction with the procedure. Quickly, we're going to go over 6 things not to do. I think 3 of these comes from one surgeon, and one of them comes from my own case, and a couple others come from another case. So don't operate for the wrong indications and don't do the wrong operation for your patient. This patient presented to us recently in California. She had gone to Mexico to have a cosmetic limb lengthening. She wanted to be taller. She's 43 years old, and she found a place in Mexico to have it done cheaper than what it can be done in the United States. And the surgeon chose to operate on the tibias, which would probably be a second choice to the femur. He made some relatively large incisions over the midshaft of her tibia and placed a monolateral fixator through the anterior compartment muscles from lateral to medial in the midshaft of the tibia, and obviously used a saw for this osteotomy in the diaphysis of the bone, and violated, I think, every Elizarov principle that exists. And then the fixator got infected, and it was taken off in Mexico, and he sent her to the United States to find some help for her situation. We don't want to forget to bone graft docking sites. This is a learning lesson of my own. This patient presented 9 months after this tibia fracture with shortening, and I was so excited to apply a hexapod fixator, distract it, translate it, compress it. We had a beautiful result here. Left the fixator on for 3 months, let him walk. But 3 months after the fixator was taken off, he presented with a fracture at the docking site. And I think it just reminds us that when we have docking sites, we need to bone graft. There's probably some that could survive without that, but we just don't have any way of telling which ones they are. So he ended up getting a signed nail, and luckily didn't end up with any shortening or long-term complications. We want to avoid unstable fixation. Here's a fixator with just 2 points of fixation in each segment. It doesn't have any circular or multiplanar fixation, and as well, there's a malalignment here that should also be avoided in treatment of these types of injuries. So this was a case that was sent to us that we provided a revision for. And just to wrap it all up here, this is a quote from Elizarov, that he said that boldness should not exceed one's skills. And there's a graph here called the Dunning-Kruger effect, where early in our career, we may be ignorant, we may be overly bold, we may have an elevated level of confidence. And I think I can say personally, I've probably followed this curve somewhat equivalent to what we see plotted out here. And as we have complications and get experience, we become more cultured. And now later on in our careers, we start to develop experience and are able to have the confidence to take on more difficult problems. So I wish all of you on your journey that you have serendipity, that you ask questions, that you always strive to treat patients with your very best efforts, because the work that we all have to do here is something that changes lives of kids like this, of kids around this country and other countries who need our help so much.
Thank you very much, Dr. Scott. This was a very good talk. His experience, his expertise have been great. The Ethiopian children and the orthopedic community here have benefited from your skills. We thank you for your service. He's been doing a lot of scoliosis surgeries in our hospital, and he's been doing lots of adolescent hip preservations. He's helped us a lot on those things, and also some limb recon cases. Thank you very much, Scott. To Dr. Efre.
Thank you very much, Dr. Scott, for your amazing talk. So the next talk will be by Dr. Amrish. He's from India.
Okay. No.
Dr. Amrish is from India, Calcutta, and this is the state of India where we know from its discovery of India by European navigators, right? So he has his own practice in India. He owns his hospital, and he's here to give a talk on our conference. Thank you for coming. So the stage is yours.
Yeah, greetings from India. So I live in a state of West Bengal, Kolkata in India. It's the sweetest part of India. So it's my honor, and I thank to the ESOT and my dear friend Efren for inviting me for this August gathering. So I will talk on PFN. So proximal femoral kneeling. This is one of the day-to-day surgery for all of us across the globe. But still, the fracture, neck femur and trochanteric fracture, these are still unsolved problems, and we face a lot of challenges in our daily practice. The treatment of proximal femur started with, our seniors may have witnessed, from SP nail, angled blade plate, then DHS, and now what we do is proximal femoral nailing. So I have also witnessed DHS for at least 1 decade, and then gradually what I realized, so PFN may be a better choice for most of the cases of proximal femur fracture. So why PFN? So proximal femoral nailing, because it has some biomechanical advantages over the surface implants like DHS, DCS, or angled blade plate or SP nail. And the most importantly, it allows us for a close reduction and internal fixation. And this is the most important part of the surgery. And obviously, as we are not opening the fracture site, so it decreases soft tissue trauma, it decreases blood loss, and that's why there is very, very minimal rate of infection and wound complications, and that's so early return of function. So these are the advantages, and that's why we usually try to go for proximal femoral nailing nowadays. What is important for proximal femoral fracture surgeries? Like for any surgeries, proximal femoral fracture should have a very good, almost perfect reduction. And there are certain criteria to assess your reduction, which I will discuss in subsequent slides. Second, while you are doing proximal femoral nailing, you should have a very good reduction, a good neck shaft angle, which is approximately 135 degree. You should have a very good entry point, perfect entry point. Otherwise, you may come out with blowout of the proximal femur and loss of reduction and later on consequences. Your nail insertion should be very properly, and you should have a very precise placement of lag screws or lag screw if you are using the PFNA2. So sometimes we face a lot of issues, like issues related with the reduction, related with entry points, related with PFN insertions, and sometimes placement of lag screws. So what about this? So this was a simple case, and you see, is it acceptable reduction? No, this is not an acceptable reduction. Sorry. Yeah. So this was not an acceptable reduction. It's the proximal fragment is in varus. So what should we do? So in this case, what we can do, we put a Steinman pin or thick K-wire, and then we just derotate it and just make it in valgus position, and just then we can get a good reduction. Valgus reduction. A varus reduction is not acceptable at all. And how we assess? How to put pointer? Yeah. How we assess? We assess by this. This is the calcar, and this is the medial part of the distal fragment. So this should not be acceptable. The distal part should not be medial. And now after reduction, after putting this Steinman pin, also Sands pin, this is vulcanized, and this is the correct reduction. So we always say varus reduction should not be accepted, and reduction of trochanteric fracture, like in other bones, we should always assess in lateral view also. It's not about AP view only. Usually what we do, we see in the AP view, we see the reduction criteria, and we then jump onto the fixation. We should also see in the lateral view. Like in this case, so this is good in AP. So there are few terms like positive reduction, neutral reduction, and negative reduction. So can you say what is this? This is acceptable or not? Yeah, this is pretty much acceptable. This is known as positive reduction. Your calcar is medial to the distal fragment. So this is positive reduction, and this is very, very much acceptable. So regarding this, is this acceptable? No, this is not acceptable because the calcar is lateral to the distal fragment and this is negative reduction. We call it negative reduction and this is positive reduction. So this is acceptable. And in the lateral view also, this is also important. In the lateral view, the anterior cortex of the proximal fragment should be projecting anteriorly either, that is positive reduction, or in the line with this, that is neutral reduction, or it should not be like this. This is negative reduction and this may land up with failure of the system. Regarding placement of your jig or making the entry point. So our entry point should be at the proximal most part of the greater trochanter or the tip of the greater trochanter or slightly medial to that. It should not be lateral to that. And in the lateral view, it should be along the medullary canal. It should be in the center, not anterior, not posterior. So this is the perfect position. It's in this. It's a medial to the tip of the greater trochanter. It's along the line of the medullary canal. So this is acceptable or rather perfect entry point. And the second important thing is you should have always the lateral bone bridge or lateral wall. Previously, what we used to think that the PFN acts like the lateral wall in such fractures. But gradually what we realized, if the lateral wall is not intact, if it's not intact, then PFN nail itself cannot prevent failure. So you need to have a good lateral bone bridge to prevent varus collapse and then subsequent failure. So sometimes what happens, we do a good reduction, we start putting nail, and then what we see, there is loss of reduction. What are the causes of loss of reduction? So to prevent these, you should have an adequate trimming before you introduce the nail. Sometimes we need to fix the fracture preliminarily before introduction of the nail. We fix it anteriorly, posteriorly, and then put the nail. That is very, very important point. And the most important point for me is avoid hammering always. Do not hammer your nail. Even in case of tibia nailing, femoral nailing, or anywhere when you are doing nailing, do not hammer your nail. If you need to hammer it, that means there is either less rimmed canal or there is some obstruction at the tip of the nail. And you may land up with iatrogenic fracture. So that is very, very important. Whenever you feel encounter difficulty in introduction of the nail and the nail is not advancing properly, do not hammer it. Reassess whether your rimming is good, whether your canal is bent or not. Sometimes what happens, we just take the X-ray of the part which is fractured. So you need to take a X-ray of whole of the bone to look whether the canal is bent or not. And now, sometimes what happens, if it's a comminuted, you can just push the nail and the proximal fragment and then apply the lag screw to prevent loss of reduction during fixation. This is important for comminuted fractures also. So where the lag screw should be placed? It is a debatable issue. So in PFN-A2, we always recommend placing it inferiorly and posteriorly, but sometimes you can place it in the center position also. But if you are using conventional 2-screw system, the lower screw or the inferior screw should be placed as close to the calcar as possible to have a good bone purchase there, and it provides better stable fixation. So practically, if you ask me, first you pass both the guide wires if you are using the 2-screw system, then pass the inferior lag screw to compress the fracture, and then put the superior screw. And while maintaining the compression, while doing this, you maintain the compression by external pressure, especially in comminuted fractures, and finally you put the superior screw. So nail length, regarding nail length, what is the dictum? We call it when your lesser trochanter is attached with the distal fragment. When your lesser when your lesser trochanter is attached with the distal fragment, then you can go with the short PFN. Otherwise, in all cases, you should go with the long PFN. Whenever there is any suspicion or you are in doubt, just go with the long PFN. In cases of obese patients, in cases of the patients having very, very osteoporotic bone, you better go with long PFN. So nowadays, the indications for short PFN has come to a very in lesser cases, and we usually try to go with long PFN only. What about lag screw? Your lag screw should be at least purchasing into the subchondral bone, like this. It should not be short like this. It should be it should pass beyond the epiphyseal scar to have a good purchase. And what about screw versus blade? There are systems where you will get both screw as well as blade. There is hardly any difference in the long-term outcome. But if the bone is very, very osteoporotic, you should not use the screw, you should use the blade. Otherwise, there is no difference. So should we lock the distal holes? Whether we should lock either of the holes or static, dynamic, or both? So there is a consensus now. If you are not locking the distal holes, probably the chances of failure is lesser, but sometimes in a comminuted fracture, you can lock the dynamic hole only. And when you are locking both the holes, so because of those step effect, there are chances of failure of lag screws more in these cases. So better to lock in the dynamic hole only or not to lock. It is the current consensus. So we must have seen these X-rays, like backing out of one of the screws, or one screw is penetrating inside. So this is Z and reverse Z effect, and the causes being the lack of lateral buttress, is whatever I explained earlier. There should be stable medial cortical contact. That means there should be either positive reduction or at least neutral reduction. And the one cause which is not in our hand is osteoporotic head. If the bone is osteoporotic, in spite of following all the principles of fracture fixation, or in spite of doing all the good things, you may land up with failure. So, is this an acceptable reduction? By the discussion till so far, this is not an acceptable reduction, because this is this fragment is medially, and this is a negative reduction, and that's why it failed in this case. So even this much of negative reduction may lead to this catastrophic outcome. So this was a case when it's a pertrochanteric fracture, short PFN was done, following all the principles. There is a good lateral buttress of bone, and there is a positive reduction, at least a neutral reduction, but it failed in long term, cause I don't know why it failed. Maybe because of severe osteoporosis, and maybe because of design of implant. So we have seen many such failures in this conventional PFN, and that is the reason. And this was finally treated with DHS, and this ultimately healed. So that is the reason nowadays we are gradually shifting to this system. This is PFN A2. So almost all the companies have this PFN A2, including the specific company, which they are providing these implants in Ethiopia, I think also. So this is having a single blade system, where what happens, this blades, it's a large diameter, and it's a blade system. So it compacts the cancellous bone while inserting into the femur, and it prevents loss of any bone from the femur. So it has a good grip. That's why minimizing failures. So as I already discussed, so these are the locking systems: the dynamic hole, static hole, long PFN, short PFN, and as I told you, the angle of insertion is also important, and this system provides inherent 5 to 75 degree of angle at the proximal part of the femur. So this is the system which is gradually catching up in the market, and the indications already showed, as I discussed, for short PFN, there are definite indications, and in rest all of the cases, we should use the long PFN only. So how does it provide rotational stability? That is a question. So in such systems, there is a tip lock. This is the head screw, which comes all the way down to this, up to this, and this screw locks this head screw or this blade, and it provides anti-rotation effect. So it does not allow this screw to rotate inside the nail. And this is the reason it has resulted in lesser and lesser failures in recent years, which we were encountering in, when we were using conventional PFN. So a few cases of PFN, PFN A2, this was the pre-op X-ray, and this was done, and you see, it is a comminuted fracture. It's a gross combination by maintaining the principles. This is the positive reduction only. There is a lateral bone bridge, and this is anti-rotation principle. So ultimately this held. Again, same case, it's a trochanteric fracture. Again, maintaining all the principles, you should follow the principles only. Entry point should be perfect along the medullary canal. This is positive reduction. The grip is in the subchondral bone, and this is 3 bony point contact. Now what we say, it should be protruding slightly out of the cortex. It provides 3 bony point contact, this one, and this one. So ultimately it's a good reduction in AP and lateral, and it healed. Again, one more case, PFN A2. Again, all the principles, you should not deviate from the principles. It's a highly comminuted fracture, but ultimately it healed. Yeah, yes, finally it healed, and this is probably 8 to 10 weeks post-op X-ray. So in brief, PFN is an excellent implant, provided you follow the principles. So principles, like any surgery, it must be followed. Otherwise, whatever implant you use, you are bound to fail. So from my side, principles, that should always be followed, like in all other surgeries. And implant variables, yes, these are important. And with the growing advancement and with the growing technology in the implants, gradually we are facing less and less failures. Sometimes patient-related factors are also there, like osteoporosis, and what doctor said in Elijah, taking smoking. He was smoking in the, and only Elijah can help in these cases. If somebody is smoking, long bone is very hard to unite. So we always ask our patient to quit smoking, because nicotine is an anti-healing thing. And if it fails, definitely in your lifetime, many your surgeries will fail. If it fails, plan thoroughly. Take your time in planning, execute it with lot of patience inside the operation theater. That is very, very important. In such cases, you need a lot of patience. And thank you so much, and thanks and regards from India. So I loved to be here in Ethiopia for last 3 days, and I operated few cases, did live surgery. It was an excellent, experience for me, and I would love to have some exchange program, fellowship programs with all of you if the situation demands. Thank you so much.
Thank you, Dr. Amrish. So I guess this is the time that we are going to make separate room discussion. We will have the pediatric and reconstruction group, which is the station 2, to be placed on the other side of the room. So the organizing team will lead you. Those who chose to follow the reconstruction part will go now. So we have 10 minutes to rush and then join the others room. Those who are staying for the arthroplasty and trauma part will be, the arthroplasty workshop will be here. So moderators who are moderating the other session also will be going with them. So the moderators for this session will be Dr. Galata and Dr. Manawar. No, we didn't change. So you are going to give where your talk is over here, right? Professor Raj, you are here.
Oh, right. Thanks.
Good morning, everyone. So we'll start our discussion. I think those who are on the back maybe come forward. This is closed discussions. You can come forward. So we'll moderate this session, me and Dr. Munawar. So Dr. Munawar will call the first presenters.
Okay, thank you. Good morning, all. We have a series of talks. The first talk will be by Professor Ramesh. He is a well-renowned pelvic surgeon. I don't have to introduce himself again. So welcome. He will talk about effects of core decompression on prevention of avascular necrosis.
So very good morning, and today I will be talking about a disease which I heard is reasonably common in Ethiopia, that is avascular necrosis. We heard how a younger deformed people can be made better, how a trauma can be settled down, but this is one thing which makes the people reasonably disabled at a very young age. So I was given a task to tell how core decompression works. We must appreciate from this case, it was in 1997 when this case came to me, 3-month-old dislocated hip, neglected obviously, and I did an open reduction. At that time I thought definitely this is going for AVN. So I got MRI done. I kept on watching, I didn't do anything. He was working as a driver in one of the company doctor was known to me. I told him, send him even if he's asymptomatic. I want to get MRI done on the company's expenditure. So I got his MRI in 98, you see, the AVN is developing. 2001, you see, 4 years later, hip is destroyed. He had no symptoms. And it was in 2005, hip is bad. but he's able to sit and stand. He has no symptom. So what it teaches you, he became symptomatic in 2007. 10 years later, after I did open reduction, the avian appeared. So our understanding was that whenever you are dealing in a case of an avian, if the patient becomes asymptomatic 2 years, 3 years, 4 years, don't take it as a success. It is only when it survives more than 5 to 7 years. We may be deceptive in understanding, yes, my things have worked, but 4 or 5 years, they may be totally asymptomatic and our perceptions may be wrong. So wait for a time. We all appreciate what MRI things are seeing on the various stages. I'm not going into detail. And MRI definitely is one of the best diagnostic tool to define what is an avian. We did publish that if person cannot get MRI done, PET CT scan can help with equal amount of certainty for the diagnosis. Then we did a longer study of the cases which we had. We found it out steroid was a very common cause for us, idiopathic, then alcohol, and then trauma. They're the causes in the area where I was working around. And we must understand, if somebody is getting steroid, there are chances. How early that patient will become symptomatic? They say by 6 months, his avascularity has already appeared. We need to diagnose it out. What about trauma? If I had got a dislocation, when I should be able to see it certain? This is our own study. We found it out that it is 3 months. If you take a MRI at 3 months, X-ray may take a year. This symptom may take a lot of time, but 3 months MRI is a definitive for the diagnosis of avian. That is what we published way back in 2010. Now we all know about the Fickett staging, the gradual progression, and there are a lot of classification. The question comes, which is the good classification? If you look at it, Japanese classification is the most specific and outcome related classification because it deals with the location, whether this is in the upper part or an outer part. If something is in the inner part, forget, nothing will happen whether you do anything or you don't do anything. It is the upper and the outer part, which they label at C1 or C2, where if you are able to save, it is a credit. That is what we must understand. We all know it is the area of involvement which is important. How much is the area, the carbon angle we measure, that gives us a kind of an estimate what amount of thing is disturbed. And it has been seen that large lesions never regress. Small lesions out of dome may settle. Even without treatment, I am still not at the treatment level. And then a very good study had come up. It is the amount of necrotic area. If it is more than 25% of the weight-bearing area of the femur head, this is likely to collapse in all cases. Now comes the management. Most of us understand that weight-bearing is very, very important. If you do non-weight bearing, they will settle. No. Weight bearing makes them asymptomatic. Disease does not settle down. And that is what was proved. And this was proved by histological studies also, that avoidance of weight bearing does not settle the disease. The disease stays. It is asymptomatic because the patient is off weight bearing. And then bisphosphonates, one of the very common thing which has been advised a lot. There are experimental evidences. There are papers also about it. And there's a good mechanism that they will slow down the osteoclasts, allow the osteoblasts to come up to that level. But I can show some cases which relatively did little better with osteophos therapy, but it is not kind of a universal thing and all these things. What the literature overall says? Literature says no significant efficacy is there. So we cannot befool ourselves that bisphosphonates will settle the things. No. Another review. Technically, any pharma option, they say no pharma option. Technically will settle down the avian. This is other kind of a therapies, physical therapies. They have found they can be successful, but all on a very small lesions. whether extracorporeal shockwave therapy, hyperbaric oxygen, or you can talk about ozone therapy. People tried many things. Everybody said they are successful, but they never become a treatment in most places because they were studies only. So if you review it, this paper, they say bisphosphonates you can give because it is low cost, it is compliance is very easy. So keep on giving whatever the benefit they may give or they may not give, but you can add any other things. Now, what are the surgical procedures? The topic which is given is the core decompression. And if you look at this very old kind of a metal analysis, reasonable number of certainty that in a stage 1, reasonable 84% of the outcome can be positive and less in stage 2. In 2004-5, then we understood it's not the big hole you make. These smaller holes with the 4 mm, 4.5 mm, which are equally effective with less danger of getting the fracture around. So so we have been using this therapy as an alternative therapy. Now the question comes, is it better than restricted weight bearing? Yes, it was proved in various studies that it is better than purely weight. But if the lesion is little advanced and you want to remove the dead bone, you can't do with this core with the 4.5. So we use these expandable reamers. You put inside it, it expands the blades, you carry it out, take it out and get the graft inside it. So this is something which is available now with those things. And then if you put a graft into that area, the study says you can have a benefit in this kind of a disease along with this kind of a core decompression. Now, so what is the ideal case? This is again in our paper. What is the ideal case where this core decompression may work? When the lesion is not very big. When lesion is located in A and B situation, I'm not talking about C situation or C1 or C2. And then multiple drilling may be helpful in this kind of a situation. People found osteoscopy or arthroscopy, they are likely to help in the localization of the lesion. So we may be benefited by exact localization. And these systemic review shows, yes, this is a better option to do. Now comes the core decompression alone. We have seen its level of efficacy. Can we augment it? So core decompression augmented. Now what are the augmentation tools? The effort started way back in 2004. They started looking at those growth factor and gene therapies. This is again 2004. They found these BMPs can work. They found whether this core decompression and alendronate can work together. That is my classical management in my cases. They found, yes, it can work. These are all augmentations. Then we understand the pathology that in an avian, the dead cells are actually cells are being replaced, fatty cells and the necrotic cells. And we all know the bone marrow. As an orthopedic surgeon, we found it to be the good substance with a lot of osteogenic potentials and lot of these multipotent stem cells which might help it out. And this is the person with me is Harnig, who presented some paper, and this abstract was published in one of the journal in 2001. In 2002 probably I read it. I was fascinated. Yes, marrow can be put. And incidentally, what happened? Another 1 or 2 papers appeared in the subsequent years also. Incidentally, one of my surgeon friend got an injury, dislocation reduced, has an avian. I am talking about 2003. So he said, can be something be done? I told you, I had read Harney's article. Should I give it? Can I try it out? I tried it out. He was reasonably okay for a number of years. Thereafter, he met an accident, so I lost him. Another patient, an orthopedic surgeon, my own colleague, he met with an accident, got an acetabulum fracture again in 2004, and then got this avian, because an orthopedic surgeon, you are more prone to get MRI early and get it, no. So I did the same thing when the radiology shows. Now it is 20 to 20 years. He's still okay, he's still fine. He is developing traumatic arthritis, but no avian as such. So I was now enchanted in 2004. Yes, that could be a thing to try. I tried the search scheme through AIOD France and AADO Hong Kong. I tried these 2 agencies and I took it as my PhD product and I started working on them. So I took a number of these cases, did proper in our lab. We did a proper isolation, proper workup, And then now I'm showing the cases which I did at that time and during afterwards. This was a C2 lesion, 33 years. And you can see both the hip joints, how bad are. And this is him 7 years later, reasonably settled after 7 years. Another case, 54 years Sadiq, who had got this, one side was quite bad, symptomatic, so I did a THR. The other side I went for, which was a B2 lesion. And this is him after 10 years of that core decompression. Another C1 kind of a lesion. She's a case of Hodgkin lymphoma, got steroid, got avian. You can see the lesion, did the same thing. And this is her after 11 years of follow-up. Hips are all maintained well. And after 11 years, another case, 2009, I did this. You can see the hip. And then this is him after 11 years again. Another case I show you. This is one side was bad. I was going for THR. The another side I went for it. And this is him after, this is her after 12 years of follow-up. Another case I'm showing, 30 years lady who had again some marrow disorder, got avian. So one side I did THR, another side I went, this is her 17 years of follow-up. You say, all the heads are maintained. My only addition augmentation was stem cells concentrated, put into the area. This is another, then we had these cultural cells also, I'll tell about them. This is the patient, we did it, these are the JC2 types. Now this case had got abnormality radiologically. Clinically, he was okay 17 years. He's still not gone for a replacement. He's still okay without a replacement. This case did not succeed, so this was a failure with us. But this study, with the initial result I published in 2012 in Journal of Arthroplasty, and this was cited by, because this was 4th study in the world about this. And it is cited by every meta-analysis subsequently, 2017 and 18 as a 4th study in the world it was cited. Now these days we have all these pharma company providing us every instrumentation. Now we don't need a very special lab for BMAC. Then we had this experience of culture cells also. Now these are also available. You can use cultured osteoblasts to put in those options. If they are options, these are relatively younger, these things, and they studies also say it is reasonably okay. As I was telling yesterday, there was no study about the trauma. Here we did some trauma cases also. You can see these trauma cases again showing same kind of a relatively better outcome at 3 or 4 years follow-up in these kind of a situations, and able to take care, though the outcome was not as good as I told yesterday as it is. Now, people started further augmenting because it's never 100%. So they started giving PRP along with it, whether it can help it out. Then it was another paper in I'm talking 2 years back, 23, it was paper that stem cell therapy with core decompression was more effective out of all of them. If you look at all those things, and again 25, they said you can still try PRPs also. And again 25, another meta-analysis. And now these are all meta-analysis with a lot of studies that these are likely to be good. The question came, if you are in a late stage, then your femur head is likely to collapse. Again, only BMAC cannot do it. In stage 2, early it can work. But when you are in the stage 2, later part of it, the quality of the bone, and you have done a grafting, it can collapse. So the people were using initially fibula. We were using fibula a lot. But then it came to be the metallic rods, so-called tantalum rods. And this is meta-analysis says, yes, if at that stage the rods are combined to support it out, the result is likely to be good. So this we innovated. We had a 3D printed trabecular rod which can allow the stem cells to go in, as well as provide stability to the femur head along with the grafting. Now you kerate it out, graft it up, support with this thing, and now you can expect that these hips can last for a reasonably long period. So depending upon the lesion, these are the publication which we had about these stem cells. And now this is my one of the last slides. Last year when I was working with the Institute of Technology, I found it out. We do core decompression. We all understand there is a hard bone, necrotic bone. Then there is a soft bone. There is a hard bone of the body weight from the acetabulum side, soft bone of the necrotic bone. Under is the harder bone due to the vascularity, and this soft bone get crushed. If I make this hard bone soft by multiple drilling into the around the necrotic area, probably we may succeed. And our experimental work in the lab did work, and that is published this year in the injury journal also. So this was a kind of another approach of core decompression in that area. So to conclude, we have a potential of using a core decompression in the management of AVN, depending upon the lesion. And if you have excluded transient osteoporosis, you have excluded other things. And if it is early stage or stage 1 of the AVN, simple core decompression, multiple drill holes will settle the problem. If there is a little change and you have started looking at the radiological picture and the lines have appeared, now you do a core decompression and you can add BMAC. If you feel that the lesion is reasonably big and is late, you can go in, curate it out, put the graft and put some kind of a support to that area. Along with adding BMAC, you might have a better option. And always look at it. Early results may not be everything. We must wait for the long term to see whether we are successful or not. Thank you.
Thank you very much, Professor. This is most important topic every orthopedic surgeon facing everyday clinic. So hopefully we'll have a lot of questions after. You can sit. Yeah. So the next speaker is Professor Raju. He is presenting us joint preservation technology. The stage is yours. Thank you.
Good morning. Am I audible? Good morning. After the excellent talk of Dr. Sen on the preservation of hips, I'll now be talking and focusing my talk on preservation of other joints, especially the knee joint, because we know that prevention is better than cure. We are now evolving from the era of reconstructing the joints with arthroplasty and other techniques to now preserving the joints, and hence there is a lot of focus. Obviously, the natural joints are much better than any artificial joint, and people are demanding for it, and hence we must find the ways how we can preserve the joint as far as possible. As you can see, preserving is much better than replacing it with a hat or something like that. But we must first understand why the cartilage degenerate, because there are several things that happen in the cartilage metabolism. There is altered extracellular matrix homeostasis, proteoglycans turnover is abnormal, that continues for about 25 years. There is increased activity of cartilage destroying materials like metalloproteinase and cathepsins. Also, inactivity of the joint motion is very important for the nutrition of the joint, and hence if there is any inactivity due to stiff joint or immobilization of the joint for any surgical procedure or otherwise, can lead to cartilage degeneration. If there are constant compressive forces, especially in malaligned joint, again it leads to cartilage degeneration. Aging, of course, is very important because there is altered distribution of chondrocytes, decreased in the hydration of the matrix, and there is increase in compressive stiffness inside the cartilage. So we must try to preserve the joint, and the one and the most important thing is to diagnose early, to have a high level of suspicion in these patients. And of course, we now have several ways to diagnose early cartilage degeneration in the form of plain x-rays, standing x-rays, long leg x-rays to check the malalignment, and other investigations like, and most important is MRI. And MRI again is evolving much better. Now we are doing a lot of studies on SPECT MRI and PET MRI, where we can actually detect cartilage degeneration even before any symptoms. And hence, MRI is a very useful test in cases of especially symptomatic patients in younger patients. Surgery is not the only treatment available for these patients. The non-surgical treatment like weight reduction, muscle strengthening, and training are important. Then now we have lots of nutraceuticals that are available, that are the nutrition for the cartilage in the form of, and they mostly come from our kitchen, that we use products for eating like curcumin, collagen, vitamin D, glucosamine, fish oil, and so on. And all these are now commercially available and may be useful. Offloader knee braces, especially in malaligned knee, can actually relieve pain and prolong the life of the joint and postpone the need for joint replacement. Insoles in the shoe, especially in varus knee, lateral wedge insole, is quite useful in relieving pain and postponing the need for surgery. Lifestyle changes and work style modification are also important. So these things are actually quite practical and must be tried even before contemplating any surgical option. Now, what are the surgical options that are available? There are many surgical options that are now available to us, but we need to identify which surgical procedure is useful for our patient, and there are specific indications that are available that I will discuss. Cartilage has specific problems because most of the full thickness cartilage are symptomatic and not diagnosed early. They may present with pain, swelling, locking, catching and grinding, etc. Cartilage, as we know, is aneural, avascular and alymphatic structure, and does not have the ability to regenerate or heal, especially in adult people. And if that happens, the patient usually lands up with early osteoarthritis. So the first thing in the management is to identify the correct patient. The correct patient for any surgical restoration of cartilage injury is a younger patient who is willing to cooperate in rehabilitation and has a symptomatic cartilage lesion. We usually avoid treating asymptomatic cartilage lesion with any major surgery. And patient has no arthritis in the joint already existing. The coexisting morbidities like meniscal tear, ligament injuries, or malalignment actually are not are risk factor for the cartilage healing in these patients and must be corrected either simultaneously or before the cartilage restoration techniques. There are various techniques for cartilage restoration, can be divided as chondral protective, chondral stimulation, chondral transplantation, chondral substitution, and new chondrogenesis technique, and I will discuss them in brief. This is an important slide which sums up most of the commonly used cartilage restoration technique in simple small lesions with low activity. One can do abrasion arthroplasty, debridement, or radiofrequency ablation. In small cases and not so active individual, drilling and microfracture can restore cartilage for some time. But in a larger lesion in more active person, osteochondral autograft or OATS are quite useful. In larger lesions more than 2 centimeters square, or in a failed prior cartilage procedure, ACI or autologous chondrocyte implantation, where you put cultured cells into the lesion, are quite useful. So this is an old slide, but sums up the various cartilage treatment depending on the size of the lesion. If you have a smaller lesion, less than 2 centimeters square, then debridement and lavage or marrow-stimulating techniques like microfracture are useful. In 2 to 4 centimeters square, ORTS is preferred. In larger lesion, ACI or osteochondral graft are used. Having said that, the assessment of the lesion must be done after debridement of the lesion, not before that, because initial lesion may look very small, but when you debride the loose cartilage, the lesion will expand. So your assessment for final treatment or decision to do the treatment will depend on the final outcome after debridement. So I've already discussed this. I'll give you some example. This is a 20-year-old cyclist who had anterior knee pain, and you can see there are grade 3 changes happening on the undersurface of the patella. This can be debrided, and radiofrequency ablation is usually helpful if it's an isolated lesion. If there is a kissing lesion, then you may have to do much more like microfracture or ORTS, or sometime even ACI. This is a full thickness cartilage lesion where subchondral bone is exposed on the weight-bearing surface on the medial femoral condyle, and of 2 years duration. Here certainly you require much bigger surgical procedure like ORTS. Sometime you do scopy and find even in symptomatic patient cartilage is looking almost normal, but when you probe it, there may be softening of this cartilage here. Micro drilling is useful. Another patient with grade 3 changes on the medial femoral condyle again require some sort of marrow stimulating procedures. Sometimes you find these cartilage lesions accidentally or surprisingly at the surgery because your MRI does not report it uniformly unless your MRI report person is good, and you must be therefore well prepared. So depending on the treatment, depending on the size of the lesion, you should decide the treatment and also the activity of the person. In smaller lesion with less active, microfracture is quite good. In moderate lesions, mosaicoplasty or ORTS, sometimes ACI or MACI is also used. For larger lesions, allograft or MACI is certainly the treatment of choice. In older patients, of course, joint replacement remains the treatment of choice in large lesion. So again, summing up, depending on the size of treatment, you decide the treatment of these people. The treatment also depends on the age of the patient, and outcomes also depend on the age. In children and adolescents who have some capability of cartilage healing, debridement, drilling, and sometimes internal fixation of loose fragment in OCD, especially if there is underlying subchondral bone present, is quite successful. In adults who are active and relatively have a healthy joint, microfracture or cartilage repair techniques like ORTS are useful. In patients with larger lesions or prior failed lesions, ACI or osteochondral graft is useful. In patients who had associated malalignment, osteotomy must be done in association with these cartilage lesions. In old patients, these cartilage lesions do not require any reconstructive procedures where joint replacement remains the treatment of choice. So there are several new techniques that are coming where you can do single stage cartilage regeneration. Then there are pulsed electromagnetic treatment that are able to heal the cartilage injuries. MSC cultures are now being used to produce active cells for healing of these cartilage lesions. Then if you have a large lesion, there are now implants available of different sizes that can fit the defect, like this gold implant or ORMI CFC implant to replace the cartilage injuries with these artificial implants. We know about 3D printing, but now we have bio 3D printing, where bio inks are used to repair this cartilage. And this bio 3D printing allows several advantages, like it mimics the real structure of the desired tissue or organ, including cartilage. You can create patient-specific and organ-specific treatment for these patients with 3D bioprinting. And they are quite biocompatible with human cells and tissue. And we have been doing this research for almost now 5 years with IIT New Delhi, and have published several papers where we can actually now produce cartilage on silk-based background, and they are quite good. PRP is being used right and left, at least in our part of the world, because theoretically it is very good. It provides 3 to 6 times of platelets that have the healing potential because of several of these factors that are available in it. But the problem is we do not know how many times the PRP has to be given, what is the concentration of platelets that are being used in each cases. So some people also call PRP therapy is a placebo therapy, which is the PRP means procedure rich in placebo. So if you tell the patient you are using your own tissue, your biological tissue, and heal, most patients would love it and would like it. But still we do not know much about PRP therapy. Then gene therapy is coming in a big way, and hopefully in next decade or so we may actually be able to treat osteoarthritis and rheumatoid arthritis with this type of treatment. So to conclude, my single message is try and preserve the joint, especially in younger patients, and do not go for replacement. Many treatments are available, many techniques are available that are now successful. Almost 200 years ago, John Hunter said cartilage injuries do not repair, and we believed that for almost 200 years and did not do anything in an attempt to repair the cartilage. But in last 20, 30 years, we have seen lots of therapies coming up which can help in regenerate this cartilage. So regeneration is the upcoming things in this rather than replacement. So treatment decisions should be based on patient-specific factors and defect characteristics. Thank you for your attention.
Thank you, Dr. Raju. So the next 3 talks will be about some articles. So the first talk will be the salvage total knee arthroplasty for post-TB knee ankylosing by Dr. Fasil. Dr. Fasil. Dr. Fasil is a young and a vibrant arthroplasty and sports surgeon. Welcome.
ጉልበቱን እንያዘው ወይስ ማይኩን እንያዘው ብለን እኮ ነው። እንዴት አደራችሁ? Good morning. So I'm Dr. Fasil. I'm an orthopedic surgeon, joint and arthroscopy subspecialist. So today's case is it's not defining the usual protocol that we are facing in the previous systems, in the previous treatment modalities, like patients with knee TB. Most of the time they are treated with conservative management fusion. So fusion is a good option, but this is another option that we are going to use for future patients with post-tuberculosis ankylosing knee, for those who are requiring or are in need of the motion of the knee. So the introduction is that TB is very common in our country. Knee and hip is the most common of these joints. We have encountered some of the patients with the knee. Previously, we did knee fusion in the corrective position for those young patients who are requiring heavy lifting activities or less interested in the motion. We did knee fusions. But for those patients who are in need of the motion part, the option of joint replacement was not available till a few years. So the result of severe functional impairment of the patient secondary to the loss of motion is high. Surgical options are joint fusion or joint replacement. The problem with the joint replacement with this patient is conventional joint replacement will not work for this patient. The risk of reinfection is very high. And the other problem is most of the bones are osteopenic and there will be some adhesions within the joint, capsule, patella, to the surgical, to the articular surface, all are adhered. So the role of staged, highly constrained total knee arthroplasty is what we are going to see on this patient. So the clinical dilemma is a patient who is young, relatively young, actively working, lack of motion, which we will opted her with the surgical option of fusion. She refused this, and the surgical challenges that we are faced on this patient is severe bone loss, osteopenia, and ligamentous insufficiency, risk of reactivation of TB. The implant challenge is if you are going to do total knee replacement, primary total knee replacement will not convey or will not suffice enough to counter the ligamentous insufficiency. The other problem is she has severe osteopenia. We should have to bypass all these chondral surfaces as well as the metaphyseal surfaces so that the risk of fracture or periprosthetic fracture can be reduced. The knowledge gap, we didn't have such kind of surgeries that will be done for TB cases. Maybe for trauma have been done, but for TB cases we don't have. So in the international literatures also, there are limited literatures. The aim is to preserve the successful two-stage joint replacement using hinged dual stem total knee arthroplasty. So our patient is 56 years female secretary with previous history of subtroctural fracture, and she was treated for that. And after around a year, she developed a knee pain, and for this knee pain, she was diagnosed to have a TB, and she completed TB treatment for about 12 months. By the time she arrived to our center, she was having around 70-degree knee fixed flexion, severe quadriceps atrophy, and with the consideration of fibrous ankylosis, we did knee X-ray. As you can see on the knee X-ray, the medial lateral articular tibial plateau was lost, and you can see the lateral tibial condylar surface is also innervated. And on the lateral side, you can see the extent of the osteopenia both on the tibial plateau metaphyseal part and the distal part of the femur is also loosened areas. So with the consideration of TB, fibrosis TB, then we plan to do 2 stages on this patient. The most important challenge that we faced on TB patient is, I hope most of you have seen total knee replacement. In case of total knee replacement, the primary one, the first thing that we do is exposure is very important. In this patient, 90-degree flexion is a mandatory. Either you started on the femoral part or on the tibia part, you need to have a 90-degree exposure, 90-degree flexion. Unless you do 90-degree, you can't do femoral osteotomy or you can't do on the tibial part. And on this patient, what we challenged was the quadriceps are adhesive to the distal part of the femur, the patella is adhesive to the femoral condyle, and the knee is in 70-degree flexed. So exposure of all this is challenge by itself. So on this patient, what we did was step-by-step release of the adhesive surfaces, release of the patella, reflecting the patella to the lateral part, and removing all the adhesive quadriceps from the distal part of the tibia. Then after we did all this, the plan was to do primary or hinged type of knee replacement. After we saw all the ligaments were gone, all the surfaces of the articular surfaces plus the ligaments are destroyed, and we assess the distal part of the femur, the proximal part of tibia were severely osteopenic. And for this patient, we took samples from the cases part of the tibial part, and we sent for biopsy. And the biopsy was negative after 2 weeks. Then the next procedure was to do total knee replacement. On this patient, we prepared both thanks to the implant provider. We had 2 options, whether to do CCK or hinged part. On this patient, since the ligamentous instability was gross, so we shifted to our procedure to the hinged type to counter the problems of the ligamentous instability. Then what we do, the attenuated ligament, poor bone quality, mandated rotating hinge prosthesis, cemented stem, bypassing the osteopenic part of the femur, around 13 by 10 for the femur part. We did tibia around 12 by 10 to bypass all the weak bones. Exposure and the size of the hinged system by itself requires a lot of bony osteotomy, around 17 mm. Commonly in the primary knee replacement, we take around 9 or 10 maximum, but for this patient, to accommodate the rotating or hinged part, you need to do osteotomies around 17 mm, so that the bone part, which is were very weak, has a tendency to split up. So we did a prophylactic cerclage and we did our reaming. The reamer by itself was very big, so that to avoid the fracture, we did prophylactic cerclage and we did cementing proximally and distally. And this is the final X-ray. This is AP X-ray. Cementing on the proximal as well as distal was good. So post-operatively, our patients, this is the immediate second post-op day after the surgery. She started weight bearing without significant pain, and after this is the last pictures after 6 months, and you can see we achieve 90-degree and full extension for the surgical operated site. So preoperatively, the knee score, so knee society score were around 35 for the knee score, and the function was 25. After the surgery, we have achieved around 70, and functional score becomes 60. And currently, she's walking with 1 walker. And for this, from ankylosed functional, around 90-degree passive flexion, and with active flexion assisted, we can achieve around 100-degree. And she from toe touch weight bearing to currently full weight bearing, she is actively walking with one walker. So the key is for this success is that we have eradicated till now, it's 6 months. Future, I hope we'll have more studies so that we can follow her, the outcome of the infection. The other is we have achieved stable implant fixation through bypassing the chondral surface as well as the osteopenic surface. Excellent function, around 90 to 100 has been achieved. Independent activity, she can walk with one walker, and this is what we have achieved. And the protocol, which is two-stage protocol, is very effective to achieve all this and follow the patient. So thank you. This is what I have. This is a presentation by me and my colleague Dagim from Jordanos. Thank you.
So, Dr. Fasil. The next speaker is Dr. Gammachis. Dr. Gammachis is from Addis Ababa University, Orthopedics Department. He's recently finished his trauma arthroplasty fellowship. He will present us functional outcome and the radiologic union of unstable traumatic intertrochanteric fracture managed with the CMA. The floor is yours, Dr. Gammachis.
Okay, thank you, and good morning again. So I'm going to present an article on functional outcome and radiologic union of unstable traumatic IT fractures treated with proximal femoral nail at Black Line Hospital and associated complication on behalf of my team, Dr. Miski and Professor Brook. So this is outline of my presentation. I directly go to the introduction. So hip fracture, as you all know, is one of common fracture you see day-to-day basis, especially in elderly group of population. Thus, bimodal distribution usually result from high energy injury in young patients and low energy simple fall in elderly patients. So these hip injuries could be an intracapsular or extracapsular fracture, as you all know. And the patients with IT fractures usually tend to be old and sicker than patients with femur neck fractures. And usually patients with hip fractures have associated significant morbidity and mortality. With the current care we can provide, still we face as high as 20% mortality rate in patients with hip fractures. So primarily our study focus on traumatic extracapsular IT fractures. So the treatment options we have at our centers includes sliding hip screw, dynamic condylar screw, ABP, proximal femoral nail, different types of proximal femoral nails, and sometimes hip replacement is the only option you can provide for this group of patients. So we studied functional outcome and radiologic union of unstable, specifically traumatic IT fractures treated with cephalomedullary nail of Sharma company. So this study is done for the first time in our country, and also for this specific implant, it was done for the first time, of course. So it helped us to know the functional outcome of our patients, and we will see subsequently, and we will give also some suggestions for the implant manufacturing companies. So what we did is it's a retrospective institution-based cross-sectional study. It was done in our center at Black Line Hospital. So the implant was introduced to our center in 2008 Gregorian calendar, which is now 7 years back. So we included all patients for whom this implant was used since 2018. And those patients who have follow-up for at least 1 year. So as you can see on the right side, we have a list of exclusion criteria from these studies. So patients who have significant comorbidity, which probably affects their functional outcome, were excluded from our study. and patients who have who didn't give consent and for whom we can't get complete data were also some of the patients excluded from the study. So over the last close to 7 years, we did close to 500 patients. We did this cephalomedullary nerve for about 500 patients. So the remaining doesn't have at least a 1 year follow-up. So we registered 310 patients. From this, we identified 127 patients who fulfilled the inclusion criteria for our study. So data is collected using a modified HARI-CP score and some questionnaires developed by us. So we collected data, cleared, entered into SPSS version 27, and we ran the analysis. So this is some of the key results from our study. So surprisingly, we have a significant portion of our patients are young, like close to, as you can see, about 32% are younger than 50 years old. And of course, we have elderly patients, about 10% are older than 80. So when we see the functional outcome of our study participants using the modified HARI-CP score, we found about 70, close to 75% of study participants are at least fair and above functional outcome. So this modified HARI-CP score, it's a standardized functional outcome analysis tool for hip fracture and hip replacement. So we found about close to 50% has good and excellent outcome, and only about 25% had poor outcome according to our study. Of course, we have about 23 patients died before 1 year from their surgery, and they are not available for assessment of their functional outcome. So surprisingly, we have almost 100% radiologic union. We just studied union only. We didn't study the other components of radiologic parameters, as the data is incomplete. So then we studied also the common complications we identified in our patients. So the 3 top common complications we identified in our patient includes, of course, mortality is about 17, and reoperation occurs in about 4% of our patient, and post-op infection, which includes both superficial infection and the deep surgical infections, account for about 8.7%. And helical blade backout is very common in our study. We identified about 8% of our study participants developed helical blade backout subsequently. So we do some correlation analysis to see factors that potentially affected the functional outcome of our patients, and we identified age of the patient, presence of 1 or more comorbidity, and patients who had helical blade backout has positive correlation with poor functional outcome in our study. The other correlations are there, but it was not statistically significant. So this is to show you some typical cases, complications we identified in our patients. As you can see, the first image, it shows unstable comminuted IT fracture. Cephalomedullary nail was done. As you can see, patient has got another fracture in subtroch area, which was of course managed successfully. This is one of the complications you expect in hip injuries when you are doing cephalomedullary nails. And here, as you can see, this is one of our patients who developed a deep infection. He was been on suppressive antibiotics, fracture subsequently healed. Then implant was removed once the fracture was healed, and he is infection free now. Here, this is one of surprisingly common complications we identified. So this is the first image is immediate post-op cephalomedullary nail done for unstable IT fractures. As you can see on the X-ray, maybe the tip apex distance was a little bit high. The patient subsequently developed varus collapse, the helical blade slides back, and the patient subsequently requested for implant removal due to the irritation from the prominent helical blade. Here also you can see on the on immediate post-op and on also fluoroscopic image, the implant position and reduction was good, but 2 months post-op when the patient comes for follow-up, it was in varus, and the helical blade was prominent. And subsequently we followed the patient. We got CT scan to confirm healing of the fracture, and it was palpably and irritating the patient. So the patient go for removal of the helical blade and the nail subsequently. This is another very similar case who developed sliding back of helical blade. Again, the patient requested the implant removal. So if the nail had some way to prevent this backing of the nail, the helical blade, we think these complications could be prevented potentially, or in disparate cases, we may have to use cement to prevent this helical blade back out. Here, this is the implant we are using in our center. So once you put the helical blade and lock it, there is no way of preventing. Once the patient started bearing weight, especially in elderly patients who had osteopenic bone, there is nothing to prevent this helical blade from coming out. Here, if you can run the video, the technical video. So this is the image. If you have, you can see the video. So there is nothing preventing this helical blade from going back, unless the bone is strong enough to hold the helical blade. Your helical screw obviously goes down. So we think if there is some cap, as one of my friend presented earlier, this could be preventable. So this is a conclusion. So I think I ran out of time. Thank you.
Thank you, Dr. Gamichis. The last talk before break will be about first hinged total elbow arthroplasty in Ethiopia. I will re-invite Dr. Fasil.
Good morning again. So we are going to present a patient with a 27 years old patient who sustained a bullet injury and diagnosed to have flail elbow, proximal ulnaral plus distal humerus was gone. So for this patient, we did total elbow replacement, and we are going to see the patient's outcome and everything. So total elbow replacement is option for the end stage of elbow trauma, rheumatoid arthritis, post-infectious. So there are many options, linked or unlinked, but for this patient, we use a hinged or linked system. So it's not common to have this kind of implant in this country. So it's limited in our low resource income countries. So severe post-traumatic elbow destruction present major reconstruction challenge, often leading to flail joint. So the objective is to report first successfully hinged total elbow replacement, demonstrating its feasibility and excellent functional outcomes. So our patient is a 27 years old male who was a driver prior to this injury, and he sustained high velocity gunshot wound, and after 2 years, he came to our center, and this is his X-ray. You can see the X-ray that the distal humerus is gone, proximal ulna above the radial tuberosity part, which is also gone, and radial head is intact. On the lateral X-ray, the most important fragment that you see on the cubital area is that there is a medial epicondyle part of the fragment. This is a fragment where the ulnar nerve was still attached, and all the pronator muscle and the flexor muscles were intact. So in the surgical part, I will explain that. So in this patient, after he sustained bullet injury, all his radial, medial, and ulnar nerve were injured partially, and after 12 months, all his activity regained. The clinical problem was gross instability due to massive bone loss and ligament loss. So he can't lift it up to his face, he can't do his activity. It was flat and it was just attached with the muscle and the ligaments. So the surgical goal was to restore stable, pain-free, and functional arc of motion. You can see the entry site was on the right side. You can see it in the anterior lateral part. The exit was on the posterior part with fragmented part. You can see the shattered fragments came out on two parts, so that the approach by itself was difficult to access for posterior approach on this patient. So the setting was a setting that we use. Hill Venture was our center. Patient selection was very young, healthy, and dedicated, motivated guy. And post-traumatic destruction bone loss resulting in flared elbow was the indication. Implant selection was linked prosthesis. It was mandatory because there was no bony support as well as ligament support in this patient. The implant type was coronary Mori style, hinged total elbow replacement. Pre-op planning was done on this patient. This is implant diagrammatic representation on the distal part and the proximal part, all the diameter, the length parts. And we took the contralateral for templating. We sketched it on the paper, and we can see around 3.1 centimeter loss on the distal humerus part, on the around 5 centimeter loss on the ulnar part. So when we fit the implant, this is our pre-op templating part that with a diameter around 10 mm or 1.6 millimeter. So we fit the implants and we choose our implant pre-operatively, and this is what we expected on the final. This is the implant that we selected, all range of implant from 12 to 17, and from on the ulnar part from 7 to 14 were available, and we prepared this material. This is the Junley system, the elbow replacement implants. So the exposure on this was paratricipital approach. We expose the ulnar and we dispose the triceps onto the lateral side. Before that, we expose the ulnar nerve and transpose it anteriorly. And we expose the flal joint, expose scar tissues with meticulously debrided bone preparation with a step reamer was done, trial components were inserted, and after we achieve successful range of motion, we proceed to the cementation. This is post-operative X-ray. You can see all the canal cementing and ulnar as well as humeral were in place. So that after that, we started rehabilitation after 2 weeks. For 2 weeks, we don't want the patient to have any kind of range of motion because risk of adhesions on the posterior approach skin part. And on week 2, the patient have achieved active range of motion up to 60-70 range. And progressively, after the follow-up, this is our patient's outcome. From the previous I showed you, this is flexion to 90 degree, and this is the extension up to 0. So flexion to 100, extension 5 degree lag, pronation, supination around 30 degree pronation, 30 degree supination was achieved. At May 8 months, he's currently actively working as a driver, and with my elbow performance score around 95, patient has excellent outcome, and joint is fully stable. There is no lucency, there is no instability. Currently is actively working. So in our patients, the feasibility of the procedure was that the meticulous planning, establishing local capability on such kind of procedure is mandatory. Safety, no major intraoperative postoperative complication was seen. And as outcome, I showed you The myo-elbow outcome was 95, and the motion was full range of motion. And so this is a proof that total elbow is an option for a young who is looking for range of motion. Fusion is an option for young who is going to do heavy loading activities in which this range of motion which we don't expect. So implant choice, patient selection is very important on such patients. Thank you. This is what I have. If any question, we can talk. Thank you.
Now I will call all the presenters to the stage, and all the cases are very important, and I think it is, we expect a lot questions. We have 10 minutes, yeah. So now the floor is open for Q&A. I think let's go for this 4 and then Dr. Mamu.
Okay. My question is for Professor Ramesh. In a patient with AVN, mainly in our setup, we see like most of those patients, they came with severe pain in even early stage, and most of their MRI finding they have extensive bone marrow edema that extend to the neck. And in this group of patients, is there a place for bisphosphonate? We saw that we give the bisphosphonate for those group of patients, and the bone marrow resolve, the edema resolve after 3 months with bisphosphonate, and the pain goes away. What is your experience on this one?
Yes, that was the perception with bisphosphonate therapy, that it will reduce the edema and subsequent viability may come. I showed my cases also, but individual experience is a different thing. The studies at a large, they do not still support it. Experimental studies do support, but large clinical trials have not supported it. So in the day of today, if the patient's symptoms are significant enough, I'll prefer that small hole 4 millimeter Steinman pin to do multiple decompression, and along with give bisphosphonates, I'll be more sure, because if alone bisphosphonates do not help, I am losing that time of 6 weeks, 10 weeks, 12 weeks. If it's not effective, my time is lost. And here in avascularity, earliest possible interventions will be beneficial. So that's my approach.
I wanted to add something more. If you see intense bone marrow edema on an MRI and patient with severe pain, usually AVN doesn't present with severe pain to the extent that patient cannot sleep. It is of short duration. Always think of transient osteoporosis of the hip as a differential diagnosis. TOH is a self-resolving condition which can settle in 2 to 3 months if you give anti-inflammatory, bisphosphonate, walking stick, and rest. So main differential diagnosis for such patient where AVN is suspected, and if you see intense bone marrow edema, transient osteoporosis, and I have treated so many patients, and we have a very landmark paper published in Indian Journal of Orthopedics about 10 years ago. So please refer to that.
Incidentally, I may add very interesting thing. I had this thing of a collection of about 40 of transient osteoporosis, and out of these 40 cases, 15 were doctors. Because maybe there is a reason for them to come early for the MRI. Whenever they start getting symptoms, they can come early. But the first case which we diagnosed way back in 1997 of bone marrow edema was also a doctor who was treated as a tubercular, because at that time MRI was not common, on one side. With the ATT, after 6 months, he got on the other side. So meaning by that ATT was wrong. So when the other side also had it, one of such cases had in the ankle also. So transient osteoporosis can also, it's a migratory, patient will become, you just have to console him. Don't worry, it will settle down. That is what he said it out. And it's very important. That is what I said in my talk also. Rule out transient osteoporosis. That's very important because transient osteoporosis is a self-limiting thing, settles down.
Quick questions. Shall I ask all of them, Gale, or some of them? No? All right. I will go orderly. Fasil, good papers. One quick question. The TB patient. Have you read on protocols when you put metals on TB, suspected TB joints, be it hip or knee, in terms of prophylaxis or post-op prevention of recurrence, because you can't rely on culture taken from specimen. The highest yield you can get from culturing TB biopsy specimen, if you culture for the mycobacterium, it's only 26%. You can't say they are negative. You took out cases material, and how are you comfortable to leave the patient without anti-TB for certain weeks? Some start pre-op, some start post-op, but there is confusion. But as our incidence is very high, recurrence is quite a risky. So have you considered prophylaxis? That's my question. Why do you rely on negative culture while the yield is very low? It is known. You took out caseous material, and with leaving the patient without anti-TB may be a problem. You'll reflect on that. Both professors, good papers. I challenge you from cost angle. Doctors, yes, they are in the compound. They come for follow-ups quickly. Our eyes are on them. Our patients, once they are a little better, they rarely come for appointments. And they always ask us for one-go surgery. They hate follow-ups, by the way. Just do some magic, goodbye. They may come occasionally. So for those patients, both of you, both core compression plus joint preservation, they need doctor's eye. We should see the patients always. So in our scenario, how do you see our patients? Instead of going one go for aggressive procedures like replacements versus frequent follow-ups, and in case deterioration comes, the joint fails, do replacements later on. So you reflect on this, please. Gamachis is good paper. We know this paper presented in the department. The only comment I have is put the comments you gave to the design company, plus please work with the previous presenter on prevention of this backout. He will show you all the papers and the slides. This is one of fantastic papers we have in the fellowship trainees. I kindly ask you to work on this paper with him. Cheers.
I just wanted to add one more thing. It is very easy to treat any patient with arthroplasty, and patient get quick, good result. Patients are very happy. It is very challenging to treat a patient and to console and follow up for 1 year or so while your regenerative process is taking place. So patient selection, patient counseling, doctor's patient is also very important, similar to conservative treatment. Nowadays, if you treat any fracture with plaster, patient will come every week, doctor, it has not healed, it is showing like this. And if you put a nail or plate, and patient is very happy. So this is also a very important factor in regenerative medicine patients.
I may just add, because I am in this, doing this thing for last now 30 years on AVN. Whenever I have a patient, I detail the disease to him. This is the likelihood. I remember one of the cardiologists, he was son of a doctor, he himself is a cardiologist, came to me, okay, Dr. Sen, I know this is avian, I have read about it, and it was early stage. I want replacement, only replacement, you do it. So I did it one side, now do it on the other side. I did both the sides. He was 37 years old. He says, I'm affected by my practice. I can't stand do the all stunting and all that. I want this to be done as a first go. Yes. A patient who says, after that counseling, I can wait for, can you try something? Yes, we tell them this is something we can try, but always I give them 60% the chance I may succeed in an early stage, 40% you will end up with the arthroplasty, and time depending upon when you feel you can't manage it or the pain is too much. That's the way.
To reflect on the professor's question was that I've cited some researches on the treatment of TB joint with either on the knee or on the hip. So previously it was considered to have at least 10 years resolution of the TB condition and to do any kind of joint replacement. But recent studies were showing that in the past 20 years was that some of the surgeries were done specifically after 2 months of the initiation of the TB. So whether the surgery was done after 2 months or whether it was done after years, the outcome was initiation of the TB treatment was enough. Some of the challenges that are they facing was in some studies was psoas TB and the presence of TB on the hip as well as on the psoas area. So in these patients, when they're considered hip AVN or hip collapse arthritis, and they open up and they face with pus and they send the pus and they find that it's a TB, whether to do the surgery early or 2-stage or 1-stage procedures. On those patients, what they show was the outcome of TB treatment after total hip replacement, even before the initial phase of or the 2 months treatment was adequate enough to prevent any kind of recurrence. So in our patient, it has completed all TB treatment. The risk of recurrence and regurgitation on this patient is very high. So what we did with send the culture, as you have said, there is still the risk of remnant. So on the triad part was ligamentous instability, reinitiation of the TB problem, plus bone loss. So we will follow this patient. We will see from the studies that we saw was 2 months initiation treatment was adequate enough to prevent further reinitiation of that problem. Thank you.
One more question. We are out of time.
Doctor, regarding your TB protocol, it has been recommended worldwide that you can do surgery under the umbrella cover of anti-tubercular drug, maybe after 6 to 8 weeks after initiation of anti-tubercular drug. That is conclusively proved, number one. And if there is recurrence, so in most of the cases, that is because of multi-drug resistance tuberculosis. So what we recommend in India, we usually get culture sensitivity test and resistance test also, drug resistance. So in cases where you are getting recurrence, it's probably because of resistance to anti-tubercular drug. So that thing should be kept in mind. This is about TB. And about Sir Raju sir told about the knee preservation technique. So we are doing even I am doing lot of cartilage transfer techniques, OATS and mosaic plasty. So I had a formal training on OATS and mosaic plasty, and it works wonder. So we have seen in 3 or 4 months after OATS transplantation, cartilage transplantation, patients becomes almost normal. I have 15 years of follow-up of a young patient whom I did two plugs of osteochondral cartilage grafting, and he is doing well till now. It was a deep, more around 2 centimeter by 2 centimeter of cartilage defect, full thickness defect. And the patient is still doing well after 15 years. Now he is around 45, 46.
OATS is a great technique for full thickness cartilage defect with larger diameter, like more than 2 centimeters square. But technique is very important. You need to have expertise in doing this technique, and the plug should not be very prominent or under the surface. It should match the surface.
Yeah, regarding that, I am an arthroscopy surgeon also, by the way. Basically, I'm more of arthroscopy surgeon than trauma surgeon. So the problem is the angle of the plugging of the graft is very important, and there should not be any protuberance. It should be like a smooth surface. There should not be uneven surface there. And what initially we used to think that it should only be done arthroscopically, but now with the growing experience, we are more easy to open it. We always try to open it, see it, and we need to have clear-cut angle. That angle of implantation is very important. So that is the thing we should keep in mind. Otherwise, it can do wonder. Sorry, and regarding AKI, that is also very important. That is, but it's two-stage procedure. That's the problem. Chondrocyte implantation.
One more question, burning question, Dr. Said.
Okay, thank you, Gali. So my question is to Dr. San. I have previously attended some of your webinars and lectures, and it's a pleasure to have you again here. One question is regarding the bone grafting. You have already mentioned your technique. I came across with also during my training the so-called light bulb procedure, where open grafting of the lesion performed in advanced cases. So what's your comment on that? And the other is usually when patients come with AVN, symptomatic AVN, we also find asymptomatic AVN in the contralateral side as an incidental finding. So what's your recommendation regarding cord decompression in the contralateral side?
Yes, the most important thing, actually, because the topic given was core decompression. So I did not delve about the other procedures. We have tried many procedures, from the classical muscle graftings, the classical, which we make a window light bulb procedure. We have done vascularized fibrillar graft. We have done non-vascular fibrillar graft, and all those procedures. Now we know that this patient with a sizable amount of a gap eventually will get THR. So you do not want to do any such surgery which will compromise the eventual THR, which might happen in 30–40% of these cases. So we try to minimize the first procedure. So you have to weigh the amount of morbidity you cause and the amount of outcome you are expecting, depending upon the stage of the disease. If disease is reasonably okay, I told you that bad X-ray doesn't mean a bad disease. Patient may be comfortable for next 10 years even. So only one thing which makes them to get early surgery will be pain, or the painful limitation in his activities, which will be. So we believe that if it is a early stage, simple. If it is a relatively advanced, my procedure should not go out of the bone. I do not want to go front, I do not want to go, because the chances in relatively late stage to late stage, the chances of success becomes less. So I personally, after doing everything, I have restricted myself to only, yes, I do TCVO, trochanteric rotational osteotomies, in relatively younger patients where your lesion is type B involving the head, where we can rotate it out and have, but this is all extracapsular rotation, varus or valgus. This was described by Suzuka before he described the Suzuka osteotomy. Suzuka had its own problem. We did that also, but it's technically difficult. We left it out. But this trochanteric rotation osteotomy is a better in a very young patient, which I am willing to do, because you do not go inside the joint, outside you rotate. There are many procedures which are done after surgical dislocations also. But again, that you must be that level of expertise where you can conduct it well before doing it, so that your eventual THR is not affected. Now, regarding your second question, the contralateral side, always assess the size and location. Most of the time, the first size is a bigger size. It is usually C1, C2. The other side is usually A lesion or a B lesion, which may never increase. If there is no edema on the side, I will just observe, not do anything. But counsel the patient. If any time he becomes symptomatic, get an MRI done. If it is edema coming, I'll do a core decompression. But if it's already edematous to a stage and edema is there, or he might have some symptoms, then I might simply do a core decompression on that side. But that surgery will be definitely smaller surgery than the major side.
Thank you very much, Professor. We thank all the presenters for your nice presentation. It was very great talks, all of you give us. And we also thank for the audience for your questions. Thank you very much. Now, I think, do you have any comments, Ephraim, from Organ? So now it's a health break. Thank you very much, everyone.
ትናንት ግሩፕ ፒክቸር ስላልነበረን በደንብ ግሩፕ ፒክቸር የገባንበት የቪክትሪ ጌት ላይ ያለው ረጅሙ ደረጃ ላይ ግሩፕ ፒክቸር አሁን ይኖረናል። So we shall start, I guess. So we're a bit late. Since Professor Ramesh has to leave early to his country, India, so we will give him the first two chances to present back-to-back his presentations, and he will be dispatched. So his first talk will be management of pelvic injuries in hemodynamically unstable polytrauma patient, challenges and current updates. And second talk will be introduced actually by Dr. Santayo, and then we'll continue.
Thank you. So can I have the slides, please? So now we are talking about a situation when we have got a polytraumatized patient with a pelvic injury. You know, that's a very specific kind of a situation where the person is already in a situation which can happen mostly in a motor vehicle accidents, but can be a part of fall from a height, and we are getting elderly people where this happens within the house also. But we are primarily considered polytrauma, that is a high energy trauma coming to us from a field vehicle. Now look at this scenario. One hit, second hit, third hit, and fourth hit. 4 hits to a man. Now the number of injuries will definitely be multiple, and that is the scenario with which the patient will have all the implications. It could be multiple injuries in the various parts of the body. Now this patient will be brought to the hospital. It could be either he's in extremes, or he's stable, or he's somewhere in between in this scenario. We all know the basic protocol of initial resuscitation. The ATLS protocol we follow, and accordingly we do. I will just detail it out, fluids, binder, and all things. This will be done, and then we do a secondary survey, evaluate clinically what is most relevant in this kind of a situation. Look at the external, thoracic, pelvic, long bones, and abdominal as such. Now what is to be remembered, that this patient might be in a shock. And what is causing that shock? It could be, apart from the pelvis, the chest trauma. And that is what we have to be aware of it. Now look at this scenario. Why pelvis is important? Because once pelvis breaks, the separation leads to involvement of the vessels along with it. Once the vessels, thereafter it could affect the visceral organs. They can be affected. And then this hematoma will make the patient hypovolemic. And now we have this complex scenario where a patient in a shock stage with the organ injuries could present to us in this kind of a instability situations. Never do this palpation to judge whether pelvis is stable. Evaluate it clinically only, because what might happen? There might be some clot formation. You manipulate, that clot is gone. The next clot may not be as potent. So first clot which has formed, do not disturb it. That's very important. Now it is important whether this pelvis after the injury is a stable one or it is an unstable one, because that has a lot of implications. If we have got the mortality figures, you can see them 16%, 27%, or 55%. And if you look at the basic mechanisms also, APC, when the pelvis opens up, when it will happen with the front injury, when the pelvis opens, maximum amount of a hypovolemia due to the vessels damage happens into this area. That is to be understood. Now, it could be any of these 4 scenarios. Pelvic instability and the patient's instability. Which is the worst? Unstable patient and an unstable pelvis. Now, that is what we are dealing with. We must be rapid in our assessment, because every 3 minutes delay, 1 minute, 1% increase in mortality. We used to talk the golden hour, now we talk platinum 10 minutes. That has to be understood. Whatever you do at the earliest is the most important thing. And don't forget that this patient might have a head injury, this might have a chest trauma, this might have a other organs involvement. So this has to be seen. We look at the general characteristics, we look at what we are giving to him. So we have to consider a kind of a minus or negative blood in that kind of a situation when it is an urgency. Now we must understand the basic principle now. This is called DCR, damage control resuscitation. First part is permissive hypotension. Don't aim to bring to the normal level. The volume is not, the BP is not to be brought to normal, little less than normal, which allows the basic vascularity, this viability of all the structures, but does not come to the normal level that it will displace the clots which has already formed. So don't over-infuse, under-infuse, so that the vitals are continuing. That's the most important part in these situations. Don't give too much of fluids. Give quality fluids. Give blood. Give this PRP and all those things. Don't give this thing platelets. Now that is what is called as restrictive fluid administration. That is the key. What it will do, because if you give a lot of blood, there could be coagulopathy, so you have to take care of it. So we do not want those fluctuations. So restricted fluid administration is the most important thing which has to be done, and it is found to be important. In between, we are surely going for a lab workup. And what is most important is this coagulation profile, then it is serum lactate and ABG. That's the most important part depending upon these things. And this is what will term us whether we have resuscitated adequately or not adequately. That's important. But if two of these factors are there, understand this patient might require much more blood. So what is called as massive transfusion protocol, that has to be. And in this protocol, it is very important. More is the blood required, more are the complications also. The benefit also, the complications also. And if there is a facility available, which is not there in many of our Indian hospitals also, but if this facility is available, that's an excellent guide to the amount of fluid and the blood administration. That's a very important part. And this has been seen because now you are able to monitor the coagulation profile. You can calculate and adjust the amount of a volume and the blood required. But if it is not there, obviously, as it happens in most of the places, we will have to compromise on it. Then patient's temperature warming, especially in the torso area, is very, very important in this kind of a shock conditions. The next part is that you look at the acidosis, which you have to take care of it, because that is what is happening in this kind of a situation. So we might have to give. Now this is, TXA is very important. Literature, it is right now confirmed that if given within 1 hour, or technically speaking 3 hours, TXA given, this is very important management protocol in our resuscitation. This can be available, and most of these centers are likely to have it and keep it, because this is that acute resuscitation which is supposed to be very good. And though, if you look at the corner, this is our own study, we did not find it to be useful if you are operating upon a acetabulum, that will reduce the blood. We did not find it out in our study, which I have pointed it out. But in acute trauma, when there is a hypovolemia, then this is important to reduce the amount of bleeding. That is what it is there. Then if you have infused enough blood, the blood pressure is not coming up, then you can give vasopressors. Otherwise, without a fluid, they are not likely to be useful in that situations. Obviously, we are going for E-fast, and that is a very important part in early stage. Don't go for a CT in this hypovolemic stage. Only do X-rays or the radiographs. No CTs, because CT is called the tunnel of death. If that patient with the hypovolemia is getting into the CT scan, so let it. Now we have to define it out. What are the all fracture with the X-rays? The best thing we can do is apply a binder. Binder at the level of the trochanters by internally rotating the limbs. If there are no other injury in the acetabulum or this thing, then binder is likely to be the best thing you can do in emergency, even on the roadside where the accident. So pre-hospital care should have binders. And let me tell you, in all the local meetings of the doctors or the paramedics, do guide these people in a case of a suspected trauma to the pelvis, use binder. You will be saving lot of lives by this thing. And you can see how a simple binder can close the pelvis, and if the pelvis is closed, it reduces the bleeding. And as for efficacy, its closure gives you reasonably good strength in this kind of a situation also. Now there is something with the binder. This is a new report, 2025. They looked at the literature again. They say binder is not very important. but this is one report which has come. Till date, every other literature in the world said binder is very good. It saved a lot of lives. This report this year said they are little doubtful about the evidence. They analyze all these things, but that is what they have found it out. Till that time, we have got more learning about it. Take binder to stay over there as the first protocol to be made. Then definitely you are looking at the bladder, you are looking at, now question comes stability. Binder is the first stability. Now binder cannot be applied for more than 24 hours. Otherwise it will cause skin necrosis. I reapply, the best is to put an X-fix in this situation where you are not going for any more surgery. X-fix is a damage controlled procedure. Just put 2 pins on the either side. You don't have to be very specific to give a very good, because these are temporary fixation devices, but must stabilize the pelvis. As a second part, once your fluid administration or a binder is done, you have to stabilize the pelvis. X-fix is the next thing which you can do it up. If things are available, C-clamp, very costly thing. Very few hospitals, even in our country, has got it. So what we do is we have our local made things also. We have made locally the same kind of a principle. Sometime we can employ, but it's not that much, because there are enough dangers when you apply in an emergency situation. So you have to be very clear when it has to be applied for. When you compare C-clamp along with the external fixator, C-clamp has more dangers as compared to the X-fix. So X-fix is supposed to be the better tool for that stability of the pelvis as such. If patient is still not settling down, next comes pelvic preperitoneal pelvic packing. Now remember this word. In our developing world also, this is a procedure which can be done. You just have to stay within an area, open it up, and push the sponges. But it's very important, there must be stability. You can't, without stability, if you pack it up, the pelvis will keep on opening up. First have the fixation, that is the external fixation as I showed, thereafter open. And now there is a video which you must have seen on the net. This gives a very clear picture how that blood will be there, or this can be there over there. In this situation, how the packing is likely to help. That is what you have to do in that emergency situation. No big technology required. So simple fluid administration, tranexamic acid, binder, X-fix, and if required, preperitoneal packing. That is what is to be required. And this has been seen that many have even reported 100% success result in this kind of a situation. That must be understood. Now, this is 2024, the status by one of our friend Axel Genslen. He has wrote this paper, this published in 2025, that the binder is still the best thing we can do. This is, and pelvic packing. So pelvic packing is a low technology thing which all of us can do in our hospitals. So that is something which all of us can do. And third thing comes, if patient does not settle, because we must understand primary blood loss is from the veins, 80% of it, 90% of it, 10% from these arteries which may not settle down. These 10% cases, if patient doesn't settle down, will require angioembolization. Now there is a big contrast in USA, North America and Europe. USA people, corporate hospital, they are more going into the angioembolization first, packing later on, while the European people still think that packing is the best thing and then they will go for. So there is always, but our protocol, in our setup, this angioembolization requires a lot of expertise, so we keep it at the last in our protocols. Now, when this thing, you see, it is a reasonably effective whenever the vessels are involved. So now what is called, what we should know is a 3-in-1 damage control. First thing is X-fix, then is the packing, and if packing doesn't resolve, then is the angioembolization. This is 3-in-1 protocol which we must be able to take care of it. Now, whether embolization has made a difference, this paper says no. Pelvic packing is reasonably good in this kind of a situation also. So we should not be thinking that we are not in that level. Another thing which has come is called Rebova. You can look at resuscitative endovascular balloon occlusion of the aorta. If you look at that place, there is a, here you can see the balloon will be inflated. Mostly it is done at zone 3, meaning by inferior to the renal, this thing. But it can be upper, either up. The only problem is if you block the aorta, it cannot be done for more than 30 minutes. In between the zone 2, which is between the aorta and the subdiaphragmatic around the vessels, you don't do it. But zone 3 is below the renal vessels. You can do it and you can keep it for 2 hours. During these 2 hours, you do everything else. But thereafter, it has to be taken off. Now, whether it's good or not, yes, it's very good. The only problem which I was consulting last month, I was in Austria in another pelvic course. I was asking their experience. We don't have a Rebova, but they have it. They say patients die when it is taken out, because the resuscitation amount is not that good or that effective at that stage. Now, this, even packing is compared to Rebova. What it says, packing is still equivalent to. So packing is not bad, and that all of us can do in our scenarios. That is. So in a limited resource country, which most of our countries are, what should be our protocol? This is what we have to see it out. Our protocol has to be careful about this kind of a situation where our alternatives directly come from the binder and then subsequent TXA and subsequently the blood and packing with external fixator. That is what we need to remember it out. So these challenges, retroperitoneal pelvic packing is our primary thing after the initial resuscitation is done. And if patient remains unstable, we are obviously, laparotomy is done if there is a abdominal blood and all those vessels are there. Now I'm showing you this scenario. The question is, you can't keep this binder for a longer time. What do you do afterwards? There is one option which says you can put a binder. Now you put a X-fix, or why not to put a screw, which we call as a shock screw or a dynamic screw into, and you can stabilize the pubic symphysis, which is not a very big surgery. The posterior screw is a this thing. So it can be done rapidly if you are expertise. So they say you can operate upon these cases with a limited surgery. They call it as a simple, this is damage control fixation. This is early intervention in this kind of a situation. And this is what we do. We can do it, put a screw. It's a shock screw. You just put it up and the patient can settle. Now no more issue about this thing. But whether that surgical system should be done in this situation or we should stay with the X-fix, that is the query. And this is what I'm telling it about. This can be done. They say this early total care is also safe. The only thing is, we have to be patient specific. For which patient this is safe, for which patient that is safe. And now we have this is defined, because the complications of DAC are also noted up. DAC is not always a very simple thing, because you are doing in that situation. What has been found it out? That among the two things, if any surgery is likely to take time, do fixation. Then don't do any kind of do external fixation if the surgery is likely to be if it's the definitive surgery is likely to be long, do X-fix. If you can do it up quickly, then you can do the definitive fixation, that kind of a situation. So tile B type of a pelvic fracture, early total care can be done. You can put a screw, you can do symphysis. But in tile C fractures, it's better to do external fixation. That is the kind of a concept we are there. And so our concept, final sum up is, we must understand the 4 hemorrhagic shock, hypothermia, coagulopathy, and the soft tissues. Safe definitive surgery concept now is the combination understanding of both these things. And that way we can manage it up. Now this is an international paper which I was also one of the contributors to look at the practices world over. How the world over is doing about the management of these cases. Now you look at, we have Africa, America, Europe, North America and everything. They compared it out. Obviously, as in a developing world, it can be that most of these things are not prioritized as far as ambulation is concerned, and this thing. External fixation remains the most common thing. And then embolization and Rebova are only in Europe and the North America and Oceania where this is done. Rest of the world is only staying with the basic things as we talked about. Staying with primary care, a binder, blood resuscitation, and then all permissive hypotension and everything, with the binder, X-fix, and if required, pelvic packing. And this is called damage control resuscitation. That stays the art for the today. Thank you. So I can go for the second talk here. second one.
Okay. Thank
So
you,
now I'll be
Professor
talking
Ramesh. Now,
about
for the sake
the-
of time, I think.
Oh, sorry.
Okay.
The acetabulum fractures. Now, what is about the acetabulum fractures? We get a lot of them. Now, I was working in a very big hospital in my city. There I was getting most of those trauma from the motor vehicle accidents. I have moved over to practice for last about 10 years, and now I don't see that high velocity trauma centers in a private setup. Only the cases come two ways: who can afford and who are not in that kind of an emergency, and these are the elderly patients. I get now a lot of elderly acetabulum fractures, not the big motor vehicle accidents. And what is different? In elderly patients, what the literature says, 82% will have a medical comorbidities. 33% will die very early within a year. 84% of were those where nothing was done. Now we all know fracture neck femur, we all know that they should walk early. We do hemiarthroplasty or something. But when the fracture is on the acetabulum side, we say we cannot do anything. That is the issue. If you don't do something, 79% 1 year mortality, 50% is within 90 days. And we accept it because we feel we cannot do anything. What are the fracture pattern in elderly? Yesterday there was a paper and it was said neglected. Even in elderly patients, anterior column posterior hemitransfers, and ABC fractures are the most common fracture pattern. In elderly, meaning by in an osteoporotic bone, the strength is not very high. And then we are looking that they should be out of bed, because if they are not out of bed, they will have a lot of complication now of being on the bed, and definitely the mortality will come. So what is important? We need their rehabilitation. We do talk about partial weight bearing. Will a 90 years man understand what is partial weight bearing? He may not. So you will have to do something where he is able to put weight without support and go around. That's the most important part. That's one way. What is the another problem? Another problem is that even if you do a good reduction and fixation, there could be still a collapse. And this is my own case. I did a reduction fixation of the acetabulum fracture. 6 months later, it collapses again. And eventually I had to go for a THR. And this is not only I am saying, the world literature is clear, 30 to 40% of So where you do these acetabulum fractures in elderly, due to the osteoporosis, their fixation fails and you are in a problem. And that is what is important. Then even if you do reconstruction, again, this is our paper where we have found it out. We have done the literature, whole literature, that 70% of fixation patients did not return to their normal level. So fixation in elderly does not have a very good outcome. That is to be understood. That's what we are saying. In 2010, this paper appeared. They say do combined surgery. Even in elderly, fix the fracture and do the replacement in only one go. You don't have to have a late stage. Do immediately. And they find that's a better option. And then subsequently, next 15 years, many other papers appeared supporting that evidence that even in acetabulum fracture in elderly, it's better to stabilize and do the replacement in one go. Then there is a very good study, 14 cases primarily internal fixation done and 12 cases primarily arthroplasty was done. And what they found out, single hospitalization, less total time, improved range, improved outcomes, and same baseline. So meaning by the patients were doing better if this combined surgery of fixation and replacement is done. That is the message this gave. And another paper in 2021 said the same thing. Another paper said, again, fix and replace, you'll have a good outcome. And again, prospective and retrospective study had the same event. If the acetabulum dome has got an impaction, if there is a femur head fracture, which is invariably in elderly patients, and if there is a posterior wall component, stabilize and replace, or replace if alone it can be sufficient. That is what their understanding was. Now, look at this case. Fracture neck femur, along with the wall fracture, acetabulum wall fracture, I had no issue. I just put the wall back and this replaced it immediately, one go. Elderly, 80 years old lady, superior dome involved, I put a cage, immediate replacement done. And this is what she was able to come out of the bed. Another case, relatively 3 weeks old. At that stage, patient was elderly, so we just went in one go, did the replacement. Now you can look at the quality of the bone. Even if you do a good reconstruction, you see the head indentation. So I had no issue in deciding it about. I immediately went on the stages, put a cage, did the graft area of that area in primary stage, and went for the replacement, and so that I could mobilize the patient post-operatively. That's very important thing. Now we have to take care. For a THR, adequate stability is required. Acetabulum is broken. You are looking at the stabilities. What is the stability? Ideally, we say 3-point fixation. But in this kind of a situation, up and down, front or back, if you are able to get stability, do THR. If you are not able, reconstruct that stability and do THR. That is what we understand in this situation. Look at this case. He's a 91 years. He retired as a principal of a medical college. His 2 sons are both surgeons of big name. He came with this injury. So I gave them the option. I can do immediate surgery, fix it. And so I did a dual mobility. Because these patients will have a weak muscles, we put a dual mobility cups in this kind of a situation. And this is the surgery I did. It was posteriorly. I had a good up, good down, put this dual mobility cup, and you can see it out. So this video is not working here. I'm sorry, he was walking around. Are they able to make the video move? Yeah. So there is a very interesting thing in the video which I want to show you. If the first video can work, that can show. Yes. No, I'm so sorry. This doesn't show on this area. Anyway, I can go further. Now here is the another case where I went anteriorly, stabilized with the this AIP approach, and then went posteriorly, did the again the same thing, reconstruction, and put a dual mobility cup and did it. And in the cases we did cementation and the cement did permeate it out, but we provided the stability. Another case, now you can see they had indentation, 74 years. You can't expect him to do better with the fixation. So we were clear it out. Again, 2 approaches, anteriorly with the iliofemoral, I stabilized the acetabulum, and then posteriorly I did the dual mobility cup in the back of it and could stabilize that part. Another situation, you can see it out, the kind of a combination in 71 years, the bone quality back, and you can see the impaction of that area. You can see the femur head now, the kind of indentation most of these cases will have. So immediate 2 approaches and did it. The replacement in this kind of a situation, and this way we could get over this. Another case with the dome impaction and this osteoporosis, again we did the same thing, but now I used a single approach. What is that single approach? Is a Levin approach. Meaning by you have a iliofemoral approach extended down to a Smith-Peterson approach. These days we talk about DAA. So DAA is something, Smith-Peterson, little more defined and little more minimized. But if you combine iliofemoral with DA, it is called as Levin approach, in which you open, reconstruct the acetabulum and come down and replace the acetabulum. That is what I did. This is the Levin approach, using it out. Another case, same kind of a situation with the dome impaction. Again, what I'm doing is same. I put this thing, plate fixation for the column, put our dual mobility cup, took an X-ray, and subsequently did the reconstruction down there also. So this concept of fixation and replacement has been found to be very good in this kind of a situation. Yes, we need a multi-hole cup, because you need fixation down into ischium, if posterior into the posterior column, and up into that area. The question was, we have to give, can we give him full weight bearing even with this fixation? We will say that he will use a walker and can walk out. But then we thought of another solution. If, I have told you yesterday also, that if we think that he cannot, we use now a kind of a cone cup. So we make a, because sciatic buttress always remains intact in ACPHT injury, which is most common. In that injury, we go with this kind of a reamer, put this cone cup into. This is a 3D printed cup which we have done with the local, I am an advisor to the government of India on the implant. So this is what we have made it up. We do this fixation and have this fixation. And now the patient can stand and walk with full weight bearing on the first post-op day also. And that is what we think will be easily possible for these. Another case, you can see it out. You can see this is a 76-year-old lady, head is bad, this is bad. So we primarily go for this cone cup, and now we can have that mobility over this kind of a stability of the device and fixation. Or another case you can see, again single 85 years man, again I put a cone cup and you can see the patient is walking, and this is first post-op day. The patient is walking around at that age. That is what I think a concept which you have to build it up. We make two kind of a fracture patterns. ABC fracture pattern where you will have to fix because the stability is not there. So you fix anteriorly, do a replacement. But if it is a ACPHT where the posterior hemitransverse is intact, you have a good stability posteriorly, there you go with the posterior side, put a cone cup and let the patient be ambulatory. And this has been found that their midterm outcomes are reasonably good in these cases. So these are our publications. So we feel that if there is a poor bone quality in elderly fractures, don't reconstruct and replace. Your patients will be able to walk better. And that is what was defined in this paper in 2023 also, that primary arthroplasty is the option in this kind of a situation. Again, 2023, 33 studies now. The material supports it that whenever there is a dome impaction, whenever there is a irreducible comminution, whenever there is a femur head injury, or in cases where the AVN or existing OA is there, do it. Again, 2024, same kind of a message. And again, you can see in 2025, same message that your fixation and replacement is the answer for this kind of a fixation over there. Thank you.
Okay. Okay, thank you very much, Professor. Next will be presenting with Dr. Solomon on a similar paper where Professor Sun is involved in evaluating surgical interventions and functional outcomes in pelvic non-unions, a single surgeon experience.
So good afternoon, everyone. Thanks so much for coming today. So I'm going to present on one of the complications of neglected pelvic fracture, that's pelvic non-union. Then the leading surgeon in those all cases was Professor Sen. Thank you so much for helping me to write this paper. I will be covering all these topics. So as you all know, pelvic fracture is quite common. It ranges from 3 up to 10% of all fractures. When it's acute, the treatment is a little bit easy, I mean, in a well-trained surgeon. But when it gets complicated, when it gets neglected, when it's not treated optimally, so the patient can end up with a lot of complication. So one of the rare complication, which is really debilitating, is a pelvic non-union. So there's no clear evidence that shows it's this much prevalence, but when it's occur, usually it imposes significant complications. So the patient can present with chronic pain, get disturbance, and then urogenital dysfunction. So non-union is really complex when it's occur because the anatomy is distorted because of significant disruption, significant displacement, incomplete callus, and as well as the surrounding soft tissues, the fibrous tissues are contracted, so reduction is really tough, so that make it very complex. In addition, there's no well-written literature about pelvic non-union, so you can do this way, you can do that way, so there is no clear evidence that make it even more challenging. So our paper shows it evaluates the outcomes in pelvic non-unions. So data was collected in the our study design is retrospective cohort study. So this data was collected in over 18 years, starting from 2005 up to 2023, and then the study was done in India in different hospitals. So our inclusion criteria was all patients with pelvic non-union who underwent surgery and then who have complete follow-up, whereas those patients who doesn't have full information, we exclude them. So we got total of 41 patients that was treated as a non-union for pelvic with surgery, and then seven patients were excluded because they lost from follow-up. So with a modified Harris score, this patient reported outcome where the clinical evaluation is removed. So this is the recent one. It has 3 domains: pain related to the gait as well as daily activities, and then there is also grading, excellent, good, and fair, and as well as poor. So, so surgical technique we used for pelvic hernia is more or less a multi-sequence, because a pelvic is a ring structure. So whenever there's disruption in one area, they're more likely to be disruption in the other area. So in some cases, maybe enough just single approach, but in most of patients who came late, you have to access in multi-sequence. So you either start from the defect, so you clear the area with extensive debridement, and then you will go for the other area, the front or the back, truly the contracture, and then you can back and then put autologous bone grafts, and then you have to put a stable rigid fixation. So based on this, our result shows from 34 patients, 18 were male, and then the remaining 16 were females. And then the mean post-injury was ranges from 6 months to 10 years. And then most of our patients have tile C pelvic ring injury. And then the most common site of non-union was crescent fracture dislocation, as well as sacrum fracture associated with anterior ring disruption. And then the most common indication for this patient with non-union was persistent pain, the pain that starts from the injury, and then followed by pain while they're working related to gait or pelvic instability. So the initial treatment in most of our cases was conservative treatment with bed rest and then traction. So that was the main reason for non-union. And then, but there are also significant number of patients who have poor internal fixation before it fails. So the average modified hardship score we achieved was 84%. So despite this complexity, significant amount of patients can achieve a good result when they are treated in expert hands. So this is the summary of our results. Just to inform you, so the functional status at last follow-up in all those patients, so 85% of patients was able to achieve standing with single leg, and then still same percent of patients can able to achieve sitting crossed leg without pain, which is a common traditional sitting position in India. And then unassisted ambulation was achieved in more than 67% of patients who underwent surgery for pelvic non-union. So as a conclusion, although it is really complex, so it needs extensive surgery with significant complications. So it's better to avoid neglecting pelvic to avoid this rare but debilitating complication. Just to show you some case races. So this is a 54-year-old male patient with he came 7 months from the injury, and then he really have severe pains, as you can see from the picture. So this patient have significant disruption, crescent fracture dislocation, bilaterally, plus significant disruptions of the symphysis pubis, and then he was not able to work unsupported even with walker. So this patient really needs surgery, and then this is intra pictures, and then 8 months post fixation, as you can see. So patient needs posterior as well as anterior fixation, and the patient is really comfortable. So even he can able to stand with single leg. Another patient who has came 6 months from the injury, he really had pain while he was walking because of the disruptions of the abductor mechanism. So there is non-unions of the iliac wing, iliac crus. So this patient underwent surgery. As you can see, this is the final X-ray, 2 years post-op, and then he's very comfortable. Another patient where he underwent surgery for the anterior one, though it's a little bit not enough, but they just neglect the posterior fixation. So this patient was unable to work by himself, even for standing. He needs assistance from both sides. As you can see, this patient underwent fixation from posterior with transiliac plates, dual transiliac plate, and then he was comfortable at 6 months with the picture on the right side. A similar patient with similar situation, but the anti-fixation is a little bit poor. So although they put the dual plate, they failed to achieve that one. So still patient can't make it, then he underwent surgery from the posterior as well as from anterior. So the anterior fixation was revised, and then the posterior was fixed with dual transiliac plate. Maybe with what's special with this patient is this patient, because it was really to achieve compression of the symphysis pubis. So I think the sensor he used ribs to support the plate. So these are my references. Thank you so much for your attention.
Since Professor Ramesh has to leave early, in case you have one burning question, we'll leave. Okay, Prof.
We really enjoyed Professor's talk. One quick question before you leave. We'll keep asking you on other communication means.
Always welcome.
It's on the primary acetabular THR for acetabular fractures. The implants you used, I was watching, are customized and they look expensive. So my question is, instead of using implants that we use for acetabular defects, sort of, what are the clear indications or ways to use regular, primary, simple total hip implants in such fractures instead of going to revision or customized implants?
Yes. If after the fracture, the case is delayed, there is a reasonable stability in the construct. And then if we take care, as I told yesterday, we have our own classification of acetabular defects, where if primary stability is achievable at 2 levels, not all 3 levels, if at 2 levels, our basic implants can work. The only thing is we need a multi-hole cup. That's very important because single proximal fixation cannot stabilize it. We need up and we need down. So that is essential to have a multi-hole cup. With that, most of the cases, as you saw some of the cases, I was very clear to put a posterior approach and a standard cup, multi-hole. But if there is a gross instability and you are stabilizing as a primary, now the acetabulum being broken, whatever stability you give, you can't allow them the weight bearing. So in that scenario, you do reconstruction or you use a cage. Cage is not very costly and that can supplement the stability. My only option, why I don't use cages, because for application of a cage, you strip off the gluteus muscles. And then you get the stability. Here, with the cone, I don't devascularize anything. I just stay within the joint, have the stability with the sciatic buttress, and I'm okay. So it's important to assess the stability because eventually patient has to walk. So that stability is important.
Thank you very much. On a question on Solomon's presentation, we know like the acetabular, once it's the pelvic ring fractured, and if it is long time, it's most of the time it's very difficult to bring it back. So what was your approach? Is it how you staged it, or is it front to back? What was your step of fixation, the front and the back? That's one. And the other thing, you always use plates on the back. So yes, why not SI screws?
Yes. We must understand that in a fresh fracture, the SI screw, one main important thing is reduction. And non-unions, you can't reduce by closed means. So they remain displaced. Meaning by either on the table you reduce them, which in a non-union is not easy. So you can stabilize in situ. The patient has the problem. Why do we operate non-unions? Not for reduction, not for the deformity, primarily for the pain. And it is very clear from the literature and the experience that the only indication which is most important for reoperating, because this surgery has a lot of morbidity and the complications. If pain is a disabling pain, and what we do sometimes, if there are 3-4 fractures and which cause is causing pain, you infiltrate the area of the likely and see the ability of the patient to walk. You can define, do that thing only. So once you are doing it for a pain, not for deformity, try to freshen and stabilize in situ. And in situ cannot be by screws. You have to put a plate. That is the reason we use plates for most of these cases. Yeah, front back. Now we have got the stability non-union mostly of the posterior side, not anterior side. But posterior non-union will also not settle if you do not stabilize front side, because otherwise there will be this kind of a hemipelvis. So you will have to put anterior fixation and posterior fixation. Where to start? Where, if this posterior fixation is not, anterior has gone up, now you will realign it, then fix it. But if it is here only, it is displaced, then I'll go back first and then come front first. So this all depends upon individualized to each product.
So thank you very much. Please give applause for his amazing talks. It is a big pleasure to have him. Honestly, it has been more than a year since we have been asking him. We wanted him to come for our last year event. It did not materialize because he was so busy at that time. But this year, I met him in Davos and he gave the word. He kept his promise. Honestly speaking, this is the first time he came by himself. He covered his own cost coming to this event. So, sir, it is a privilege to have you. We are really thankful. We appreciate all the positive energy, the science, and all the talks. You have been very inspirational. I hope you will give more chance to Ethiopian colleagues to come to your place and attend your fellowship. He has promised to accept more fellows, so it's also a big privilege. So I call upon our very own professor, Professor Brook, to come here and give a certificate and a small gift from Ethiopia. Okay. This is a gift from his mentee. So. This is also for his wife.
Okay, okay. So
your better half. Thank you. And this is a small gift. Okay, for you. Another one, I don't know. So this is a small tie that you will lure every time.
Thank you. Thanks a lot.
Very good. We can be very more. Thank you.
Sure. Thanks a lot. I'm really appreciative.
So thank you very much. Safe trips. So we'll continue as we are here. So we'll call upon our very own inspirational pelvic acetabulum and arthroplasty surgeon, Dr. Samuel, to give a talk. So thank you. Welcome, Sam.
Good afternoon, everyone. Again, I know it's very difficult to give a talk just before lunch, right? I'll try to make it as brief as possible. I know the title there says pelvic acetabulum because it's a big topic. I'm just going to talk to you about acetabulum, and basically I have divided it into three. Since medical school, we have passed through different phases, right? Where we have seen people being managed inoperatively on traction, and then later, some form of fixations have been tried. And early on during medical school, or even early on during residency, most of acetabulum fractures were, being diagnosed as, associated with fracture or without fracture. That was the sort of things that we were used to, like, during internship and later on. And then the management was bed rest. Either, how many of you have done lateral trochanteric traction? Anybody? Only Dr. Mellesa. Of course, here as well. So most of you, I guess, you have not seen that stage of management, right? But as a first year resident, that was one of the big surgeries that we used to do for acetabulum, I mean, right? And Mele, did you do it in Zawar or where did you do it? In Zawar. You just do local anesthesia. What screw did you use back then? Oh, shank spin. Okay. Anybody who has done it with any differently? Shank spin as well. Okay. I guess when I was first resident, we used partially threaded 6.5 screw from the lateral side. And we did that. Actually, we did get a good and reasonable concentric reduction on the head, and we keep them at least 6 weeks or sometimes even longer, right? So that's how we used to manage them. And then later on we started operative procedures. I think if I have to call a name, I would call Dr. Anderson. I think you have seen him present different approach and different things, including doing SI screw without C-arm blindly, right? So we have seen different early on interventions that he has been doing. So just to talk about operative, we'll talk something about operative preservation and replacement options, basically. So when you talk about preservation, unlike pelvis, acetabulum is not as much as life-threatening issue. So we have the life limb function, right? So we are mainly focused on the limb preservation and function, but of course, certain scenarios where the arteries might be involved, it could be an emergency, right? So vascular injury is definitely an emergency, and dislocations obviously are emergency cases, and those with incarcerated piece on the articular surface and affecting the congruency of the hip are also important emergency things to consider. And progressive neuropathy or neurologic dysfunction or palsy, especially following hip reduction. Those are the kind of emergencies that we encounter in general. Other than those, most of the acetabulum cases are really not emergency. So even though we have now the better understanding and better facility and expertise in Ethiopia, we still recommend non-operative management in a good number of cases where the roof arc is acceptable in a good range with proper oblique views. Not by moving the X-ray machine or the C-arm, but by actually moving the patient to each contralateral side and getting your proper obturator, iliac, and AP views. And they can heal as long as the key thing is the remaining part of the acetabulum. The remaining part of the acetabular dome should be well concentric to the head. So that's the main critical thing. And if you have good maintenance, that kind of fracture can be managed non-operatively. And the other thing is posterior wall fracture. Even in settings where you don't have C-arm, less than 20% of posterior wall fractures, the size of the posterior wall fragment, if it is less than 20% of the whole posterior wall piece, that can reasonably manage non-operatively, even though evidence now tells us even these injuries, you have to stress them, right? You have to do proper stressing with obturator oblique view and do a proper stress and see if the head actually remains stable. But in the setting where you don't have C-arm and limited resources, you could still consider this management. So this is the patient, the previous patient on his later follow-up. And then when you go to approach, depending on what you are used to do, you can position patients lateral or prone. In Black Lion and also in Canada, most of the patients were operated lateral. So we have carried that trend. And in our setting, mostly just because of anesthesia-related issues, and we do most of them, in under spinal anesthesia. It's very difficult to keep patients prone in those scenarios. So lateral position remains, I think, a good position. And of course, at times you might need to do also hip dislocation, like trochanteric osteotomy and anterior hip dislocation. In those scenarios, you cannot do it in a prone position, so the lateral remains important. And the caveat with that is gravity is working against you, so you need to have a good assistant, which we have plenty of residents to do, right? Abdo was complaining last, was it last week, Abdo? Is he here, Abdo? Oh, he left, okay, I don't have to talk about it then. You need to have a proper traction either through the trochanteric traction or a hook or of course, longitudinal traction to some extent also can help you in this regard. Other than that, most of the things you can work around it. So approach-wise, you can do. So ADE would be the classical Coker-Langenbeck approach, and B would be what Gibson actually originally described, and then C would be the modified Gibson. So when you do longitudinal approach, it has its own advantage. Gary, do you mostly do Coker-Langenbeck, or what about Minu? Coker-Langenbeck, you do? Yeah. So what about Ephraim when Coker-Langenbeck? So I like to do Gibson. I'm a Gibson, actually a modified Gibson approach. I guess most of you who have seen me, I like to do it like that for different reasons. It's longitudinal incision, so I basically don't touch the Gmax. And then some of the things that it can actually help you is minimize trochanteric osteotomy, especially in cases where you have a superior extension of the posterior wall. So certain kind of injuries, you could minimize osteotomy demand, and of course because of supine position post-operatively, patients sometimes might sleep on their wound, right? It's a little bit away, but it can occur, right? And then later on, depending on what approach you use, especially if you use a lateral approach, this longitudinal incision makes it easier to use the same incision for if they develop arthritis or an indication for totalip, you can still use the same incision for later on. So personally, I like to use Gibson. And then obviously, troch flip is the other thing that, especially early on, I did a lot because we didn't have C-arm back then. I did a lot of troch flip osteotomies, and also in cases where we have neglected hip dislocations, where it is easier to actually access the hip joint to remove the scar tissue. I did a lot of that, and so anybody who does a step cut, or you all do a straight cut, guys? Straight. You do step? Okay. So basically, to me, especially in neglected cases, doing the step cut, what it actually helps is it helps the trochanter piece, that's the osteotomized piece, from migrating proximally, because the abductor is tight because of the shortening. So that helps it quite a bit, and you don't need to use bigger screw. You can just safely use your 3/5 screw in a lag mode, and I think it can minimize risk of nonunion and maybe proximal migration as well. And anteriorly, you can use any of these combinations, and of course, from posterior anterior side, you can use any of these combinations for fixation. And then in terms of hardware, whatever we have, we can use. Anybody who has any form of modified or copied form of striker plates? So at least in government hospitals, that is not available. So we can actually work around most of it with just the regular standard recon plates and and semi-tubular plates in selected cases. So we don't need anything fancy, and then you can lug, the pre-drill it first, the posterior wall piece. So you come outside the articular surface, then you know where your drill bit is coming out, and then you reduce the posterior wall, and then you can provisionally put wire next to it, and then you can put your next hole. So if you do, typically I use 2.7 screw. So the drill bit for the glide hole will be 2.7 screw, and then the far cortex will be drilled by 2.4 or 2.0, whatever the drill bit you have in your set. And then marking it with cautery helps. Sometimes you drill it and you lose where the start point is, right? In any area, even in the medial malleolus, right? When you do lag screw, so cautery marking helps in minimizing where to locate it. And then, column plates basically are a bit different behaviorally. So unlike wall plates where you put them peripherally, you can keep them a little bit lateral. And this is a wall style plate where you actually see almost a tiny bit of the rim of the wall, right, posteriorly. So that's a wall style plate, and the previous one was a column style plate. And then spring plates. Does anybody have ready-made spring plates in any of your hospitals? I guess, yeah. So we all have the good traditional one-third tubular plate. And basically, you can do it preoperatively if you don't have proper cutting, like wire cutter or a big cutter. You can just use a regular, workshop cutter preoperatively and just sterilize it, right? You can do that. But if you have it, that's fine too. And make sure your indus are not past the cortex of the posterior wall. That's very critical because they can actually erode the cartilage and result in later on arthritis, right? And then, lag screw from anterior side, you can do all these sorts of fixation from the anterior. Basically, name-wise, maybe for the residents, I'll just summarize it. So this I'm sure, iliac screw. So this will be your LC2 screw. This will be your posterior column screw, and this will be your long style posterior column screw, depending on where the posterior column is exiting, right? So if the exit is basically above the spine here, then you can use this screw. So which you can safely do without C-arm. So this specific model is what I did without C-arm on a fourth generation composite pelvic bone model. So without C-arm, you can safely do this posterior column style screw. I mean, of course, it needs practice and everything. But the other one definitely needs, a C-arm to get to it. And then the other screw is this, so which we call a supraacetabular screw. And this one, the one that you see inferior to the acetabulum, is what we call infraacetabular screw. That's the classic Loternel screw. It has some good things. And then, of course, what you are used to is superior ramus or retrograde anterior column style screw. So any of these screw combinations, depending on the fracture pattern, you can use them. And this is one of the examples where only screw fixation was used for this style acetabulum fracture. And sometimes in a rare type of fractures like this, where you can only use infrapectineal plate and get them reduced, and a combination of supra and infrapectineal plate can be used. And sometimes a case like this where you see combination on the anterior column, the ideal plate for this would be your striker plate, or what Professor San was showing you his sort of version of that plate, right? So that would be the ideal thing, but this kind of plates, fractures can actually be well reduced and fixed with spring type of plate. So it's basically the alphabet, like the Ethiopian alphabet style type of plate, where you use a 7-hole one-third tubular plate and you create figure. And then you just need to have one screw supraacetabularly, and the rest, basically the supra and infrapectineal plate will buttress it and lateralize it and hold it very nicely. So Efraim wanted me to talk about the outcomes of these fractures. This is what we published with Emmanuel and Shukriya on JBGS. And on this specific paper, we included around 100 plus patients. And basically 88% of good to excellent outcome after average of 2 years, basically. And then the main outcome determinant factors we found were this. And who was yesterday present? Was it who presented yesterday? The acetabulum delayed. Was it Getaun? Getaun? He's not here. Everybody is left. Okay, so basically, the same outcome, right? Age, they also found to be a good predictor for this. And then the other thing that we noted is cartilage damage. The presence of cartilage damage has also been shown to be associated with poor outcome in our cohort, and surgical congruence. In Getch's paper yesterday, he actually presented initial surgical congruence, initial congruence, not post-operatively. So I think what he should have actually looked at should have been after reduction, after fixation, if the dome is actually congruent with the head. I think that's what should have been seen. So the congruence was associated significantly with outcome, and this is what I told you earlier. So to just give you a couple of examples what congruence significance is, I'll show you 2 examples, one with good outcome, one with poor outcome. So this is a 30 plus years old gentleman who was operated 3 weeks after comminuted fracture with dislocation. And as you can see, there is a comminution and a good piece fragment, good number of fragments are in the articular surface. So basically, we used the same thing that I told you earlier, step osteotomy. We reduced it from the back, fixed the posterior side with double column plates, basically. Both are column plates. And we know the posterior wall piece was small, so we left it. We didn't actually fix it. So what you see here, a gap, is the anterior part. The anterior part has a good, callus, soft tissue callus anteriorly, so we don't want to touch. It led me to use N plate I showed you earlier. So you see there is lack of congruence. The dome and the head are not well congruent, and it's actually medialized. So this patient went on to develop arthritis, and we actually converted this into a total hip replacement with a direct anterior approach. So these are the factors I told you. And the other thing Dr. Getaun mentioned earlier yesterday were comminuted fractures, multi-fragmented fractures. But in our cohort, we didn't find that to be associated with a poor outcome. And we also looked at time to a determining factor of outcome in different papers. But I guess it has to do with the case selections primarily on this cohorts. So this patient was operated 6 months after, and he did end up in developing some arthritis, but functionally he's now 9 years out after surgery, and he is basically still up and working a good amount of time. So this is salvage, and I'll just give you a brief idea on what we are doing on the replacement spectrum for these fractures. So basically, different classifications have been proposed to guide what can be done in acetabulum fractures, not in an acute scenario, but in a late scenario, because the acute scenario we have already discussed with bone. Basically, with the anterior as well as posterior column intact, you can use your regular cups, and you can still get away with your primary fixation. And when you have segmental bone defects, especially on your superior aspect, then you might need structural graft, what we call shelf graft, the structural graft. So or you just use a femoral headpiece, or you might also need augment, either of the two. And when the columns are intact, but the medial wall is the one that has a defect, you might use your impaction bone graft, like the protrusio type of surgery, basically. And sometimes, if the defect is quite big, you might need actually a mesh associated with it. But when you have discontinuity, you can use the cage that you saw earlier, but cage comes at an expense of lifting the abductor up, and also the outcome is not as rewarding as especially peripherally locking shells. Basically, you need to have your multi-hole cap with peripheral screws that give you at least 2 points of fixation. So those points of fixations are either superiorly into the dome, or anterior column, or you're into ischem. If you have 2 of the 3 point fixation, that is adequate fixation. So if you can get that, you don't need actually this. An ideal scenario would be 3 points of fixation, all the 3. And the only time you get those fixations is if you actually have dedicated peripheral screw holes, not with a regular multi-hole cap. You cannot get that with that. So that would be the case where you do that. And sometimes the anatomy will be completely distorted. In those scenarios, you need to use a 3D printed image. So I'll show you a couple of examples. So this is a content defect with a small defect on the medial side, but obviously the acetabulum is malunited. So this is a case where I don't know. Okay, the video works. So you see a small defect on the medial side, and the cap has obviously decreased in size because of the malunion. So this basically needed a little bigger cap size. With for the medial defect, we needed to use this impaction bone graft. So basically, you get your towel clip, your assistant can hold the head, and you can get a good amount of bone graft, morcellized bone graft from your head. And basically, whatever you have rimmed, you put this bone graft into the medial aspect of the acetabulum, and then you reverse rim by -1 or 2 from the last size of your rimmer that you have used. So this is one example that, and of course, it needs a good 2 screws. So these are both 40 screws fixing it well. So the other is under segmental defect, or the uncontained type of defect, where basically the head is migrated proximally, and this needs some sort of graft. So for this specific case, we did use shelf graft from the head, and you could also use augment like this. Sometimes the head might also be not available, right? The head might be gone, and you might not have enough bone stock from the head to do shelf graft. And there are also studies that actually showed resorption of shelf grafts. So in those, to just minimize those risks, allograft is much more dependable. I mean, augment is much more dependable than the shelf graft. But whenever you can, if you can build bone stock, you try to do that. And in discontinuity cases, that's what I told you earlier. These are the peripheral screw holes, where these screws have to be ideally positioned in such a way that you are able to get 2 or 3 points of fixation to bypass the pelvic discontinuity. The alternative will be the cap cage that we discussed. And sometimes the anatomy will be distorted, and you don't even see any acetabulum here, basically, right? So just to show you what the image looks like. Okay, I thought I had the. Can you play the video? Or? Okay, I guess it's okay. I can just show you for the sake of time. So this is basically the 3D model for this specific image. As you can see, the whole anterior column is gone, and the dome is also gone, and you don't even have enough posterior aspects of the wall. So this is a kind of case where you cannot do it in any form of either peripheral locking place or even cap cage that will not do the job. So this is a kind of case where you need customized processes. So this would be where the cap sit, right? And this is what kind of fixation you would need, at least 2 fixations, as I told you earlier. And for this one, you have 4 possible fixation modalities. And this is okay. This is a 3D image. And that's basically what we ended up in design. So when you get customized processes, this is how it comes. So you have the bone model, yeah, and you also have a model to trial it after your rimming and everything. You have a model to trial it, and then you can do your surgery, and you can give the patient this second chance to work comfortably. So the way I see it, the future is coming to basically getting a good system to minimize delays, which every of us are experiencing, and so that proper referral system is developed amongst ourselves, and we minimize inter-facility referrals, and then later on minimize all sorts of complications that are resulting from delay and neglect of these injuries. And of course, navigation and robotics are coming our way, and that's where I see ourselves going. So just to wrap up, we need to understand the personality of the fracture whenever possible in our resource limited setting. In young patients, try to repair the fracture as much as possible, and understand what actually determines the outcome. And if you have poor outcome determining factors, you don't have to indulge into repair. It's better to delay the surgery and do later on replacement. Thank you.
So thank you very much, Dr. Samuel, for your amazing presentation. So we have one more to talk to finish up. So is Dr. Suleiman around? Dr. Suleiman, I think he has sent his presentation, or he's not around. Okay. So if that is the case, then if you have any question to forward for the previous presentation, including Dr. Samuel, then you are more than welcome, Sami. You can come forward, and then we'll go for lunch. Solomon is here, even if you have additional questions. Any other?
Thank you, Sami. So in the approach you said, we do most of our patients in lateral positions because of the way we trained. That's how we're familiarized the way it is. So how easy is to put anterior column screw from in lateral position? So we face some challenges putting because getting the image is quite difficult. Do you have any tips and tricks? One question. Second question is, a posterior column, especially, is also extending to the dome area. We thought you get it, but we have fixed it, we have folded it, but we have seen one or two complications, patient presented with sometimes even to the extent of dislocations. So do you have anything, experiences or anything to say about that? Thank you.
Yeah, so one of the difficulties you see in lateral position is column and screw, obviously, right? And I think the easiest way to do it is, if you can get reasonable reduction from the back and reduce the back, flip it supine, do it retrograde. That's the easiest way to do it. If you can actually, get a reduction of the anterior column easier. But if you want to actually use your clamp from the back and to actually put your anterior column screw first before you fix the posterior column, then you actually need your proper radial cent table. That's the main issue that we have in Black Line, right? So what actually ends up happening is, in order to get your AP view, you have to put your C-arm lateral, right? And then when you want to get your obturator outlet view, you have your lateral position, and then you have to basically bring the image at an angle, and then your post gets on the way.
I think that's the most of the difficulty where we are coming. And of course, an ideal positioner would be either your peg, which is completely radiolucent, or you use beanbag. So in those scenarios, you can see 360 and it will be relatively easier. And of course, in lateral position, until you are used to it, it's good to have the bone model in the OR, and then basically position the bone model the way it is, like the way you have positioned the patient, and try to guide yourself, your C-arm and your trajectory with the bone model. Just ask one of the residents to hold it in front, and then it helps you navigate. Where am I going? Where should I go? That helps quite a bit. And when doing it from lateral position, if you have a good clamp, it doesn't have to be a long screw from the back, right? Actually, ideal screw would be perpendicular to the fracture, right? And the fracture perpendicularity doesn't lead you to the ramus, right? It actually leads you into the brim, right? So that's the other thing that you can aim. And I have done it always. I have done it from the lateral position. I have first fixed the anterior column from the retrograde, and come back, reposition and do it. And I have also done it, fix the posterior side, supine, retrograde, whichever way works, and depending on, of course, the personality of the fracture, you can do it either ways. And the second thing is transtectal posterior column. So basically, when the posterior column fracture is transtectal, right? That's what you said. When it is close to the dome, right? That's a question? You're talking about the wall, okay. So when with the wall, I think basically the moment it is on the dome is basically violating your pillar, right? So the moment your pillar, gluteal pillar is involved, I think that's the limit when you have to actually do your osteotomy. Because what actually happens whenever the posterior superior aspect of the wall is fractured is, when we see it, when we stand, the whole pressure is basically going through that part of the acetabulum, right? And most of the load that occurs on the acetabulum is actually in the posterior superior aspect of the acetabulum. And that needs a good buttressing. So for that, I think the best way to deal with it is you do your trochanteric Philip osteotomy, you have a good visualization of your gluteal pillar. You need to have 2 screws past that anterior piece or anterior fracture end. I think that is the only way to get it buttressed. And of course, try to maximize your fixation, right? If you can, put a couple of lag screws and then buttress it at the same time. Otherwise, the load that occurs there, even if the patient is non-weight bearing, is significant enough for failure ratio side.
Any other question? Okay, Gage.
Okay, thank you, Sami, for your nice presentation. So my question is, when do you consider percutaneous fixation in acetabular fractures? So is that right? Yeah, it depends on the patient parameters in general. What's your recommendation during percutaneous fixation for acetabular fracture? The second question is, there are scenarios where you apply 2 posterior column plates. So usually it's determined intraoperatively. Is there any way that you should know preoperatively so that you should be cautious and apply a 2 column plate?
So let me start from your second question. A posterior column cannot be stabilized with a single plate. That should be clear, because it cannot prevent the rotational forces. It cannot avoid rotation you cannot avoid rotation with a single plate. So the way to deal with the posterior column, if you want to stabilize it enough, is either use good lag screw and then augment it with a plate, like not on the same trajectory. You can do it, like the model I showed you earlier, the dry raise model. You put 1 lag screw and then next to it you put your column plate, or double plate. So I try to do lag screw with the plate whenever I can, but you have seen dual plates I used. When I am not able to get a good compression lagging screw, that's when I use the dual plates basically. Otherwise, a single plate will not be able to
avoid the rotational forces that occur around the posterior column. And your other question was?
The question of percutaneous screw fixation.
So if it is minimally displaced, as seen, less than a couple of millimeters displacement in terms of, a step off, and less than 3 millimeter gap, less than 2 millimeter step off. An ideal thing in acetabulum is less than 1 millimeter, right? So if it is minimal like that, then yes. In the elderly, yes, then I would consider it, even if it is significantly displaced. If I don't want to do, aggressive operative intervention, if I am not comfortable with the comorbidity of the patient, then I would consider percutaneous fixation. And in cases like this, where plate will be actually a bad actor in the pure superior type of fracture that I showed you earlier, if you put a plate on the brim or anteriorly, it will open up on the opposite side. So the best way to actually get it reduced is to go through the middle of the fragment and lag it. So in those type of fractures, even if I open it to reduce, lagging it is actually the best way to get an appropriate fixation. But in general, acetabulum is not, a kind of case where you try to deal with percutaneously. Unless, you have open fracture, older patients, comorbidity, minimal displacement, like we discussed earlier.
And the other question is, when do you do shelf grafting? What's your recommendation on weight bearing? So do you just wait until it incorporates, or is there any recommendation that?
So one thing has to be very clear here. Shelf graft should not be the main source of your hip stability. The stability of your shell should come from the remaining part of the acetabulum. So if you have seen the picture, can you bring up the image, please? The screws that go through the shell should go into the intact part of the acetabulum. It should not go through the shelf graft. Because what ends up happening is resorption can occur in a shelf graft, right? If you end up having resorption, your stability will be lost. So you should not rely on a shelf graft for primary stability. So that's the main thing. But saying that, even though you have a good screw, it's better to delay until, about 6 weeks. You can do touchdown weight bearing or delayed, depending on your comfort level of your acetabulum cap stability. Go to the previous. Go back. So you see here the screws. So the shelf graft ends here. So both these screws are going into the native. Even though it's going a little bit medial, I don't mind. I would rather screw it into the native bone instead of actually keeping it a little more horizontal and trying to go through this.
That's clear. The final question is in complex injuries, when there is a defect in multi-direction, there are, as you have said, customized implants, so that we need 3D printing. So is it available here?
Yeah, that's
can. Okay, thank you.
Okay, I have one question, one or two questions. My question is for those patients with previous or any indication for septic or other things. We have patients with girdle stone, or now they are to do total hip replacement. In those patients, what do you recommend? I mean, do you go directly with the revision implants like the Wagner stem or the S-ROMs, or is there any chance of staging it to do the soft tissue release, put on traction, then to do with the primary cup, or what's your experience and your recommendation?
So are you talking from the femoral side of it, or from the femoral aspect of
femoral,
okay.
Side.
So I know there has been some publications that actually have done staged procedure where they do release, put them on traction, and come back for later on conversion into a total hip. But I think that's an overkill for me because if you do your proper releases, sequential releases, you can actually do it at the same time. And most of the time, if the girdle stone is done later on after the bone growth has completed, the issue comes when the girdle stone has been done early on in life, right? Where the bone will not develop the way you expect it to develop. In those cases, yes, you do need a cone or some sort of diaphyseal fitting stems, right? But in other cases where the girdle stone has been done later on in life, after the bone growth has occurred, you can actually get pretty much any stem to work if the bone quality is good. If the bone quality is not good, at least try to avoid proximally coated stems. Try to get a fully coated stem. And try to, the main issue comes is calcar fractures, right? Because the proximal end of the bone will be very weak. No matter what you do, you end up in having a soft calcar side. So you might end up in having to put a prophylactic wire or cable around it that way. But if you have the cone, that's safer. You can safely put it distally. Sequential release wise, so you can start from your abduct, like capsule is the first thing. So you can do your circumferential capsular release. Any scar tissue you have to release, and then depending on your the extent, the next step would be if you are doing it from the back, or even if you are doing it from lateral position, your gluteal sling. That's another important structure that actually hinders your reduction. And then you can release your iliopsoas if it is not reducible even with that. And the last thing to do is adductor release if you get to that point for reduction. But I think if you do proper sequential release, you can get it to reduce.
Okay, thank you very much. We're a bit late for lunch, so we'll go all the way to the lunch and we'll come back early at 2:15, please. So we don't need to be late again in the evening. So let's take the time for lunch, quick lunch, and come back. Okay, make sure that you have the badge with you to get into the food court. ይሰማል? እዩ አይ ቲንክ እንጀምር ያው አርፍደን ከምንጨርስ so welcome back from lunch. So it was a big pleasure to have Professor Raju Vaidya from India throughout the past 2 days, and it was an honor to have you, sir. And he has been really keen enough, volunteer enough to come and teach here, to be with us, and he promised also to give fellowship opportunity for our young members. So we will try to coordinate through ESOT, and then hopefully we'll have a MOU signed between ESOT and Apollo, so that we would have readily somehow continuous fellowship opportunity for our members. So this is what we wish, and he is really interested to have our members as his fellows. So thank you very much again. So we have a small gift before he leaves, because he is leaving right away. I will call upon our mentor, father figure, Dr. Baharu Bazabeh, to the stage to give this small gift to him. Yes. You have something additional also. So since he loves coffee, then it wouldn't be fair if he goes without Ethiopian coffee, right? So this is the best gift Ethiopia can present. Thank you. So safe trips. Thank you very much. We hope to see you again.
Yeah.
Okay. Thank you. Thank you, boss. Thank you, Dr. Bahru. So for the next session, we are going to start in general. So everybody will be here, all inside. So we have a lot of papers back to back to be presented. As you know, we have accepted 46 papers were submitted, and we have accepted 22 for 46, 49. 49? Okay. So we had 49, 22 are accepted for presentation and journal, I mean, at least magazine publication, and the 10 for poster presentation. So as you have seen, 10 posters are already on your side. So you are invited to look on each poster. And then, so today will be the day where a lot of presentation will be made. So without further ado, I will call upon the moderators for this afternoon session. And then Professor Vaidya, and then you are excused to leave it's okay. Thank you very much again. So our moderators are yes, Dr. Baharu and Dr. Zakkan.
Thank you very much, Dr. We have in the afternoon 5 presentation. These are stopus trial internal interim analysis finding, pattern and treatment outcome of primary bone tumors in children treated at tertiary referral hospital, and novel technique of patellar tendon reconstruction and resource limited setup, design of novel anatomical plate for the fixation of scapular fracture, and neglected reducible obligatory lateral patellar dislocation, a combination of surgical technique to reduce a resource limited setup. According to the list, the first presenter going to be Dr. Mangistu, the second one Dr. Gashau Araka, and Dr. Gitaun Workene, and Mr. Habtamu Yilma, and Dr. Binyam Danyo. I think the time is already limited. Each of you, you're going to present only 8 minutes. Thank you very much, Dr. Mangistu. You can start.
Good afternoon. Thank you very much. In this session, I will present our STOPUS multi-center randomized control trial. It is a research which is multi-center in Ethiopia, and it is a randomized control trial. I am not primarily operating this patient. I am leading and organizing the research team, otherwise my main practice is spine. So I would like to thank all the researchers, surgeons who are working with this research from different centers. I will brief about it, then we'll see the material section. I will present the interim analysis result, and we will finish with conclusion. So when you say STOPUS trial, it means it is a trial which assess the effectiveness of straight arm traction compared with that of operative treatment for displaced supracondylar pediatric fracture. So in the other way, we are comparing non-operative versus operative treatment for displaced supracondylar fracture in Ethiopia. So So rationale of the study, it is, as you know, one periodic supracondylar fracture, it is really common in most of us as an orthopedic surgeon. We face these injuries. The gold standard treatment, which is close reduction and percutaneous fixation, is expensive in most of the centers due to absence of C-arm and other issues. In the contrary, there is a paradigm shift from non-operative treatment to operative treatment. While we were a resident, most of the patients were get treated by traction. But now, every patient is opt for operative treatment. So where is the balance? Which patients really need operation and the like is a research question for this study. So the research question is there any difference in patient outcome measured with patient-reported outcome measure between closed reduction, percutaneous spinning, and lateral serrator traction? The aim will be to answer these two questions. One is a patient outcome and the economic burden of the issue. This is multi-center prospective randomized control trial with 3 years study period starting from August 2024 to July 2027, which means 1 year is already elapsed. 2 years for patient recruitment, and the 3rd year will be for completing the follow-up data. 8 centers included in this trial. Of them, 6 of the centers recruiting patient actively. The center selected based on the presence of orthopedic surgeon, specifically pediatric orthopedic surgeon versus even general orthopedic surgeon, and there should have C-arm for percutaneous pinning. These are eligibility criteria: patient from 3 to 10 years with Gartland type 2B and C, displaced supracondylar fracture, presenting within 48 hours of the injury will be included. Those patients who have open fracture, vascular injury, polytrauma, having ipsilateral humerus or distal radius fracture will be excluded. In the other way, those who have flexion type and refracture at the same site will be excluded. Sample size is calculated based on the online sample size calculator, considering non-inferiority power calculation, which give us 202 patients. Considering the 10% lost follow-up, it comes 222 total of sample size. So this is a single blinded, only evaluator blinded study, which means the surgeon and the patient can't be blinded, as you know, for most surgical studies. Primary outcome is the PROMIS upper extremity score, and secondary outcome include PROMIS score, functional outcome, and economic cost. So the PROMIS score and the PROMIS upper extremity score, they are different. So this is a randomization. The randomization then with random computer generation randomization, 222 patients will be divided into 2 blocks. The type 2 will be randomized separately, since a different block than that of type 3. So both arms, there are 2 arms to be randomized in each treatment arm. So far, we published the stop trial protocol. It is registration should be done. It is done already, and we also published the protocol, the registration as well as protocol. And when you see the interim analysis, a total of 104 patients over the last 1 year from 6 centers were included. Data was entered into the STOPAS database, which is developed for this specific research, and the analysis done by SPSS version 27. So 6 months telephone interview and patient-reported outcome measure was completed by non-orthopedic surgeon evaluator in order to blind them, and it is done for 50 patients. Age in average is 7 plus or minus 2 years, and most of them, 78% are male. If you see the classification, most of our patients are type C, and the randomization, it is almost equal. It is almost equal except single patient. So this is the primary outcome measure. Early PROMIS upper extremity parent proxy score at 6 months. We see the outcome or the mean score for both arm, operative and non-operative. If you see the score, it is almost the same for operative and non-operative. And if you see the p-value and the 95 confidence interval, there is no difference at all. So which means at 6 months, whether we manage the patient operatively or non-operatively, there is no difference for displaced supracondylar fracture. So it could be a game-changing study actually, but it is too early to say that, okay? We need to recruit the whole sample size, and we need to follow for 1 year. Similarly, if you see the secondary outcome and the complication, secondary outcome is almost the same with that of the primary outcome. And when you see some of the issues like crossover, that is one of the challenge for randomized control trial. Patient can cross over from one arm to the other arm. We have 10 patients, which account 9.6. The principle of RCT, it is actually acceptable, up to 15%. But still we need to work, okay? We need to work. We have 3 patients of lost follow-up and non-functional or wrong telephone number is recorded for 5 patients, which needs great attention to accomplish that. Just to see one of the patients, he's a 3-year-old male patient, 2B, randomized to non-op. You can see the X-ray, AP and the lateral. After 5 days, we change into posterior gutter support. Then after 1 month, this is the X-ray. It has a good callus formation. And at 3 months, it is well remodeled, and the patient can do full flexion and extension comparable with that of the contralateral side. So, as a conclusion, non-operative management, it is not inferior compared to that of operative management in the early promises score. But we need to follow for their outcome, and finally, we need to report that. Otherwise, it seems like lateral solitary interaction is safe and effective treatment, either definitively or temporarily. Thank you.
The next presenter, I think, is Dr. Gaetane Gashaono.
Okay. Good afternoon, everyone, and it's a great pleasure to be here to present our research titled Patterns and Treatment Outcome of Primary Bone Tumors in Children Treated at Referral Hospital, Ethiopia. And I'm Dr. Gashao, pediatric hematologist and oncologist from the Grambasa Specialized Hospital. And it's a great pleasure to be here, and hopefully we'll have more orthopedics very much interested in with oncology after this research. So as the outline, we'll have introduction, methods, material, result, and we'll see brief discussion and conclusion and references. And as you know, malignant bone tumors account for 6% of all childhood cancers, even if hematolymphoid cancers, acute leukemia is the most common cancer, followed by brain tumors, neuroblastoma, and Wilms tumor, and malignant bone tumors, osteosarcoma, and Ewing sarcoma accounts for 6% of childhood and adolescent cancer. And this childhood and adolescent bone tumors are associated with high morbidity and mortality. And histologically, these primary malignant bone tumors are classified into osteosarcoma, Ewing sarcoma, and osteosarcoma subclassification. And the most common sites being distal femur, proximal tibia, and others. So when we are seeing the overall survival of primary malignant bone tumors, it is primarily affected by disease, the stage of the disease. It is whether localized or metastasis, or time of diagnosis and treatment response to neoadjuvant therapy. And an institutional-based cross-sectional study, especially in low and middle-income countries, including South Iran, showed that the commonest tumor is osteosarcoma, followed by Ewing sarcoma, and most of 1/3 of the patients, you can say around 27% of patients, usually have metastasis within 3 months of diagnosis, and the mean survival rate was 94 months. And in their study, the 5-year overall and event-free survival was 85 and 69.2 respectively. So, based on the estimate of childhood cancer in Ethiopia, which was published in 2015, and bone and cartilage tumor account for 7% of childhood tumors, and less than 30% of children survive in low and middle income countries. So knowing this is very important for baseline and prospective studies. So here are the objectives. The primary objective is to describe the patterns and outcome of primary malignant bone tumors treated at Blackland Specialty Hospital. Here, operational definitions is: one is overall survival. Overall survival is defined as the time from date of first diagnosis to date of last follow-up or days from any cause. And event-free survival is defined as the time duration after treatment or completion of bone tumor that the patient remain on events. And events include treatment abandonment, which is one of the major issue in children with cancer, relapse, and death. So the study was conducted at Black Lion Hospital, which is a hospitalized-based retrospective study, and we include children diagnosed with primary brain tumor from January 1, 2014 to June 30, 2022, and all children less than 8 years were diagnosed with bone tumor during the study period were included. So we use the prevalence of 7% from population study in Ethiopia, and the sample size calculated to be 100, and we get 95 patients during the study period. So a total of 95 patients meets the inclusion criteria, and the patient's median age at diagnosis was 10 years with interquartile age of 8 to 12 years, and most of the children are aged between 5 to 10 years. Even if it is stated that the median age in most of the research papers is 13 years, we see children even less than 5 years, 5 patients before under 5 years, and most of the children are 5 to 10 years with a slightly male predominance. So a total of 95 patients was included. The duration of illness from the onset symptom to visit to Kurambasa is ranged from 3 weeks to 2 years with a median duration of 5 months, and swelling was the most common presenting symptom, accounting for almost 95.8%, and the most common site were lower extremity, which accounts around more than 50%, and the average duration of delay from primary referral institute to Black Lion was almost 6 weeks, and the time to treatment or the delay for treatment after the diagnosis is 1 month. So this is a clinical presentation for children with primary malignant bone tumors at Black Lion, and we can see almost 1/3 of the patient has moderate and severe acute malnutrition. So in this study, we have included 95 children with primary malignant bone tumors, and 63, which is 66.7, were osteosarcoma, and 32 were Ewing sarcoma. From the osteosarcoma, you can see 38.1 of the patients had metastasis at the time of diagnosis, and from Ewing sarcoma, you can see near half of the patient has metastasis. So from this, the overall, at the time of diagnosis, 49.2 patients has metastasis, and the most common site of metastasis is lung, followed by bone marrow in those patients. So treatment was initiated for 68 patients, which accounted for 71.6, and the intent of treatment is curative intent for 65% of the patients, and it is only a small percentage of patients who completed treatment. And the main reason for not completing treatment is one is left against medical advice and lost to follow-up. Especially lost to follow-up is a major issue. So the Kaplan-Meier survival analysis showed the 1 year and 5 year survival of children with primary malignant tumor is 65 and 32% respectively. So as we have seen, it's the median age of diagnosis 8 to 12 years and slightly male predominance, and the duration of illness, what we call the time of diagnosis, range from 3 weeks to 2 years, and the median is 5 months, and about 49.9% present with advanced or metastatic disease, and it is around 60% who presented with localized disease. So when we say metastatic disease, it is stage 4, meaning lung, liver, and bone marrow metastasis, and most of the patients with osteosarcoma has lung metastasis. So as osteosarcoma is the commonest tumor, as we have seen in our setup, and similar to other studies, and lower extremity is the commonest site, and the survival analysis showed that the 1 year and 5 year survival rate was 65 and 32%, and just we try to see the variables. The stage of the disease is what significant association with the outcomes, and also completion of treatment is one of the factors that lead to poor outcomes. So the mean survival rate compared to other low-income countries low, especially in our setup. So as a conclusion, the study reveals that most bone tumor patients seek medical care after an average of 5 months with a range of 3 weeks to 3 years, and more than 1/3 of the patients presented with advanced or metastatic disease, and the 1 year and 5 year overall survival rates was 65 and 32, which is low compared to other studies, and lost to follow-up in treatment abandonment where common events occurred during the treatment process. So here are the references. Thank you very much. I think I hope I used my time.
Okay, thank you, Dr. Gasharaga, for your presentation. And the next speaker will be Dr. Gitana Orkna in a novel technique of patellar tendon reconstruction in resource-limited setup.
Okay. Thank you. It's a great honor and pleasure to present my case in front of the giants. So I'll present my case that's novel. This is not okay. Can you change it? So sorry for the inconvenience. So I'll present my case on novel technique of patellar tendon reconstruction and recourse in resource limited setup. As you know, even though patellar tendon injuries are rare, especially the chronic ones, the reconstruction is demanding, and especially the tendon harvesting and distal fixation is difficult. So as an introduction, we'll see the introduction, case presentation, technique discussion, results, conclusion, and reference. So introduction, as you know, patellar tendon ruptures are the third most common injuries to the extensor mechanism, but chronic patellar injuries are rare and more difficult to manage. So if it's not treated properly, the prognosis is grave, resulting in extensor weakness, knee pain. Patients result in a difficulty of extension as well as more grave complications. So we define chronic patellar tendon injury when its duration is greater than 6 weeks of presentation, and reconstruction options includes different types of autograft techniques, allografts, and in some scenarios and difficulties, there are synthetic materials to be used for reconstruction. And the problem is there is no, as it is a rare injury, there is no gold standard reconstruction method to reconstruct the patellar tendon. So my case presentation history is a 70-year-old male patient who presented with a fall-down accident of 2 weeks duration, and he was having a difficulty of waking, and then he went to traditional bone setter and massaged, and meanwhile he developed, unfortunately, septic arthritis, and it was a double injury. And on physical examinations, there was a gross knee swelling, and with clear pus pouring from the knee, and extension mechanism was lost. And then we investigated with laboratory markers. It was significantly elevated. White blood cell, CRP, and SR was elevated, and with the diagnosis of left knee septic arthritis plus patellar tendon mid-substance complete rupture. We staged this patient in 3 stages. So the first stage was proper debridement. We did intraoperatively, there was necrosis of the mid-substance of the patellar tendon, and there was extensive scars, and I tried to just remove the dead tissue, start the antibiotics, and later change it to PO for 4 weeks. Meanwhile, it was splintered with the POP, and the total duration was 6 weeks. And then we did, after eradication of the infection, the next step was the second stage, which was the definitive reconstructive surgery. And the technique is the patient was put on supine position with the figure of 4 position. As you can see, there is the right upper quadrant. There is mid-line patellar tendon injury, and we did 4 proximal incisions. So the problem we don't have, because it is a resource-limited setup, we need a closed or open tendon stripper, but we don't have that. So we need, I did 4 incisions, as you can see from the picture, this is the proximal incision, sorry, the distal incision at the insertion site of the hamstring tendon, where there is a common site of fibrovascular bands were here, and we try to incise fascia, and then we try to harvest it. As well, we just go proximal, just 8 centimeter proximally, and there is a fibrovascular band which comes from the gastroc, and we try to release that. And then it's basically I need 2 proximal incision to have adequate access to avoid premature amputation. And as you can see from the lower down picture, we did to the distal insertion site of hamstring was maintained, and the shorter was gracilis, and the longer one was the semitendinous tendon. Then we try to remove the muscle, which was the proximal insertion site. And the second was the tendon routing and fixation, which is more basically for distal fixation we need different types of suture materials for a distal fixation. But what we did was, as you can see, we try to maintain the figure of 8 position of this tendon, hamstring, as well as semitendinosus was gone from medial, sorry. As you can see here, it was rerouted in the lateral direction, and the gracilis tendon was gone from medial side to the lateral side, and then the semitendinosus was sutured to the proximal original insertion site, and we did a hole in the distal direction of a proximal tibia, which is almost 1 centimeter distal to the tibial tuberosity. And then we apply coraco stitch for the distal 2 tendons, and finally it was the semitendinosus muscle was passed through this hole and fixed with the gracilis tendon using the 8 bond number 2 sutures. And the third stage of this procedure, almost you need the accelerated phase of rehabilitation. Initial phase, especially in the first 2 weeks, we did blocking of the knee flexion using, as you see, the hinged knee brace, intermediate phase and the advanced phase. As you can see, this was the result at 4 months. He has a full flexion, as you can see from the picture, and full extension. And there is no quadriceps atrophy, there is no knee pain. Now he's a student, grade 12 student, he's running, he's functioning well. So in conclusion, you have to be aware of the potential chronic complication of patellar tendon injury. If it is chronic, it results in quadriceps atrophy, knee pain, extensor lag, knee stiffness, and instability later on osteoarthritis. And there are options of patellar tendon reconstruction and more advanced setup, but this is an option, especially where in our setup there is a tendon, where there is tendon stripper as well as distal fixation materials. And the rehabilitation is the cornerstone of treatment for successful outcome. This is my presentation. Thank you.
Okay, thank you, Dr. Gaetana. The next presenter will be Dr. Abtamu on design on novel anatomic plates for the fixation of scapular fracture.
Sorry. Thank you. My name is Abdamu Imam. I'm a biomedical engineer. Okay. I recently graduated with my PhD at the University of Cape Town, and currently I'm working at School of Biomedical Engineering. Today, I'm happy to share with you one of my research work on scapular fracture fixation, and I'll start my presentation by giving some background information. As you know, scapular fractures are mainly caused by high energy injury trauma, such as motor vehicle accidents, fall from height, and motorcycle injuries. More than 90% of these fractures are commonly treated with conservative fixation. However, if there is significant displacement and if there is significant displacement and instability, there will be surgical fixation, also known as open reduction, internal fixation. In open reduction and internal fixation, most of the fixations are performed using plate and screws, including reconstruction plates and other plates, mainly in the lateral border. Sometimes they use double plate fixation to achieve stability. In such situations, surgeons usually struggle to bend and twist intraoperatively to align the bone anatomy. So this sometimes result in implant-related complications. So the common complications related to implant failure discomfort are mainly common complications. So to avoid these drawbacks, plates are designed anatomically specific to specific anatomical regions. These are accurate anatomical plates. They also serve as a template during fracture reduction. However, they have their own limitation due to size and shape variation between different population groups. They cannot fit optimally to some population groups. As you can see, there are a significant difference between different population groups, the size and shape variations. Not only the shape and size variations, the fractures also one issue. Some of the plates does not accurately fix the different fracture variants. So the main aim of my research was to design population-specific and fracture-focused anatomical plates. To design such a plate, I start first studying the fracture pattern to start with. So I collect several fracture patterns, align them together, and study which area is more critical and the frequency of the fracture patterns. Then, after identifying the fracture patterns, I also studied the shape variations. To include the variations in specific population groups, I created a 3D model, a shape model using 41 cadaver bone models. So I created this average model. Using this average model as a reference template and the fracture region of interest as an indicator, I designed plates specific to specific anatomical regions. In this case, for lateral and medial borders. Based on the information from the fracture pattern study, I designed with two size options in each side for lateral border plate, long and short size option. Medial border plate, similarly, long and short size options. After designing the plates, the next step was to analyze the biomechanical strengths. So for that, I tried to use comparative biomechanics analysis using finite element method. What you see in the left two are fixed with the new short and long plate options. On the right, I accumulate body plate options. So by applying the same load and boundary conditions with same material property, I evaluated the response for the applied glenohumeral joint contact force. The other assessment was I evaluated the fit assessment between the bone and the plate. For that, I evaluated 3 parameters: mean bone plate distance, maximum bone plate distance, and percentage of plate surface area within 2 millimeter gap. After measuring these parameters, the fit was categorized into 3: anatomical fit, good fit, or poor fit. Anatomical fit means it doesn't require any intraoperative blade bending. That means it's perfectly fit. Good fit and poor fit, the good fit, it needs some adjustment. And the poor fit, if there is no overhang, it can be corrected, but if there is overhang, it cannot be fitted. Using this criteria, we evaluated the plate fit. As you can see, we found the result from biomechanical assessment or finite element analysis for the 2 fixation methods and the commercial implant. The distribution, as you see, maximum stress is concentrated near to the fracture site. And we compare between each implant the maximum stress. Highlighted in green is the accumulated plate and the rest is the new plate. So they have comparatively better performance to each other. The other is fit assessment. In the fit assessment, as we measured the gap between bone plate distance, based on the category of the fit, we have anatomical, good, or poor fit. Then we have also specific measurements, mean, maximum, and percentage of plate surface area. You can observe here in the new plates, since they are extracted from the average model, the mean bone plate gap distance was achieved less than 2 millimeter, except the long medial border plate. The rest we were achieved to get less than 2 millimeter distance. So the last, I try to demonstrate this one with a typical patient. So this is a typical patient body fracture fixed with the long lateral border plate and the accumulated plate. The accumulated plate in the distal region, it needs some adjustment to fit the bone. At the end, what we did was we tried to evaluate the usability of the plates. This is one typical example. On cadaver test, we create a fracture model. This is one critical fracture, which starts from the glenoid fossa and extends to the neck and medially to the lateral border. Then we use two plates, glenoid plate and medial border plate. And I think, as you can see from the middle fixation, there is accurate anatomical reduction. And we evaluate by observing the fixation. This is all about my presentation, and I think I ran out of my time. So thank you for your time. Thank you.
Okay, thank you. The next presenter will be Dr. Biniam on neglected irreducible obligatory lateral patella dislocation, a combination of surgical techniques to reduce in resource-limited setup.
Okay, thank you very much. I will present behind the team, but I wish Dr. Mammo could present this case, but unfortunately I will present the case. So my case is a neglected irreducible lateral patellar dislocation, and we used a combination of surgical techniques to reduce in our setup at Abet Hospital. So obligatory patellar dislocations are rare childhood conditions, and the knee dislocates with every flexion, and sometimes it may reduce in extension, but later it may not reduce in extension, and it might be permanent. Often in childhood it is well tolerated, but the most important factor is contracture of the lateral soft tissue. And no single procedure is effective to reduce the patella, so we have to use a combination of techniques. So our case is a 22-year-old male patient who presented with odd-looking right knee since his childhood, but 6 years back, the dislocation becomes irreducible. As you see on the video, the patella is lateral. Even the quadriceps mechanism is lateral to the knee, and the trochlear fossa is palpable. But since the patella is dislocated, the patient can fully flex, but he can't flex if the patella is centered, because there is contracture of the quadriceps mechanism. So for this patient, we send X-ray. As you see, the patella is out of the trochlear groove, laterally dislocated, and he had a poor quality MRI, but the TT distance is greater than 3 centimeters. So what our plan was to release the lateral soft tissue and to make anteromedial tubercle transfer and MPFL reconstruction. But initially we released the lateral soft tissues and the quadriceps was shortened. So we make the lengthening of the quadriceps, as you see on the image. Then we did anteromedial tibial tubercle transfer, but still the patella was not centered on the trochlear groove. Then clinically the patient has valgus deformity, so we did opening wedge distal femur osteotomy. Then we harvested semitendinosus graft, and we reconstructed the medial side using the dynamic reconstruction technique or the MQTFL reconstruction by using the semitendinosus tender. We looped it under the adductor magnus and we put it on the distal part of the quadriceps tendon. So this we call it dynamic reconstruction of the MPFL. It has the advantage, it prevents the fracture of the patella, and it avoids the use of CRM to find the shuttle point to fix the MPFL. It has comparable outcomes with MPFL reconstruction. So this was a post-operative X-ray. The knee was centered, and then we put the patient in weight bearing for 6 weeks with physio rehab range of motions. Then this was 3 months post-op X-ray with this extension and flexion, and the patella is centered. So our case presented too late, and he's symptomatic, and the patella was irreducible with both inflection and extension, and the extensor mechanism was shortened, and the tibial tubercle was too lateralized with the valgus knee. So with those combination of techniques, we reduced the patella and we improved the patient outcome. But in advanced setups, we may try trochleoplasty, but for us, we are not trained for that, and we use to prefer the combination of such techniques. So neglected, irreducible, obligatory patellar dislocations can be reduced with a combination of techniques, but the take-off messages we can't reduce with a simple one technique. Thank you very much.
Thank you very much, all presenters. Now, with restriction of time, we're going to have 5 questions and comments. And then, as I am a chair, I have 1 question to Dr. Mengistu and 4 questions I leave to the floor. I remember 27 years back in our department, in the early stage, we have treated 86 children with supracondylar fracture. That paper, it was not published, but if you have any knowledge about this paper, I think and then we had 80% of our patients, they got excellent. And then this paper was done by the first batch, a Yemeni guy. Now he's in his country. I remember that. That was why we don't have any alternative except traction, straight lateral arm traction. This paper, I think, if you look from our department, maybe it will help you, but we don't have a comparison. If you have anything to say, thank you. Now let us have questions from this. Okay. Back 1, 2. Here? No? All people? Yes. 3. Dr. The boss. Ish.
Okay, thank you.
Dr. Melissa.
Okay. My first question go to Dr. Getana. It's good to attempt it in a very remote area, resource limited to do such surgeries. It's a complex surgery, by the way. The debridement is beneficial. You do stage debridement, I think. So at the end of the procedure, somewhat, the last part of the procedure may affect your outcome. Like, for example, those multiple incisions. 4 incisions, I think, on the thigh. And you may encounter also significant dissection on the thigh. If you are interested in such surgeries, you don't need for this, you don't need the whole complex sport set like SLPCL set or something like that. You can collect somewhere a tendon striper, and that will significantly affect your surgery. And to make it questions, have you tried to minimize, like, there are ways like 2 incisions and dissect with some instruments? You can minimize it from 4 to 2 incisions. And that will also affect the outcome and rehabilitation of your patient. And when it comes exactly on the reconstruction, did you get some remnant patellar tissue, and have you incorporated to the reconstruction, or have you tried or think of augmenting that reconstruction? And exactly what did you do on the reconstruction of the tendon? What implants? I think you use screws, suture anchor. What type of implant you use? Make it detailed. So the other, it goes to Dr. Bini, I will ask you on this research as well as on, since I got the time also, I have one thing to ask on your poster. It's a good trial and it's a good courage. So when you, that is a complex, this obligatory patellar dislocation is one of the complex patellar instability or maltracking. So have you think of, or were you having a CT scan? Because the CT scan interprets most of the bony deformities, including the TTT distance. MRI will not be good for assessing that. Also tracheal dysplasia, all the criteria will be easy to pick on CT scan. And why you choose, why you don't go for standard MPFL reconstruction technique if you have the CT scan and some of the instruments? One question in this way I want to ask on your poster. You know, some membranes and the medial structures are tightly anchored. It's not like the lateral structures, the capsule, the meniscus, the semimembranous, lots of reflecting tissues, they are adherent together. Was all the structures in the medial side, including medial meniscus, the oblique popliteal ligament, and also the MCL, including MCL, and also ACL also can be associated with this injury since it is a high jerk injury. Was all these things assessed when proceeding to fix that fragment, which was you find in arthroscopic diagnostic was done, and that fragment was found in the medial compartment intraarticularly. That means the medial capsule was already gone. Definitely also meniscocapsular separation is expected. Was all those things assessed? Okay, thank you very much.
Thank you, Dr. Mallas.
Thank you. It's for Dr. Mangistu. My question is over supracondylar type 3 fractures. We know that there is sagittal and they may also have a coronal displacement. So when and how you change to POP after traction? Because the other is, when you change it to POP, do you check for a reduction of that coronal displacement? Where do you do it? Is it in the OR or in the ward? And the other is, when do you say it is conservative management is failed, and what is the plan for that one? And how long you go with the conservative management? Thank you.
Thank you. Please give to Dr. Ephraim.
So thank you very much for every one of you. I have a question for Haptamu. By the way, Haptamu is the department, a member of the department in the biomedical engineering department. So I really want to congratulate him because he was the first one to contact us for presenting his paper. So as ESOT, we are really happy to have you. So what's next? Like, what shall we expect from your trial? Like, you have designed it, and then what's next, and how can we collaborate further? I want to know what is your further plan on this paper, like.
Thank you, Dr. Efre. One question we want. Yalla. I will ask, how about the patellofemoral joint? If it is neglected for a long time, is it normal, or I don't know if you tell us about this? Thank you very much. Now, the floor goes to the presenters according.
I have one question to Dr. Gashau. In primary tumor presentation in children, you have mentioned a lot of factors which has impact in early treatment and outcome. So, can you say something related trauma and tumors in children? Is it clearer? You know, most of children has trauma regarding playing or other factors. So initially they can be treated in the nearby health centers or even in pediatricians. So they can attribute the trauma as part of accidental trauma in football or other sport activity. So they can be treated at home. But we have seen a lot of children treated in the nearby health centers or by local centers, etc., by having local massage or treatments. So, you know, when they come at hospital level, they come late. So at that time, maybe diagnosis can be late. So do you relate this?
Please. Dr. Binyam, continue.
Okay, thank you. I will start the question from Dr. Malasa. And you are right, we need CT scan to assess all the parameters of trochlear dysplasia. But this patient brings MRI, and due to the cost issue, we didn't send him for CT scan. But as you mentioned, CT scan is very important to characterize all the parameters for trochlear dysplasia. But regarding the TT distance, it is comparable with MRI and the CT scan, so we can use MRI. Why you preferred the dynamic MQTFL reconstruction rather than the standard MPFL reconstruction? As you see on the presentation, we did a lot of procedures for this patient. One thing, this one reduces the time, and also it avoids use of C-arm, and also it reduces the associated risks of putting a screw on the patellar fractures. And also study shows the functional outcome is comparable on both approaches. That's why we use the MQTFL approach. Regarding the poster, as we said, semimembranous avulsion fracture usually it is associated with meniscal tear and ligamentous injury. But for our patient, even on an MRI or diagnostic arthroscopy, the meniscus and the ligaments are intact, but the problem was on the posterior medial side, and the MCL was intact, but the capsule and the attachment sites of the semimembranous was avulsed with the bony fragment. The other question was with Dr. Baharu. Intraoperatively, the patellofemoral joint, the articular cartilage was intact, but the trochlea was dysplastic and the lateral condyle was hypoplastic. That's why in such settings, we may consider trochleoplasty if the setting is comfortable.
Okay. So two questions were raised from Dr. Mallasa. So why you choose a 4 incision so that you can minimize, at least you can make it 2 incisions. So from the outset, we don't have, I'd be happy if I got the closed or open tendon stripper. As you know, we were so remote, so it's difficult to get the stripper. That's all in a set. So we can't get it in an isolated way. So So why don't you make it 2 incisions? So basically there are 2 types of bands where the origin is at the basically at the insertion and at the origin of gastroc muscle. So these 2 distal incisions were basically to avoid premature amputation of the stump. And the 2 proximal incisions were done to avoid premature amputation as well as to have adequate length. And actually these 2 incisions are minimal, mini-invasive, wouldn't dissect so much, and it follows the fascia of the hamstrings so that we avoid complications, and there is nothing reported in the case report. There was no pain site infections following those incisions. And the second question was how to use the distal fixation. So we don't use the screws. What I did was I use a number 2 it bond stitch. I use which are applied on the same tendinosis as well as the gracilis in the form of coraco stitch. So that's the hamstring, the same tendinosis, and the gracilis tendon. Then finally, through the distal hole are approximated and sutured with a non-absorbable suture. And there was small remnant tissue of the patellar tendon, which is proximal and at the distal side. And I try to augment the hamstring tendon with adjacent remaining tendon. And that was the technique. Thank you.
Thank you very much for the suggestion from Dr. Buharu and for the question. Regarding to the point raised from Dr. Buharu, yeah, I heard, but since it was not published, we can't incorporate that idea into our literature or something else. You know, it is a scientific writing. It needs to have something published, but probably for future, when we publish the result, we can incorporate it as unpublished source for the evidence. That is possible. But I agree, since we all passed through Black Line, we know non-operative treatment was one of really most common way of treating for the supracondylar fracture. In the same way, nowadays, as I mentioned, there is a paradigm shift. That's the reason to conduct this randomized control trial, to find the balance, which patient will be ideal for non-operative and which patient will be indicated for operative management. That's the key question to address. It is a kind of, there is also a kind of eminent-based approach for this one, since there are publications from Western or other African country mentioning operative treatment will be best option for displaced supracondylar fracture. Everybody who now get and graduated and start a new center, we believe like the gold standard is percutaneous fixation after closer reduction. So we are questioning that one, and your point is supplement for our study. Regarding to the question, yes, supracondylar fracture has both plane displacements, sagittal as well as coronal. The malalignment will be there. How do you check is the question. That is really a good point. So when we change the traction to getter, it will be changed after 5 to 7 days based on the patient condition, clinical condition, not radiological. We don't believe the lateral straight arm traction will cause reduction at all. That's not the intention. The intention why we put patient on lateral arm traction is the edema need to get down and the patient should be comfortable to apply posterior getter. So how did you check the alignment will be the point again? We check it clinically, not radiologically. In the protocol, we didn't advise to take X-ray even after change of traction to posterior getter. But there is flexibility. If the surgeon wants to do, they can do. But it's not part of the study. We know that it could have any malalignment. We are not treating X-ray. We are treating the patient. And we believe after a year or 6 months, there will be remodeling. There will be remodeling. So the way we check this malalignment is clinical. That should be the point. Second question is, the third question is, where do you change? We change in the ward. That's why. One of the aim of this study was to address which one is cost effective in resource limited setup. If we take the patient to operation room, it is costly, right? We want to address that one as well. It is not only CR. Taking the patient back to OR is, we believe it is costly. And the plan is, once the kid is stable, we will give analgesia, then we will remove the traction and change into posterior gutter by flexing the elbow more than 90 degrees. That is point here. The other key question that you raise is, thank you very much for this question again, and when did you say conservative management is failed? It is the same with that of operative management. When do you say operative management is failed for you? It is the same. There is no difference. Either operative or non-operative, both could fail, right? Which means the patient will develop either complication or something else which need further intervention. It is the same for non-operative treatment. For example, actually we will follow the patient for 1 year. After 1 year or even during the follow-up, if the patient develop neurovascular injury, if the patient necessitates any type of surgery, that means the non-operative fracture end up with complication. So failure means it is part of complication. We consider like that.
Thank you very much. So for the question raised by our moderator with regarding to trauma and diagnosis delay. So in children with primary malignant bone tumor, as we have seen, the median time to diagnosis with primary malignant bone tumor is 5 months, which range from 3 weeks to 2 years, and 3 weeks to 2 years, and the median is 5 months. And this diagnosis delay, patients are passing through different delays. Those are one is parental delay, referral delay, physician delay, healthcare and health system delay, and diagnosis and treatment delay, and overall what called total diagnosis delay. And this delay primarily at parental and at physician level, especially in primary healthcare care, is common in children with primary malignant tumor or solid tumors. This is primarily because this childhood cancer is a very rare disease, and this childhood malignant bone tumors, whether osteo or Ewing sarcoma, patients or caregivers are attributing to trauma, and thus patients are getting care at the primary or at the traditional healers, and which is contributing to the diagnosis delay or the parental or at the physician's referral delay. So not only at the community level, it is also at the physician or referral there is a delay, because this childhood cancer are very rare and there need for capacity building. So thus attributing to the childhood cancers, the bone tumors, to the trauma is one of the causes leading to advanced presentation. As we have said, that 49.2%, which is a significant number of children with primary malignant tumors, are presented with advanced or stage 4 or metastatic disease to the liver, to the lung and the bone marrow. So the take-home message is that early detection and diagnosis is very crucial, because the outcome is significantly different between those localized disease and metastatic disease. So a take-home message, early detection and early diagnosis is crucial, so which will be paramount with community health assurance as well as capacity building. This capacity building will be at the patients at the different level, starting from the primary health care level. So the attributor to trauma to those pediatrics malignant bone tumor is a contributing factor for late diagnosis as well as poor outcomes. Thank you.
Okay, thank you. My question, I think, what will be my next plan? So this is the first prototype based on the South African patient population. So it has already submitted, the IP is under review. So I will try to experiment for different patient population group, like local in our case. I will try to collect data and rebuild the plates. And also these plates are initially manufactured with 3D printing. So I will look at conventional machining, and also it's also from titanium. I will also reduce the thickness and try to manufacture with stainless steel. So after the IP approval process completed, the next step will be looking for the commercialization options. That is my plan.
Thank you very much, everybody. Please give them good applause. And then we finish our session.
Thank you very much, everyone. Dr. Gasha, we need to acknowledge him. He's also not an orthopedic surgeon, a pediatrician, I think, with hematology and oncology subspecialty. Thank you for coming here. Thank you for being with us. We'll pass to our next presentations. I'm going to call on Dr. Iheyis, Dr. Mamo, and Dr. Brille to be the moderators for this session. We'll have a couple of papers to be presented, 4 papers to be presented.
Good afternoon again. These 4 presentations will be our last in our 18th ESOT annual conference, but they are not the least. We'll have 4 presentations. Dr. Said Mohammed, Dr. Hizkias, Dr. Kidana Mariam, and Dr. Brooke will present today's sessions. The first one will be a single patellar tendon for double bundle medial patellofemoral ligament reconstruction. Will be presented with by Dr. Said Mohammed. Thank you, Dr. Said.
Okay, thank you, Dr. Hayes. So welcome again. Good afternoon again, everyone. I'm Said Mohammed from Ekai 12 Hospital. And just to say a few points about the hospital where I came from. Ekai 12 Hospital is a public hospital under Addis Ababa Health Bureau. I think most of you already know it. It is the only teaching hospital under Addis Ababa Health Bureau, teaching undergraduate as well as postgraduate studies. Currently, the orthopedics, regarding in particular the orthopedic department, there are 6 surgeons, including myself. And in addition to the routine trauma care, we are already regularly performing arthroplasties, joint replacement, hip and knee in particular, as well as sports medicine surgeries. So here I'm going to present to you about, I'm going to talk about recurrent patellar dislocations. And I'm going to present a practical and cost-effective technical modification from the conventional technique. So recurrent patellar dislocation is a common scenario that you all usually, I believe most of you have noticed a lot of recurrent patellar dislocations. It usually occurs in young and active patients, and it occurs due to MPFL, or the medial patellofemoral ligament injury. So for this injury to happen, there are several risk factors, including patellar trochlear dysplasias, and a lot of structural things, including malalignments. But once the rupture occurs, usually patients tend to have recurrent dislocations along the way, because MPFL, or the medial patellofemoral ligament, is a primary restraint of lateral patellar dislocation. Once dislocation happens, patients usually start to have pain, dysfunction, and early osteoarthritis. That's one of the things that we usually worry about, because those are young patients, as mentioned, and they will have early patellofemoral osteoarthritis unless this is taken care of. So to take care of these dislocations, in the earlier days, the medial patellofemoral ligament used to be repaired, but later on, it has been shown that this repair usually fails very early, and the technical modification that has been adopted was to reconstruct the patellofemoral joint with something that, just like what you see in the picture in the right hand, a ligament, a single bundle, a ligament that stretches between the patella and the femur in the original MPFL site. But that has also been seen later on to be biomechanically unstable, and later on that modification changed into double bundle, so that 2 bundles should stabilize the patella and the femur. So this is the conventional technique, but the problem with, I wouldn't call it a problem, but the technical modification proposed to improve this is, as you can see, there are 2 tunnels in the patella to strain, because we are talking about double bundle, 2 bundles, so 2 tunnels are required in the patella. So those 2 tunnels potentially will cause increase the risk of patellar fracture. Literatures, there are conflicting literature outcomes, but some literatures in meta-analysis have shown that the risk of fracture when you adopt double bundle reconstruction, double patellar tunnel, it reaches up to 8.3% the risk of fracture. So for that, single patellar tunnel is proposed to be as a solution for that. So the rationale behind this technique, so single tunnel and double bundle, we need both, right? So we need the construction to be double bundle for the stability, and it has to be single tunnel to avoid fractures. And so this technique is developed by, it was developed in 2013 by Italian professors, but later on, the guy I mentioned at the end, Professor Ramazan Akmash, is one of my mentors during my fellowship. So they published another paper with this technical modification in 2021. So this technical modification simplifies the technique, and it has, it retains the double bundle stability while minimizing the risk of fracture. And the other point, that the modification they adopted is they use a single incision for both the patella and the femur. So I have already adopted this technique, and we are using it in our hospital in a routine basis. So our surgical technique is the regular harvesting. We harvest the hamstring in the regular technique, and as you can see in the upper picture, we divide the patellofemoral distance into thirds and go through the center, because it has to be a single incision to address both. Then we use the fluoroscopy to put our guide wire in the patella, and using that guide wire, we put our drill and pass the already prepared hamstring tendon in the regular basis. So I'm going to focus only on the technical differences, because the routine techniques are, the basic techniques are similar. So once the hamstring passes through the patellar tunnel, we flip it around the lateral side and bring it to the medial side. Then we identify our shuttle's point in the distal femur. We also use fluoroscopy usually for this. You can also use it, do it without fluoroscopy. Then we fix it in the distal femur. So this has reduced already, not only just patellar tunnels, but even the fixation is only, you need only either a single interference screw or anchor suture in the femur. You don't need fixation materials in the patella. This makes it very efficient, especially in resource-limited settings like ours. So finally, we confirm the patellofemoral integrity with arthroscopy, and we also make sure that while passing the tendon, the medial capsule is not breached. So once we confirm the stability, we fix it, and that's the whole procedure. So in conclusion, this technique offers safe, economical, and anatomic option. It avoids complications, especially is very good in resource limited settings. So this is my presentation. Thank you.
Okay. Thank you, Dr. Said. Next presenter will be Dr. Iskas. He will present on prevalence associated factor for fracture-related infection among operatively managed adult patients.
Okay, thank you. My name is Dr. Iskas. I am from Awasa University. I am an orthopedic surgeon, so I will present my thesis work, which is on prevalence of fracture-related infection and the local determinants. So these are my contents. We will see briefly about introduction, methods, materials, result, and we'll see some conclusions. So as we are an orthopedic surgeons, we all have one common things. That is, we hate fracture-related infections. Yet they are our daily routine experiences. So it is one of the feared, the hated complication after fracture fixation, and it is associated with high disability and mortality, and this problem is very common in our country, which is part of the low and middle income country. So one of the problem is the fracture related infection is underestimated in our country, and our study tries to identify the baseline fracture related infection prevalence and identify some local determinants of fracture related infection. So this is a facility-based cross-sectional study which was undertaken between July 2024 up to January 2025, and our source population was all adult fracture patients operatively managed at our hospital, and we used the 2018 fracture-related infection expert consensus definition, which states that we can diagnose fracture-related infection whenever there is purulent discharge, fistula, sinus, or wound breakdown after fracture management. And it doesn't need any additional investigation, and it doesn't depend on any anatomic location or the timing. So these are our inclusion criteria. We selected patients who are above 18 years, all patients managed for fracture, and a minimum of 1 year follow-up was taken, and all patients with complete charge were included, and patients with prior surgery at the same site with pathologic fracture, and patients who have reported and definitively diagnosed infection were excluded. So we used this simple systematic random sampling, and we have 1,250 source population. Among them, we calculated our sample size to be 230 patients, and 11 patients were excluded due to incomplete data, and so we analyzed totally 219 patients. So these are the main findings. So majority of the patients were male, and the mean age was 34.2, and surprisingly, the fracture-related infection prevalence was 24.2. So this table shows you the binary, the bivariate logistic regression, and we identified about 6-7 factors which have significant association with the fracture-related infection, and we took these factors into multivariate logistic regression, and we find 3 key determinants, one of which is nature of fracture, being open or closed, and the other is initial hemoglobin level before surgery, and the other is length of hospital stay in days. So these were identified to be local determinants. So when we compare our results from other previously done studies, fracture-related infection prevalence was significantly higher, both from similar setups as well as the other developed countries. And the 3 factors we identified were similarly identified in other studies. So as a conclusion, we have high fracture-related infection prevalence in our setup, and we identified anemia, open fracture, and prolonged hospital stays to be locally identified determinants or factors associated with higher prevalence of fracture-related infection. Thank you.
Thank you, Dr. Hizkias. The next presenter will be Dr. Kidana Mariam Abraham. The African Bone and Joint Infection Network, its genesis and goals.
Good afternoon, everyone. I'm Dr. Kidana Mariam Abraham. I'm from Ida Referral Hospital. I will be presenting on an introduction to the African Bone and Joint Infection Network. I will be presenting this on the behalf of the AGM committee. So let's start from the global burden of bone and joint infection. We know that one of the greatest enemy for an orthopedic surgeon has been infection. It has been there since the beginning of time and still continuing and actually increasing. So in some researches, infection is said to be up to 2% for elective surgeries and up to 30% for open fractures. Globally, it's said to be up to 18 million newly diagnosed fracture-related infections every year. But this is said to be very underestimated since we don't have, especially in the low-income countries, we don't have registry, we have a growing population, we are usually under diagnosing it. So we are also, on the other hand, we are not planning to totally eradicate infection because it's totally impossible. Bacteria is way, way smarter than us, way, way older than us. So we are here to decrease the burden. So can we use, we don't have guidelines, we don't have researches. Can we use the developed country guidelines and researches? Of course we can use, but there is a limitation. For this one, the African Bone Joint Infection Network was created. It is a group of individuals who have come together under the umbrella of European Bone Joint Infection Society with the support of always the EU Alliance to improve bone and joint infection care in the African continent. So these are the steering committee. This is on the 41st annual conference of European Bone Joint Infection. You can see here a great surgeons, and I'm just there because I was for 1 month fellowship for bone joint infection and limb lengthening in Basel University Hospital. So what are the goals? The goal is to have a research, to develop guidelines, education, and training. Especially the research and the guidelines. It was discussed earlier in the pediatric conference that we don't have ours, which are useful for our region, for our hospitals, for our clinical practice. So we are using those developed country guidelines and researches as a reference, but they are not ideal for ours. So after this was established, I hope every one of you remembers that 2 questions was online being distributed. The first is bone joint infection is a pressing health challenge. The second is, do we need a network to challenge this problem? So around 250 surgeons from Africa responded, almost 50% from our country, and more than 91% all agree that it's a pressing health challenge and we need a network. So currently we have 2 guideline working groups. There is a guideline working group. There is a database working group. The guideline working group is chaired by Liz, and under her there are a lot of advisors, including me. There are also plastic surgeons because we know bone joint infection is not a single department problem. This is also a database working group who are developing, it's almost being finished, developing a registry system for the whole of Africa. It's being led by Visa, supported with Nando Ferreira. Ferreira is a known limb recon and bone joint infection surgeon in South Africa. So this is a website. So under the website is under the European Bone Joint Infection Society, and you can see search about the network, the research and the data, the education and trainings, and you can also get involved. Already one guideline is developed and it was being distributed. Management of fracture-related infection in low-resource setting, both in English and in French. So this is a QR code you can scan and sign up, be part of the association. Thank you.
Okay, thank you, Dr. Kidana Mariam. So the next presenter will be Dr. Brook, operative outcome and determinants of traumatic knee arthrotomy.
Okay, thank you. My name is Dr. Brook Dubale. I am an orthopedic surgeon working at Dilla University, and I recently graduated from Asa University Comprehensive Specialized Hospital. So my talk will be on 6 months post-operative outcome and determinants of traumatic knee arthrotomy in Asa University Specialized Comprehensive Hospital. So this will be my outline of the presentation. So as you all know, traumatic knee arthrotomy is one of the underrated orthopedic injury and mostly left for junior residents during our study, as you can see, and it's potentially disabling because if it's not treated early and if not detected early and treated accordingly, they may result in potential complications which may be disabling the patient, and given the fact that it affects the younger population, it will have a high socio-economic burden. The other the other thing is with traumatic knee arthrotomy, there is significant limitation in the literature, and most of the literatures that are present are old ones in military population, and most of them focus on the diagnostic modalities rather than treatment outcome and associated factors. So our paper will we planned that our paper will answer the gap in the literature, and it will lay a groundwork for further studies and will help in developing institution-based treatment protocols. So when it comes to methods and materials, so this is an institution-based cross-sectional study conducted from June to December 2024. And we included all patients with traumatic knee arthrotomy, which visited Hawassa University Specialized Hospital from April 2021 to April 2024, 3 years period. And we got around 73 patients, which include which fulfill the inclusion and exclusion criteria as mentioned below. So when it comes to statistical workout, we did a descriptive statistical workout, including frequency, mean range, and the standard deviation for the or monovariate analysis, and we did also inferential statistics with bivariate analysis and multivariate analysis, and those variables with p-value of 0.25 were selected to undergo multivariate analysis, and the primary outcome of our study was presence of infection, and secondary outcomes were stiffness and hospital stay. So when it comes to the results, total, as I mentioned, total of 73 participants were included in this patient, and it shows male predominance, and mean age was around 27 years. And from our patients, 12.3% presented after 24 hours from injury to treatment, initiation of treatment, and majority of the mechanism in our patients was road traffic accident, given most of the transportation in our area is using motor vehicle. So 17.8% of the patients developed infection out of the 73 patients, which was a big number. And on bivariate analysis, variables that are showed relation with the primary outcome included presentation or time from injury to presentation, degree of contamination, wounds that are sutured on presentation, presence referred patients, and surprisingly, presence of comorbidity was not shown any relation with the primary outcome. As you know, comorbidities are significant risk factors for infection, but in our study, they didn't show any correlation. So we did multivariate analysis with these variables, and degree of contamination and time from injury to presentation in ours showed significant statistical relationship with our primary outcome. So in conclusion, we have relatively high rate of infection from papers or from other references. Ours is around 17.8%, and the literature, which was an old one, showed there was around 3.6% infection rate. And the risk factors that are identified are delayed presentation in grossly contaminated wound showed significant statistical relationship, and road traffic accidents were the commonest mechanism of injury. So thank you very much. These are my references. Thank you.
Thank you, Dr. Brook, and I would like to thank all the presenters for their nice presentations. If the audience have any questions, let us have your questions. One, two, three, four.
Thank you. And my question is for Dr. Skas. It is, first of all, I would like to congratulate you. It is a nice presentation. And we did the same study on fracture-related infection at 2 centers in Addis, at Black Lion Hospital and Alert Hospital. And the prevalence was 13.2%. It's like more than half compared to yours. So the most important factor we get is delayed antibiotic administration and polytrauma and non-intramedullary nail fixations. So how did you compare and what do you think is the difference? What's your suggestions? Thank you very much.
Okay, thank you all the presenters for your fantastic presentation. So I blended my question, probably my suggestion and question for Dr. Hizqias and Dr. Kidane Mara. I think it is a great initiative, but there are, as you know, surgical site infections, there are regional disparities, as you know. So did you do the baseline assessment? I think it needs a collaboration, it needs a multi-center study in as an Ethiopia. So what's your future recommendation and how do you proceed? And probably Dr. Hizqias is have done, I think Dr. Biniam, as he suggested. So you need to tackle the infection. So we need to make it a multi-center study, especially the teaching hospital should be included and have to be involved in this solution-based approach. So thank you.
Okay. In fracture-related infections, as a negative factor, you have mentioned anemia and hospital stay. Preoperative anemias are not able to correct them, or what is the special factor? And the other hospital stay is referred to those who need to stay in hospital because of managing some injuries like open fracture or other, or are there is a difficulty to operate patient frequently, and because of that they are to stay long, and this is a factor, or what is the reason?
Thank you very much for all presenters. It was an excellent presentation. My question is for Dr. Hizqias regarding the definition of fracture-related infection. You used only in one study, which is published in 2018. They put confirmatory and suggestive or criteria which needs investigation. So you use only the confirmatory criteria without any investigations. So if you don't consider those criteria without investigation, suggestive criteria, do you think the prevalence will falsely fall down, like you mentioned? Because if you consider the prevalence might be more than you report, how do you think on that?
Okay, thank you all presenters. My question goes to Dr. Said. The modification is very nice, but I want to ask a few couple of questions. Like on the femoral side, you didn't modify, I think. You just used a standard Schottler's point by your arm as you showed on the presentation. On the patellar side, do you modify anything or just you use one of the two tunnels that you supposed to use in the double bundle technique? If you are expected to brief more on what modifications to do on the patellar side, and were you happy or on the conclusion of your surgery on patellar tracking, and you use a double bundled tendon or single bundle, like a single bundle on the patellar side, single bundle on the femoral side when you modify this? You choose the Semiti or gracilis or both? These are the few questions. And also, like for example, on the traditional technique, risk of fracture, if you raise, what is your routine use of screws? Screw may be cheaper, especially metal screws. I don't expect any fracture from the switcher anchor. If fracture happens, if at all, it will be happening from the interference screws. Like the routine size, which type of, which size of diameter of screw you are using, or during your experience on fellowship? Thank you.
Well, thank you very much for Chairman. I think the presentation is excellent and informative. I want to ask the presenters who present about infection. So you know, infection, the fracture infection, it has different factors. There are patient factors, fracture patterns, and the surgeon. And the setup where you do your fixation, the duration of the surgery, all these factors are very important. So do you consider all these factors to decide that this fracture-related infection are very alarming in our setup? As an academic person, I have been involved with teaching for a long time, and we have a lot of patients. Some of this usually related to delayed surgical time and soft tissue handling, patient factor, and the surgeon's factor. So have you considered all these factors? And the other thing, you mentioned the clinical presentation was infection. So the clinical presentation after surgery, there are different clinical presentation. In addition, what you have mentioned, but microbiological or just laboratory investigations are very, very suggestive that the bone infection is running on. So how do you explain that? Thank you.
Okay, thank you. The questions were very appropriate and the suggestions are also well taken. So the first one, I will start with the operational definition. We used 2018 expert consensus criteria definition, which has both clinical and histopathological criteria. Both are equally diagnostic. So we used only the clinical criteria. So you are right, our study might have underestimated even the fracture rate. But both are equally diagnostic. We can use only the clinical criteria only for diagnosing the fracture-related infection. So that's one of our limitation of the study. The other question, how do you compare your study with the other studies done in Addis especially? So the fracture-related infection in your in the other studies you mentioned is about half as that of our finding, but our study is special in its kind because it didn't identify the patients as open or closed. We used all the patients who were managed for fracture, whether it is closed or open, whether Gustillo 3A or 3B, whatever the fracture type. If the patient has operation for whatever kind of fracture, he is or she is incorporated into the study. So that might overestimate our finding. One of the different things I find from other studies is that one. But as you mentioned, we can do multi-center studies and prospective studies to further investigate this problem. The other is the issue of anemia. We took the preoperative hemoglobin level as a risk factor, not anemia. So our finding is adjusted odds ratio is 0.87. That means a drop in 1 gram per deciliter of hemoglobin will increase the fracture risk by 13% from our finding. So it is a retrospective study. We can't intervene to correct the anemia. So we collected the chart and we studied the factors. So when we identified that factor, so the finding is it is associated with increased risk of infection, decrement in hemoglobin level. The other is length of hospital stay. Yes, we can't know for sure whether it is preoperative stay or postoperative stay because it is still now it is chart review. So it needs a prospective study to identify where is the stay. So this is one of the limitations of the study as well. But our finding suggests that every patient who stays 1 day more has 6% increased risk of fracture-related infection, as our study shows. The other question is, did you consider all other factors? Yeah, we identified about 13 independent variables. The one you mentioned, fracture type, the anatomic location, the type of implant used, all the factors were considered. So we did first binary logistic analysis and we identified about 8 factors. So we took factors with significant association with p-value of 0.25. So we took those 8 factors into multivariate logistic regression analysis, and from that analysis we find only 3 factors which were significantly associated with rate of fracture related infection. So that's our finding. The other, I think I addressed the microbiological issue with the first question, with our operational definition. Thank you.
Okay, thank you. So the basic technical modification we use is a single patellar tunnel while retaining biomechanical stability that should be achieved with the double bundle. So we retain the double bundle benefits while using a single patellar tunnel. So it is double bundle basically, but one of the technical tips we use is the way we drill our tunnel is we use it like a 15-degree cephalad direction, so that it will not be pulling the patella from a single insertion point, but it kind of the load will be kind of spread throughout the upper pole of the patella. So it will be flipped from the lateral side, and regarding the femoral side, there is no any technical modification. We use the regular fixation materials. And regarding the common screw size we use, one of your questions was that. So it depends on the diameter of the ligament. So for stable fixation, usually it has to be around 1 millimeter larger than the diameter of the ligament. But from experience, what I usually use is around 7 or 8 millimeters in the femoral side. Thank
you. Okay, thank you. So for the question which was raised by Dr. John, whether this fracture-related infection studies should be one center or multi-center, I'd like in other researches, it's better to be multi-centered. Even now, you can see the difference between studies, research done in Black Line Alert and Hawassa. So when we do multi-center studies, we will have probability to know the different variables which are factors which are risk factors for the fracture-related infection. And we can also know the different pathogens which are responsible for this infection. So the study is better to be multi-centered.
Okay, I think we're done with the question. Thank you, the presenter, and for all the questions. It was very nice interactive session, and we give a loud applause.
We are wrapping it up. እየጨረስን ነው. So I guess we will skip again the tea break and finish, and then we'll go out, have tea and network, and then we'll finish all the way. That will be fine, right? So we have one sponsor talk from Denk Pharma. if the presenter is around, right? Dr. Nakusi. He's around, right? Oh, yeah. Okay. So thank you very much for coming. So I will invite Dr. Naguse Gabrai to the floor, and he would have 15 minutes talk. And then we'll finish with the official recognition ceremony, and we'll wrap it up. Welcome. The floor is yours.
Okay. Thank you very much, and good afternoon, all. So it's a pleasure for me to be here. And my name is Dr. Nuguse Gabrai. I'm a consultant internist and hematologist at Addis University College of Health Science, Black Line Hospital. And I'm here to talk on the role of direct oral anticoagulants in the prevention of venous thromboembolism in patients undergoing major orthopedic surgery. And thank you, Denk Pharma, for sponsoring this talk. This is one of the topics in the very heart of improving patient safety and outcome of surgical patients. Okay, so why is this topic important? Like, venous thromboembolism is the third leading cause of vascular death worldwide, and most importantly, it is one of the leading cause of preventable deaths in hospitalized patients, and it is associated with significant morbidity and significant long-term complications. And its financial and health cost related implications are also very huge. So, can you assist me? Good. So more than half of patients who are hospitalized have significant increased risk of developing venous thromboembolism, and more importantly, patients undergoing major orthopedic surgery have the highest risk. And studies reported that as high as 60% of patients undergoing surgery for either knee replacement therapy or hip replacement therapy develop some form of venous thromboembolism, either symptomatic or asymptomatic DVT. And out of this, as high as 3 to 5% will develop symptomatic VTE, and appropriate implementation of VTE prophylaxis will significantly decrease this risk. So this increased risk is associated with different surgery-related and patient-related risk factors, and major orthopedic surgery will trigger almost all the classical components of the virtuous triad, forming or creating a perfect storm for the clot formation. And in addition to this, different patient-related risk factors and different pro-coagulant medical conditions will augment this risk further. And before surgery, it's better to look for these medical and patient-related risk factors for effective prevention of venous thromboembolism. So the good thing is thromboprophylaxis is very effective, and it decreases the incidence of venous thromboembolism by about 40% in high-risk surgical patients, and the incidence of symptomatic venous thromboembolism is lowered into close to 1% in patients who receive appropriate thromboprophylaxis. So the challenge is implementing or utilization of this appropriate venous thromboembolism remains a significant challenge globally, and this either interruption or inappropriate use or sub-therapeutic usage of venous thromboembolism is associated with significantly increased risk of post-operative VTE. And as you know, close to 50% of venous thromboembolism will occur post-operatively or after discharge from the hospital. So extended thromboprophylaxis is indicated where there is appropriate indication. So what options do we have? So we have lots of options for venous thromboembolism, and we have parenteral, we have oral, we have mechanical, and oral agents, the direct oral anticoagulants, including direct factor 10 inhibitors like apixaban and rivaroxaban, and direct thrombin inhibitors like dabigatran are getting favored nowadays. And this is because these agents have more predictable dose response association, and this eliminates the need of continuous monitoring, and they are at least comparable to parenteral ones, like low molecular weight heparin, in terms of preventing venous thromboembolism with relatively lower risk of bleeding, especially in case of apixaban, and they have convenience and better adherence because they are orally administered. Okay, but we must be cautious of some exceptions where these direct oral anticoagulants are not recommended, like antiphospholipid syndrome and patients with mechanical heart valves and pregnancy, lactation, and advanced organ impairments. Okay, so we have robust data which came from phase 3 controlled randomized trials, which compared the efficacy of these direct oral anticoagulants versus enoxaparin or lower molecular weight heparin, which was a standard for decades for this purpose. And the record trial, the series of these 4 trials, phase 3 controlled randomized trials comparing different doses of enoxaparin with 10 milligram per day of rivaroxaban for VTE prophylaxis in major orthopedic patients, especially undergoing hip and knee replacement therapy. And the meta-analysis of this record, the 4 record trials, demonstrated that enoxaparin is more effective than low molecular weight heparin in preventing venous thromboembolism, both total and symptomatic events with comparable risk of bleeding. We have also strong evidence for apixaban, and this came from the advanced trials from 1 to 3, and the meta-analysis of this advanced trial also demonstrated that major VT events are significantly lower with apixaban, with 2.5 milligram twice daily when compared with enoxaparin 40 milligram daily for prophylaxis in patients undergoing major hip and knee replacement therapy. Okay, so the risk of bleeding was also slightly lower in apixaban, but it was not statistically significant. So the conclusion is apixaban is an effective alternative for enoxaparin for this purpose, with a comparable or at least a comparable risk of bleeding, or in some it is associated with less risk of bleeding. So based on this robust data from controlled randomized phase 3 trials, different guidelines endorsed these direct oral anticoagulants as effective and safe options for VTE prophylaxis in patients undergoing knee and hip arthroplasty. The exception is for patients who are undergoing hip fracture surgery. The efficacy, especially the safety of this direct oral anticoagulants, was lacking because these patients were excluded from the major phase 3 trials, and the main patients who were included in the phase 3 trials were patients undergoing elective knee and hip replacement. So this is the summary of the guideline recommendation. So the duration of prophylaxis should be extended one, especially for patients undergoing hip procedures, and the recommendation is to give prophylaxis for at least 4 to 5 weeks, because the risk of post-discharge venous thromboembolism is significantly high in this group of patients. For knee, the recommended duration is 10 to 14 days. So the common question is which DUAC or which direct oral anticoagulant to select. So here we don't have direct head-to-head comparison between different direct oral anticoagulants, but we have indirect evidence from network meta-analysis in different settings, like in orthopedic patients, in atrial fibrillation, in venous thromboembolism, in cancer, and so on. And in this regard, almost all DUACs have comparable efficacy in preventing and venous thromboembolism, but the exception is apixaban is consistently demonstrated to have significantly lower risk of bleeding. So there is no difference in terms of efficacy, but safety is favors apixaban in most of the regards. So let's, like, when we see the practical, so how are we going to put this into practice? So assessment of risk of venous thromboembolism and risk of bleeding pre-operatively is very, very important, because strategy should be tailored to individual patients and should be individualized. So prophylaxis should be initiated like 6 to 12 hours post-operatively once hemostasis is secured, and short duration of prophylaxis is shown to be associated with significantly increased risk of post-discharge VT. So prophylaxis should be given for reasonable period of time depending on the type of surgery. So in patients who have contraindications for pharmacologic prophylaxis, we can use mechanical prophylaxis, and aspirin has also a role, especially in patients who has lower risk of venous thromboembolism. But in patients with major orthopedic surgery, aspirin was shown to be or found to be less effective in preventing thrombosis. So there is still unmet need in thrombotic therapy. So the available anticoagulants, including these direct oral anticoagulants, are very effective in preventing venous thromboembolism in most of the patients. But even though the absolute risk of bleeding is low, this is still significant. So the bleeding risk remains an ongoing challenge for most of the antithrombotic treatments. So with this regard, factor 11 inhibitors are on the horizon, and factor 11 has an important role in the formation of pathologic thrombosis, but its role in physiologic hemostasis is less when compared with other anticoagulants. So this means factor 11s may potentially uncouple thrombosis and hemostasis. So earlier phase trials of these factor 11 inhibitors demonstrated comparable efficacy in terms of preventing thrombosis, but they were found to be significantly better in terms of risk of bleeding. So there are lots of phase 3 studies ongoing, and in the future, hopefully, these agents will be safer options for treatment and prevention of thrombosis. So just to summarize, so assessing risk of venous thromboembolism and risk of bleeding preoperatively is very important, and the VTE prophylaxis strategy should be tailored to individual patients based on the risk, but always major orthopedic surgery carries the highest risk of in hospital and immediate post-discharge risk of developing venous thromboembolism. And as a result, most of the society guidelines recommend some form of pharmacologic thromboprophylaxis, and with this regard, direct oral anticoagulants are recommended as a very effective and safe alternative to low molecular weight heparin for VTE prophylaxis. And apixaban is associated with lower risk of bleeding among the DUACs, with comparable efficacy in preventing venous thromboembolism. And individualization is always important. to look for risk of bleeding versus to balance the risk of bleeding versus risk of thrombosis when talking about VT prophylaxis. And bleeding remains a challenge still, and novel factor 11 inhibitors hopefully may circumvent this remaining challenge of bleeding in the future. So this is all I have. Thank you very much for your attention. I'm happy to take questions.
Thank you very much, Dr. Nuguse, for briefing us on a very important and very controversial subject matter in orthopedics. So far, the pharmacological aspect has been always discussed. It has been a topic in many of our AGMs. Hopefully, the newer versions, the most updated ones and safe ones, are already available in the market. We can use, and we can do also. This is a time also to do local study and then come up with a local solution, I guess. I've known Pixaban very recently, actually, after facing some bleeding tendency from use of rivaroxaban. And we had faced, personally, we had faced 3 cases of bleeding, which might be reportable, and then we started using apixaban. That's when I've heard, but when the chance came from Denk Pharma, we allowed them. So thank you very much for the opportunity. So I guess this is a time. This is a time that now we wrap it up. I know you are a bit tired, but I think this is the end of our entertaining 2 long days. So I would definitely go with a recognition ceremony. I will call upon our seniors again. We never tired of calling our seniors because we have been on the shoulder of our seniors to reach to this level. So we recognize that. And so we call upon Professor Buruk, Dr. Baharu, and Dr. Brahanu from the EC to give on certificates for different group of people. Please come forward to the stage. We have special recognition for guest speakers. Some of the international guest speakers have left, so we have recognized them already. Some we could not because they left in a hurry, but we still have some in the venue. So as you have seen today, we have done 2 different separate sessions, one here, the other pediatric and research session on the other side. So Dr. Claude Martin was also a speaker on that aspect. So Dr. Claude Martin, so ESOT recognize you refer to be a guest speaker. Thank you very much. Dr. Jim Harrison, as you know, Jim is our really friend. He is African Director of EO Alliance, so he was a guest speaker too. Thank you, Jim. We have, I don't know, I haven't seen the Alliance team from our region. We had our panel discussion and the guest speakers were Dr. Joseph Mwanga, Cloud will take for him. Okay. Okay. And also Dominic, Conado, and Kana Walter. Okay. Anyways, thank you very much. ESOT really greatly appreciates their presence into our. This is the first time we had many regional speakers also into our conference. And unfortunately, Professor Scott Nelson had to leave in hurry because he was having a trip to, I guess, to Rwanda. So he left, so we could not. So Teddy, I guess, would take his. So Professor Scott Nelson. Okay. Sponsor. Paper. Okay. So this is a time also we really recognize the papers, as I told you already. ከመጡልን 49 ፔፐሮች ብዙ ኔጎሽዬሽን ብዙ ሪቪዊንግ ፕሮሰስ ውስጥ ማለፍ ነበረበት and we had to undergo objective parameter to assess which one to reject. So we had to reject 14 papers, unfortunately, and we accepted 22 papers for presentation and journal, at least magazine publication, and 10 posters, as you have seen. So of all this, all of the presenters will get official certificate from ESOT. It is prepared for just for the sake of time. I will not call all of them, but the best original article presenter and the best poster and the best case presenter will be recognized here. Otherwise, all the presenters will be given certificate. And for this specific purpose, just this year, we have independent evaluators. We have been talking about having independent evaluator over the years, and this year we made it successful. And there were now, I guess, 10 evaluator teams evaluating independently each poster, each abstract presentation and case presentation. Upon their, I don't even know yet, upon their evaluation, the best presenter, the best paper presentation, best abstract presentation award, it just arrived. So it was Dr. Mengistu. He presented a lot, so which paper, I don't know. It has to be the stoppers, I don't know. Okay. Thank you very much. Congratulations, Dr. Mengistu and the team for your recognition. And Best Case Report Presentation Award, Dr. Habtamu, Imam, M. Imam. So that means Dr. Habtamu from Biomedical. Okay. Best Poster Presentation Award presented by ESOT to Dr. Isaac Barihun. Zarihun or Barihun? Dr. Isaac Barihun. Who is taking? Okay, Barakat, his resident is here. So thank you very much, our seniors. You can sit down. Thank you. Okay. So I would like to call on all EC members, Teddy, Dr. Mangistu, Dr. Brahano, Dr. Berha, Dr. Orko. So while the EC member is compiling up, so the paper selection evaluation team were including Dr. Masfin Utsub, the chairperson, Dr. Bakalu, Dr. Bererleo, Dr. Worku, Dr. Tirus, Dr. Sintayo, Dr. Malasa, Dr. Brahano, Dr. Admasu, and Dr. Asana. So please give a round of applause for this evaluators team. They have done actually amazing work. So thank you. Really, it's amazing. This is the kind of trend that we shall keep on, so that everybody would be at least fairly treated, right? Teddy ድገመው ስማቸውን ብሎኛል። Dr. Masfin, he was the chairperson, Dr. Bakalu, Dr. Berleo, Dr. Worku, Dr. Teros, Dr. Sintayo, Dr. Mellesa, Dr. Brahanu, Dr. Admasu, እና Dr. አሳና 10 ሰዎች ናቸው ኦብጀክቲቭ ፓራሜትር ተጠቅመው ኢቫሉዌሽን ሲሰሩ የነበሩት the whole time they were 3. Each paper and each poster, each case presentation was evaluated by 3 independent evaluators. So the average of all the 3 score was taken into consideration. So that means at least we can say this might not be okay the best, but at least the fair objective parameter, right? This is just to encourage for the coming abstract submissions, so that everybody knows you are going to be treated fairly. And so here we recognize our sponsors. Without them, honestly, this wouldn't have been possible. So we are really grateful to have all these sponsors of our society to run this kind of very bright and entertaining conference. So I'll call upon them based on their sponsorship tier. So the first one, the major tier sponsor is AO Alliance. We are really indebted to AO Alliance. We hope we'll continue to do so. So AO Alliance, who is going to take it? The other major tier sponsor is Addis Ortho Chunli. So we are happy that our very own son of the society, along with its international partner, has collaborated to be the major partner of the society. So Addis Ortho Chunli, Dr. Samuel Ailu, or his team. ካልሰሙ ከኋላ እሺ ሲመጡ መቀበል ይችላሉ። የአዘር ዩዥዋል ፓርትነር ኦፍ ኦል ታይም ብዙ ስንጨቃጨቅ ስለነበረ ሄኖክ ሰልችቶት መጨረሻ ላይ ያው ኢሶት ከሁሉም ፕሮፌሽናል ሶሳይቲዎች በልጠዋል አለኝ መጨረሻ ላይ እና ምክንያቱም ብዙ ነው የጠየቅነው ስለሚገባ እና በስንት ማግባባት ዘንድሮም በዛው ልክ ነው የቀጠሉት። ድሮጋ ሜሪል ቲም The other platinum sponsor is Shega Merrill team. Merrill is collaborating with 2 local partners, one with Droga, one with Shega. So Merrill Shega team. Okay, they can come anytime when they're available. And the gold tier sponsor, which you have heard with the sponsor talk, is Denk Pharma. We have multiple silver tier sponsors, so I will call upon based on their order. Mega We Care. Mega We Care. ስፖንሰሮች ትንሽ ወደፊት ከመጣችሁ መንገዱን ማሳጠር ትችላላችሁ ስትጠሩ። You can come forward. ባሮ ፋርማሲውቲካልስ ባሮ ፈጠን እያላችሁ መምጣት ብትችሉ ደስ ይለኛል። ብሩክ የለም? እሺ ታቡክ ፋርማሲውቲካልስ ታቡክ አፍሪሜድ ኢምፖርተር ኤንድ ዲስትሪቢዩተር አፍሪሜድ ኦኬ Bishao General Trading. Team Bishao. Okay. So our major sponsor has come. So I will call upon Addis Ortho Chulni. Bishao General Trading. Bilim Pharmaceuticals. Bilim Pharmaceuticals. Pioneer Diagnostic Center. Pioneer. Team Pioneer. Ethiopian Hospital. Ethiopian. Yes. Washington Medical Center. አለከማችሁማ ማጨብጨቡም ብዬ ነው። Thank you. ውዳሴ ዳያግኖስቲክ ሴንተር Dream Orthopedics.
Work with staff. No.
Jordanos Hospital and Washa Import. ሰው ካለ አፖሎ ሆስፒታልስ አፖሎ አይሲኤምሲ አላ and Life Made Ortho, Life Made Import. Lincoln Pharma, Lincoln Pharma. ምናልባት ድጋሚ የመጣ ሰው ካለ እድል ለመስጠት ያህል አፖሎ ካሉ ዮርዳኖስ ዋሻ ኢምፖርት፣ ፓዮኒር ዲያግኖስቲክ ሴንተር፣ ቢሊን ፋርማሲውቲካልስ፣ ቢሻው ጀነራል ትሬዲንግ፣ ታቡክ ፋርማሲውቲካልስ፣ ባሮ ፋርማሲውቲካልስ፣ ሸጋ ሜሪል ካላችሁ ማምጣት ትችላላችሁ። ከሌሉ ወደ ቀጣይ ሪኮግኒሽን እንሄዳለን። በዚህ ሁሉ ሂደት ውስጥ በጣም ብዙ ያገዙን ይሄ እንዲሳካ እውነት ለመናገር በእኛ አቅም ብቻ የሚሆን አይደለም። ያያችሁት ነው፣ እየሰፋ ነው፣ ቁጥራችንም ብዙ ነው፣ ኦርጋናይዜሽኑም ብዙ ይጠይቃልና this year we have tried to devise a little bit different way so ለብዙ ወራት አብረውን የተሯሯጡ ኦርጋናይዝ በማድረግ ይሄ ቤት እንዲደመቅ ብሎ እንድናሳልፍ ከቦታ መረጣ፣ ስፖንሰር ማፈላለግ፣ መደወል፣ መጨቃጨቅ፣ ዲል ማድረግ ለኮንፈረንሱ የሚያስፈልጉትን በማሟላት በትልቁ አብረው ነው የሰሩት። በጣም ለኔ በግሌ በጣም ታዛዦቹ ነው ሲሰሩ አብረን የከረምነውን ሰዎች አፕሪሼት ማድረግ እንፈልጋለን። our course organizer Malak Events and Consultancy. So we really appreciate Malak and your team for the effort. Please give her a warm round of applause. ከዛ ውጭ ይሄ እዚህ ያለንበትን ቦታ እንድናገኝ እና በተለያየ መንገድ ደግሞ ዲሉን ቀለል በማድረግ ሴኩሪቲውን በጣም የተሻለ እንዲሆን በማድረግ የተባበሩን የአድዋ ቪክቶሪ ሜሞሪያል ሙዚየም አስተባባሪዎችን ማመስገን እንፈልጋለን። ብዙ ጥያቄዎቻችንን ፎርዋርድ ስናደርግ ፖዚቲቭሊ ፕሮፌሽናል ሶሳይቲዎች ናቸው በሚል ተቀብለውን አስተናግደውናል። ካሉ ሪኮግኒሽን ሰርቲፊኬት ቢወስዱ ደስ ይለኛል። አድዋ ቪክቶሪ ሜሞሪያል ሙዚየም ፕሬዚዳንት ያው ነው it's okay. ከዛ ውጭ የተዘጋጁ ለፕሬዘንተሮች ለሁሉም ኦሪጂናል አርቲክልም ኬዝ ፕሬዘንቴሽንም ፖስተር ፕሬዘንት ላደረጋችሁት በሙሉ ሰርቲፊኬት ስለተዘጋጀ ስማችሁን እየጠራን መድረክ ላይ ያላወጣናችሁ ለጀስት ፎር ዘ ሴክ ኦፍ ታይም ነው ፎር ሶሪ ሁላችሁም ፔፐሮቻችሁ ሰርቲፊኬታችሁን የምትወስዱ ይሆናል። በድጋሚ ስፖንሰሮቻችንን እጅግ አድርገን እናመሰግናለን። እንደዚህ አይነት መሰል ኢቨንት እንድናዘጋጅ ስላገዛችሁን በቀጣይም አብረናችሁ እንደምንሰራ ተስፋ እናደርጋለን። አይ አም ሹር ከዚህ በበለጠ ስፖንሰር ታደርጋላችሁ ብለን ነው የምናስበው። ኦኬ ሪቪውርስ ቲምም እንደዛው ሆነስትሊ እያንዳንዱን ፔፐር ቅድም የጠራኋቸው ስሞች የኢቫሉዌተርስ ናቸው። ሪቪውር ፔፐር ሪቪው በማድረግ ፕሮሰስ ውስጥ ያገዙ በጣም ብዙ ሰዎች አሉ። የመጡትን ፔፐሮች በሙሉ እያንዳንዱ ሰው ስኮር አድርጎ ከአንድም በሶስት ሰው ስኮር ተደርጎ ክሊኒካል ብቻም ሳይሆን ፐብሊክ ሄልዝ ኤክስፐርት ሪሰርቸር ማለት ነው አብሮ ሪቪው በማድረግ ሂደት ውስጥ ነበሩ። ሶዛት የሚቀርቡት እንኳን ፊልተር አውድ ሲሆን ኦብጀክቲቭ የሆነ ፓራሜትር እንዲሆን በሚል ነውና ሪቪው ያደረጋችሁም በዚህ 2 ቀንም ደግሞ ኢቫሉዌት ያደረጋችሁት ቲም በሙሉ ሰርቲፊኬት ያላችሁ መሆኑን ለመግለጽ ወዳለሁ። በዚሁ ግን አንዴ ለኢቫሉዌተር ቲሙም ለሪቪውር ቲሙም ሞቅ ያለ ጭብጨባ ብታቀርቡልኝ ደስ ይለኛል። በእኛ በኩል ሁላችሁንም ለተሳትፏችሁ በእውነት በጣም ደስ ብሎናል። ብዙ ሰዎች ከተለያየ ከክፍለ ሀገር መምጣት ችለዋል። ብዙ ሬዚደንቶች ማሳተፍ ችለናል። እኛ ከታች የነበሩት ሰዎች ሲያሳትፉን ፕሮፍ ቤታችን እንዲሆን እንዲሰማን ስላደረጉን ነው። ሁላችንም በቅብብሎሽ እዚህ ድረስ የመጣ ነው። አሁንም እዚህ ብቻ ያሉት ሳይሆን ክፍለ ሀገር ያሉትም ተመሳሳይ ፊሊንግ እንዲሰማቸው ለማሳተፍ ተሞክሯል። ካልተሳሳትኩ ወደ 35 ሰው ሆቴል አኮሞዴሽንም ስፖንሰር አድርገን ማምጣት ችለናል። ከዚህም በላይ ቢመጡ ሁሉም ሰው ቢመጣና ቢሳተፍ ደስታችን ነው። ግን ለመጣችሁት እጅግ አድርገን እናመሰግናለን። አንዳንድ ቦታዎች ስፖንሰር ራሳቸው ሲኒየሮች ሆነው ነው ሬዚደንቶቻቸውን ያመጡት እና ለዚህ ተሳትፏችሁ ከዚህም ከክፍለ ሀገርም ለነበረው ተሳትፎ እጅግ አድርገን እናመሰግናለን። አይ ቲንክ ለሁላችሁም ሞቅ ያለ ያን ብቻ አይደለም። ዘንድሮ በቮለንቲሮች ታግዘን ነው ስንሰራ የነበረው። ወደ 10 ቮለንቲር ግሩፖች ሜዲካል ስቱደንቶች ማለት ነው ቮለንቲር አድርገው አብረውን ቆይተዋል። ቮለንቲር ግሩፖቹም ሰርቲፊኬት አላችሁ ኦፊሻሊ የምትወስዱ ይሆናል። ለነበራችሁ የነቃ ተሳትፎ ግን እጅግ አድርጌ በጣም አድርጌ በኢሶት ስም እናመሰግናለን። ይሄ ተሳትፏችሁ ወደፊት ቀጥሎ ኦርቶፔዲክ ፊልድ ውስጥ የምትገቡ እንድትሆኑ ምኞታችን ነው። ይሄን ካልኩኝ ምናልባት ሁላችሁንም እጅግ በጣም አድርገን እናመሰግናለን። እንወዳችኋለን። በቀጣይ ደግሞ የምንገናኝ ይሆናል። ኔክስት ይር ፕሮሚሲንግ የምንገባላችሁ እንደሆኑ ፕሮትራክትድ ይሆን አይደለም። በአጭሩ በቅርብ ጊዜ ቀጣዩን ኤጂኤም ዴት የምናሳውቅ ይሆናል። አትሊስት 10 ወር በፊት ቀድማችሁ አውቃችሁ ተዘጋጅታችሁበት ብዙ የተሻሉ ገስቶችን ጠርተን ደመቅ ያለ ፕሮግራም እንድናሳልፍ ለማድረግ እንሞክራለን። ከሌሎች ፕሮግራሞች ጋር በማይጋጭ መልኩ ማለት ነው። ይሄንን ለማለት ነው የምወደው። ያው ፕሮፍ
ለምን ሮጬ እንደመጣው ይገባቸዋል። ለሰው ሁሉ አስጨበጨቡ፣ አመሰገኑ። እነሱንስ ማን? ይሄ ኤክስኪዩቲቭ ኮሚቴ በጣም ለፍቷል። ስራው ይናገራል፣ ስራው ይመሰክራል። ፖስት ኦፕ ኤክስሬውን ስታዩ ሶ ናይስ ዌል ፊክስድ ፋንታስቲክ ኤክስሬ። ስለዚህ ያንዳንዳቸው ጆርናል በማዘጋጀት ይሄ መሬት ላይ ምናምን አንድ ጆርናል ወድቆ እንዳናይ በልፋት ነው የተዘጋ። አንዱ ስንት ነው? 395 ብር አንዱ። ከለር ፕሪንት አብዷል። ስለዚህ በደንብ ቁጭ አርጉት፣ አይዝረክረክ። ዲፓርትመንቶች ይላክላቸዋል። እንግዳ ሲመጣ ስጡ። ሴል ኢሶት ሌጋሲ ይሄን በጣም በተሻለ መልክ ያን ሁሉ የሬዚደንት ስም የኮንሰልታንት ስም ስፔሊንግ አያት ተሳሳተ፣ ባቼ ተሳሳተ፣ ከባቼ ያስወጣኸኝ ይሄን ሁሉ ኮሜንት ወስደው በዚህ ዓመተ ምህረት ነው የተመረቅኩት ውጭ ሀገር ቢሆንም በቅንፍ አስገባ ይሄ ሁሉ ኮሜንት እየወሰዱ የለፉ ቢኒያም ለምን ቤዛና ቢኒ የሉም እዚህ እነሱንም ታሳቢ ያርጋችሁ። ቢኒያምና ቤዛ ይሄ ሁሉ ኢሲ ኤፍሬም 6 ዙም ነው የሚከፍተው። አንዱን ወጥሮን እኛን ስለ ጆርናል ስናወራ እሱ ስለ ብር ያወራል። ይሄ ብዙ ሚሊዮን የወጣበት ኮንፈረንስ ነው። ቁጥር አልተናገሩም። በጣም ውድ ነው። ሁሉ ነገር ይናገራል። ኪናችን ምና ሁሉ ዘንጠን በቃ ኤቭሪቲንግ ዋስ ፋንታስቲክ። ከዚህ ሁሉ ጀርባ ዴዲኬትድ ኢሲ ግሩፕ ነበር። እኔ ይቅርታ አድርጉልኝና የገባሁት መድረኩ ላይ ዘልዬ ለነሱም ቴንኪው እንድንላቸው ከፕሬዝዳንቱ እስከ ሁላቸው በአንድ ላይ እነ ሰይድ ሁላችሁ ሌሎችም መልቲ ታክስ ተሰጥቶ ሬዚደንት ያልተሰጠው ስራ የለም። ለነዚህ ሁሉ ከፍተኛ ጭብጨባ የምስጋና ጭብጨባ እንድናቀርብ ለማድረግ ነው። ቴንኪው ኤፍዬ ብሌስ ዩ ተባረክ። ሁላችሁም በርቱ። በጉባኤው ስም አመስግኛለሁ፣ መርቅ ያለው ባህሩ ጨምር የይስ ጨምሩ። ቴንኪው
እሺ የተወሰነ ታይም ያለ ይመስለኛል። ባይዞይ ቱሩ ቃል የገባነው ቱር አለ። ቱር ማድረግ የሚፈልግ ሰው አድዋ 00 ፎቶ የተነሳንባት አደባባይ ላይ ከተገኛችሁ ቱር ሊያስደርጉ የቤቱ ሰዎች ይጠብቁናል። ቲብሬክ እያደረግን ቱር ማድረግ እንችላለን። አጋጣሚውን ተጠቅመው ማየት ይቻላል። ምናልባት ሲኒየሮቻችን ፕሮፍ እንዳለው መናገር የሚፈልጉት ካለ ወደዛ ነው ልክ
ከተዘጋ በኋላ መናገር ከባድ ነው፣ ግን በጣም ደስ የሚል ፕሮግራም ነው ያየ ነው። በሚቀጥለው አመት ደግሞ ከዚህ የተለየ ከዚህ ከአዲስ አበባ ወጣም ብለን ትልቅ ዝግጅት እንደሚያደርጉልን ተማመናለሁ። ይሄ ለመናገር ነው።
እሺ አይገስ በዚሁ መዝጋት እንችላለን። ስለነበረን ቆይታ በአጠቃላይ ሁላችሁንም እጅግ አድርገን እናመሰግናለን። ቴንክ ዩ ቬሪ ማች። ኔትወርክ እናድርግ፣ ኢንተራክት ማድረግ ይቻላል። ቲብሬክ ኦልሬዲ ዝግጁ ነው። እንዳልኩትም ጉብኝትም አለ። ፕሮግራሙ ኦፊሻሊ ተዘግቷል። እናመሰግናለን።
Thank you.